Hello, and welcome to our very first Norton Educational Series 2-day meeting. This is to commemorate our 30th anniversary, and we are glad that you are able to join us today. With me today, I have three very distinguished members of the doctors in GI, especially functional GI motility disorders. My co-hosts for the next 2 days. We have John Pandolfino, who is a professor of medicine at Northwestern University in Chicago. He is an expert in the area of the upper GI tract and is going to be with us today to help moderate the sessions and answer your questions. To my left, I've got Dr. Bill Chey, a very familiar face for those of you that do a lot with IFFGD. He is a member of the IFFGD Board of Directors and also chair of our research committee. He is been our program chair for this event and is, as most of you know, an expert in the GI tract. He does a lot of research in the area of functional GI disorders, food and diet as related to GI disorders, and also will be doing a session on H. pylori later in the program. And then all the way to our left is Dr. Lin Chang from UCLA in California. Dr. Chang is also an expert in functional GI motility disorders, specifically in the lower bowel with irritable bowel syndrome, which she'll be giving a talk on later today. You'll get to know these wonderful co-hosts throughout the weekend, and please send in your questions in the chat if you have any as we go along over the next few days. But before we get started, I want to just again welcome you. Over the next 2 days, we will be having many talks through the entire GI tract. And so please make sure that you pay attention all day long to the program agenda and participate throughout the next 2 days. Also want to say a special thank you to our program supporters. This event would not have been possible without the general support from AbbVie, Ironwood, and Takeda. And thanks to them, we were able to put in a great lineup of speakers, and we will get started very soon. But we do want to let you know that not only these three program supporters, but also other exhibitors and patient resource organizations are available in our 2 exhibit halls. Those exhibit halls are available to you online throughout the programming, even outside of our agenda, so in the evenings, and then they will be available moving forward on the website. So please make sure that you check those out. In our patient education resources page, we do have several other organizations such as the Oli Foundation and other nonprofit patient resources that can help you in your journey with your gastrointestinal illness. Also want to let you know that we will be taking multiple breaks throughout the day. But if you happen to miss a session, they will all be available on YouTube and on the website moving forward. So feel free to take breaks as needed and then just come back when you can. So before we get started today, we are going to talk a lot about functional GI motility disorders. There's also some rare disorders that we'll be discussing. But John, can you talk a little bit about what the difference is between functional GI and motility? Because I know that gets confusing sometimes.
Yeah, it's a great question. And I think it's actually a pretty difficult question. And I think if you asked many gastroenterologists, they'd actually have a hard time explaining the difference. And really what we like to think about when we think about the distinction between the motility disorders and functional disorders are there motility problems that are pretty overt. The motility problems that actually cause retention of liquid in the esophagus or retention of liquid in the stomach, maybe even have an obstructive component because the sphincters are not opening up. Those tend to be what we like to classify as motility disorders because they're really overt findings that are associated with that. Now, functional disorders could have a motility abnormality, but it's subtle. It may not manifest or present with an obstruction where people feel food getting caught or food's getting stuck in the stomach. It's more that there might be a mild abnormality that might leave a little bit of liquid there, but people tend to sense that more. And that's kind of how we try to distinguish the motility from functional. It's really the overt findings and really focus on obstruction and retention versus the subtle findings where they could have some mild abnormalities, but it's more of the perception, the sensitivity, and the attention that focuses on that subtle motility abnormality.
Fantastic. Thank you, John. So like I said, we'll be talking about a lot of different disorders throughout the program. But, first, we are going to be talking today specifically about the different sections of your GI tract or your digestive system. So we're going to have talks about the mouth and esophagus, moving into the stomach, the small bowel, into the colon and the rectum. And so those are all the different areas of the GI system. And we're going to be giving you information. Lynn, can you talk a little bit about, we're going to talk about the different organs, the pathophysiology of, potentially some of the disorders that could happen in those. But when should a person say, I think this is normal for me, but maybe it's not? When should a patient say, maybe I should talk to my doctor about something? At what point in their, are there any alarm systems or things that should trigger them to say, maybe I should talk to them?
Yeah, I think it's a really good question and maybe different for different patients. But definitely, if there are symptoms that are bothering that individual, I definitely think they should seek care. Because you can read so much on the internet and it might be very helpful, but it could also sway you down a path that maybe it's not relevant to you. And also, it's really, it's obviously what we don't know what we don't know. And some patients may think, I don't know, what are they going to do if I go there? Is there anything to offer? But there's a lot of information, like accurate information that healthcare providers can provide a patient. And also, they may not be aware of certain diagnostic tests or different treatments that are available that may be helpful. And it could be pharmacologic or non-pharmacologic. But I just think if there's any symptom that is bothering a patient, especially if it's persistent, unpredictable, chronic, at least 3 months or even less than that, then I definitely think they should seek healthcare.
Absolutely. That's fantastic. So please keep that in mind. We are actually not here to give you healthcare advice, but to educate you about the digestive system, about disorders that you might have that are related to your digestive system. So, please keep in mind that if you do have bothersome symptoms, that you should go see a doctor, and that would feel free to contact IFFGD if you need help in locating someone near you. For those of you who are not familiar with the International Foundation for Gastrointestinal Disorders, we are an organization that is led by patients, that is for patients. We provide education on all areas in gastroenterology, as well as work with leaders in Washington with advocacy. We try to provide a community of support. We have a vibrant social media platform. For those of you who are not following us, please do. You can find us on Twitter, on Facebook, LinkedIn, Instagram, and on YouTube. And we will be tweeting and social mediaing all day long, whatever that is. That's not my forte. But we will be doing that. Please follow us along on social media and like the posts and share them throughout the next 2 days. So before we continue or go any further, I do want to let you know that every session here has been pre-recorded by some amazing, amazing colleagues, and that have done some really great presentations for you to view over the next 2 days. Some of them have included some graphic images, and these are images to help you to better understand what they are explaining in their talks. So just to let you know, there are going to be some videos from endoscopy and things like that that might be a little bit disturbing, or things that you may not understand. Just want to give you that disclaimer and that disclosure, and please understand as we're moving through if there are things that you are uncomfortable with. When the session is over, we'll be able to still participate in the questions. So one of the things, because we do have such wonderful people on the program over the next 2 days, a lot of times they mention disclosures. So Bill, can you explain to our patient population, why would someone include that in their talk, and how does that sort of affect our education?
This is a really important point for people to be aware of as they watch this program, or really any program that has to do with medical education. Remember that pharmaceutical companies developing devices or diagnostic tests, have a lot of expertise about the technical development of those products, but not necessarily the clinical expertise to choose the right patient for a specific treatment or test or device. And that's where the interaction between those companies and experts, like the three of us, for example, is really important, is for the clinical experts to put in perspective where a test, device, or treatment might best fit. But oftentimes that will include the exchange of money. And so there's the potential for either conscious or unconscious bias as people talk about various treatments or tests for a specific condition. And it's important for people that are listening to educators like ourselves to be aware of those interactions, those relationships, so that they can try as best they can to put things into perspective.
Absolutely. And just to let everyone know, these pharmaceutical companies and these device manufacturer companies had no input on the actual program for this weekend. However, it is important to know when you are listening to someone, or if you're Googling on the website, you know, if somebody is receiving funds from particular companies, that you are aware of that, so that you can understand if there are any biases. So we're going to go ahead and start our first session of the day. And like I said, we're going to start today with really talking about the digestive system. So it's going to lay a groundwork for the rest of the weekend. And we're going to go through the different sections of the body. Bill, can you introduce our first three speakers?
I'd love to. Thanks, Cecile. So our first speaker is a good friend and colleague of mine from the University of Michigan, Dr. Shantius Warren, who's an associate professor there and really an expert in functional GI and motility disorders, but more broadly, just gastroenterology in general. And she's going to give an overview of the gastrointestinal tract to hopefully put all the subsequent talks into some greater perspective.
And then we're going to go ahead and do the other two as well. So do you want to go ahead and introduce those?
Sure. Next, we're going to have Dr. John Pandolfino.
I'm sorry. Yeah, it's okay. Is it playing?
My name is Dr. Ceciel Rooker, and I'm here to talk to you about Gut Matters 101. Welcome to this exciting day today at the Norton Educational Series. And we're going to have a lot of really great content to talk about with you. But first, I thought it would be great to talk about general GI physiology and anatomy so we can understand what's going on during the rest of the speakers today. So when we talk about the GI tract or digestive system or gut, what we're really talking about is a series of organs. And our digestive system is made up of a series of organs that allows our bodies to absorb nutrients and water from the food we eat. And as food travels through the digestive system, it's broken down, sorted, and reprocessed before being circulated around the body to nourish and replace cells and supply all of the other very important organ systems in our bodies. And usually this series of organs is doing its job kind of under the radar and unbeknownst to us. But occasionally, however, as many of you know, and as we'll learn about more today, this isn't always the case. So think about it this way. You are anticipating a fresh baked apple pie coming out of the oven. And just the sight and the smell of it are really enough to make your gut kick into high gear. And so we'll discuss this whole process as food moves down and through the GI tract, starting from the top. So digestion actually starts in the mouth, where chewing and saliva breaks down food, so it's more easily processed by your body. It then is transferred from the mouth and throat into the esophagus, which is a muscular tube connecting the throat to the stomach. The esophagus contracts as it moves food from the mouth into the stomach, and this process is called peristalsis. So you're swallowing this bite of pie, the muscles in your mouth and throat propel it up to the upper esophagus, and then the muscles in the wall of esophagus create these synchronized waves, where above that morsel or bite of food, the muscles are contracting, But below that bite of food, the muscles are relaxing, allowing the food to pass through without resistance to the lower part of the esophagus. And when the lower part of the esophagus kind of senses or feels that bite of food there's a valve at the lower part of the esophagus called the lower esophageal sphincter, or LES. And this then allows the food to, the esophagus then relaxes, allowing the food to pass in to the stomach through the lower part of the esophagus. Most of the time, the stomach contents and acid in the stomach stay below the lower esophageal sphincter. And while some reflux of contents and acid are normal, gastroesophageal reflux can occur when too much acid or other stomach contents flow the wrong way, sometimes causing symptoms like regurgitation or heartburn. There are other symptoms or disorders related to common conditions of the esophagus. These include esophageal strictures, which is a partial blockage in the esophagus, which can lead to some swallowing difficulty. Also, Barrett's esophagus is a condition where there's abnormal cells at the lower part of the esophagus, possibly increasing your risk for esophageal cancer. And then finally, motility disorders can occur when peristalsis is disordered, sometimes causing esophageal pain or swallowing difficulties as well. So moving on from the esophagus to the stomach, after that bite of food moves from your esophagus to the stomach, that pie or a little bite of food is broken down further. And the stomach has very strong muscular walls. And in addition to storing your meal or holding that food, the stomach's job is to churn and mix the food into smaller and smaller pieces. The digestive glands in the stomach lining produce stomach acid and enzymes, which mix with the food to form a murky semi-fluid mass or paste called chyme. And here, the muscular walls of the stomach, along with the digestive enzymes, mix up the food, further breaking it down, and then waves of muscular contractions propel it through a valve called the pylorus or pyloric sphincter, which opens and closes, allowing the food to pass from your GI or from your stomach into the upper part of your small intestine or duodenum. This pylorus opens and closes and might release about 1/8 of an ounce or 4 milliliters of chyme at a time. The rest of it's held back for more mixing until it's small enough to pass through. There's really common stomach disorders that you may or may not have heard of. The first one that we'll talk about briefly is called peptic ulcer disease or ulcers. And this is generally caused by non-steroidal anti-inflammatory medications like ibuprofen or naproxen, but also a very common bacteria called H. pylori can cause stomach ulcers as well. Gastroparesis is a motility disorder of the stomach, which is caused by slow stomach emptying. Here, patients might have abdominal pain related to food, nausea, and vomiting. And then another common disorder is functional dyspepsia. And functional dyspepsia is a disorder where we can't exactly understand why patients have symptoms, but in this case, an upper scope may be normal, and blood tests and motility testing may be normal as well. So moving on from the stomach to the small intestine. The small intestine is kind of the workhorse of the GI tract. It's the longest portion of the GI tract, over 20 feet long. And here, the food continues to break down, enzymes released by the pancreas and bile released from the liver. It's made up of 3 segments: the duodenum, which is the most upper portion and the shortest portion of the small intestine, followed by the jejunum and ileum, which are really mainly responsible for the absorption of nutrients. As bile and pancreatic digestive juices mix with other juices secreted by the wall of the small intestine and stomach, all of these nutrients are then absorbed through the villi, which serve to increase the surface area of the small intestine, allowing for greater nutrient absorption. And in the intestine, including the jejunum and the ileum, food is broken down into smaller molecules so that it's absorbed. The ileum is really mainly, the ileum is the lower and most final portion of the small intestine, again, responsible for breaking down and absorbing virtually all of the nutrients that are passing through the GI tract, save for plant-based fibers that can't be broken down all the way. Common disorders of the small bowel or small intestine that you may be familiar with include celiac disease, where the small intestinal villi or those finger-like projections are damaged or flattened related to inflammation triggered by gluten protein that's found in wheat and wheat products. Similarly, Crohn's disease can damage the villi, but in Crohn's disease, there's often seen these small ulcers that you see here that can again lead to damage to the villi and also decreased absorption and abdominal pain. Certainly GI infections like viral or bacterial gastroenteritis can cause disorders of the small intestine. Small intestinal bacterial overgrowth, or SIBO, is also in this category. And also irritable bowel syndrome can affect the small intestine and the colon as well, that we'll get into. In the upper section of your small intestine, or the duodenum, digestion continues as chyme from the stomach mixes with a variety of digestive juices from your pancreas, liver, and gallbladder. The pancreas is tucked just behind the stomach, and it produces digestive enzymes that help break down proteins, carbohydrates, and fat. The liver is responsible for many things, including producing bile, a solution that helps you digest fats. It also helps to filter the blood that's absorbed and filter the nutrients that's absorbed from the small intestine going to the liver, which then can pass throughout the body to nourish all of the other cells and organ systems that require the nutrients absorbed from the GI tract. The gallbladder stores the bile that the liver is making. If the bile is not necessarily needed at the time that the liver is producing it, the gallbladder can store it and save it for a time when it's needed, especially after a fatty meal. There's several disorders that are associated with some of this pancreaticobiliary system. The pancreas can be sometimes inflamed, which can lead to a pretty painful condition called pancreatitis. If the pancreas isn't able to make the enzymes that are needed by the GI tract, that can lead to some difficulty with absorption or malabsorption with pancreatic insufficiency. And then finally, pancreatic cancer can occur involving the pancreas as well. The liver is the most common disease of the liver is fatty liver disease, which can then sometimes lead to inflammation. Cirrhosis of the liver or scarring of the liver can be triggered by medications, infection, alcohol, and fatty liver disease as well. And the gallbladder may be affected by gallstones, which could cause intermittent abdominal pain, usually in that right upper quadrant of your belly. And then the gallbladder can also become infected, leading to fever and pain as well. As the residue passes from the small intestine into the colon, nearly all the water is absorbed. This 5 to 7 foot long muscular tube connects the small intestine to the rectum. And the real job of the colon is to absorb water and process this waste so that defecation can then be easy and convenient. The muscles in the wall of your colon separate this waste into small segments that are pushed through from your lower colon and into your rectum. And it's made up of 3 parts here. The ascending on the right part of your body, the transverse colon, which moves the stool, at this point it's called stool, from the right side to the left side across your abdomen, and then the descending or left colon and the sigmoid colon connecting to the rectum. Common colonic conditions, of course, include constipation and diarrhea, which may be actually normal from time to time, irritable bowel syndrome, ulcerative colitis, where there's inflammation in the walls of the colon, sometimes causing diarrhea and bloody diarrhea, and then colon polyps and cancer. Colon polyps are actually fairly common. About 20 to 30% of individuals have colon polyps on colonoscopy. And if they're not removed, they may go on to become colon cancer. We're almost done here, down to the rectum and anus. And the rectum is a 8-inch chamber that connects the colon to the anus. The rectum receives stool from the colon and sends signals to the brain that if there's stool to be evacuated, alerting the brain that this might need to happen in the near future. But if that's not possible, it can also relax and expand, holding stool until evacuation is convenient. As the rectal walls are stretched, they signal this need for a bowel movement. The anus is comprised of several muscles, the pelvic floor muscles that kind of hold everything intact, and then 2 anal sphincters, the internal sphincter and external anal sphincter, that can relax and contract as needed. And all of these muscles together work to control defecation. Their jobs are to detect rectal contents and can really sense whether they're liquid, gas, solid, and then they can control when stool should and shouldn't be excreted from your body. Common anal rectal disorders include anal fissures, which is a tear in the anal skin at the outside of the anus, hemorrhoids, engorgement of the blood vessels that are draining the anal rectal muscles, fecal incontinence, which can include both loss of control of gas as well as stool, pelvic floor dyssynergia. Pelvic floor dyssynergia is when the anal rectal muscles aren't coordinated in order to have a quote unquote normal bowel movement. And then finally, rectal prolapse is where the lining of the colon or the rectum can come through the anal canal, causing some discomfort and feeling of incomplete bowel movements or incomplete evacuation. So as we stated earlier, the vast majority of the time, your GI tract is working under the radar to perform this vast number of functions, digestion, absorption, all to nourish not just the GI tract, but all of the cells in your body. And most of the time, we're not even really aware of the fact that this is happening. When this doesn't happen, we may become symptomatic, and there can be a lot of reasons for this. This can include disorders of the gut-brain interaction. There can also be perturbations in the GI microbiome contributing as well. Finally, nutritional causes may be playing a role in the imbalance or balance of the GI tract and all of its functions. And some of this we're going to learn about later today. So thanks for your attention. I think that we have a great program for you today, and I'll be here throughout the day to take any of your questions if needed. See you soon.
Hello, my name is John Pandolfino, and I'm a professor of medicine at the Feinberg School of Medicine, Northwestern University, and chief of the Division of Gastroenterology and Hepatology at Northwestern Medicine at Northwestern Memorial Hospital. Today, I'm going to be doing a talk on disorders of the throat and the esophagus and how we approach this. Now, esophageal symptoms, when you think about them, whether they're heartburn, which is a burning sensation in the chest, regurgitation, which is essentially bringing food up into your mouth, dysphagia, the sensation that food is not traveling through your esophagus, chest pain, or even getting a food impaction, your differential diagnosis in terms of what this could be is pretty vast. It could be reflux disease, GERD, gastroesophageal reflux disease. It could be eosinophilic esophagitis, which is an allergic reaction in the esophagus. It could be an obstruction from either a stricture or injury and inflammation. Hopefully not a tumor, but certainly could be that, although that is rare. It could be a motility disorder or a functional esophageal disorder, which may be related to either visceral hypersensitivity, sensing things at a physiologic level, or even just being hypervigilant to that particular symptom. Now, regardless of how patients present with these esophageal and throat conditions, all of our workups really lead to endoscopy or visualization of the area to rule out mechanical obstructions, injury from reflux, and allergic reactions, especially in the esophagus. Now, that being said, if we see a negative test where the endoscopy is negative, which does happen quite often, then these are the patients who may have a motility disorder or a functional disorder
or non-erosive reflux disease. And this is the standard diagnostic algorithm that we use for most of these esophageal symptoms. And as you can see, I don't want you to go through this part, but really what I want you to see is after we get the history and physical exams, at that particular point, we will always lead this diagnostic approach to endoscopy, usually with biopsies or even laryngoscopy, looking in the throat with our ENT colleagues. And really, when I go through this, that is really the starting point of my workup. When patients come in, I typically will treat most patients with these kind of symptoms with a proton pump inhibitor, and I'll schedule them for endoscopy. And as I go down this list, this is what I'm looking for as I approach the patient, thinking about what could potentially go on in this particular patient. And then if there is the possibility of maybe some inflammation like esophagitis, a stricture, I will address those directly during the endoscopy. But as I mentioned, at least 50% of the time, the endoscopy is negative, and we have to move on to further evaluation with esophageal function testing. And then, of course, thinking about what the appropriate treatments are. Now, in terms of, as I mentioned, the idea is this is what esophagitis or a stricture would look like. You can see this inflammation sitting around the esophagus. You can see this narrowing here. This is what we would see typically with pretty severe reflux disease. And if I saw this, I would know what you have. I would treat you with an escalation of anti-reflux therapy. Now, if I saw this, this is what an allergic reaction, eosinophilic esophagitis, looks like in the esophagus. This is actually a piece of chicken that's stuck in the esophagus. And this is related to an eosinophilic. It's a specific allergic cell type that infiltrates the lining of the esophagus and creates a more stiff esophagus, so food gets caught. So once again, if I see this, I'll know exactly how to treat this with acid medicines, and then of course some anti-inflammatory agents that are typically topical steroids. And then sometimes I'll actually see these anatomical deformations like a hiatus hernia where the stomach is actually above the diaphragm. And then certainly I will think that maybe we need to treat this with a surgical remedy. But as I said before, many times these approaches show us that most people, or 50% of the time, these people will have a normal endoscopy. This is what a normal end of the esophagus looks like. This pearly white mucosa here, lining, is actually the esophagus side, and then this salmon color below here is the stomach. And this is a nice intact squamocolumnar junction, which is the end of the esophagus and beginning of the stomach. And you can see here on the retroflect view where I'm looking backwards, I can see this flap valve that is created in this particular patient. And that is the anti-reflux barrier. Once again, that same location as we see in this first image here. Now, if someone does have a negative endoscopy and they're complaining of regurgitation, chest pain, dysphagia, or food impaction, this is when we get a manometry. And really what this is this is a very fancy tool to measure pressure along the length of the esophagus. Now, these tracings was the old way we did it, and now we have this much more intuitive way to do this, which we call esophageal pressure topography with high resolution manometry. And with this now, we're able to see anatomy along with the pressure patterns. And the pressure signals are on this hot-cold scale. So if there is a red color, it's high pressure. If there's a blue color, there's low pressure. And by taking those images and looking at distinct patterns, we can actually define and classify esophageal motility disorders. And this is really important because we will treat patients based on some of these patterns. For instance, if you have achalasia, and you'll see here type 1 achalasia, you will actually get a treatment that will rely on disrupting this lower esophageal sphincter so that we can open up that obstruction. Whereas if you have one of these disorders like jackhammer or spasm, type 3 achalasia and spasm, we may give you a smooth muscle relaxant, which will relax the wall of the esophagus so it's not contracting and spasming as much. Now, as I mentioned, there's a lot of fancy algorithms that we use, but when we actually go through a manometry, this is actually the flow process that we think through when we make one of these diagnoses. And as I talked about, some of these diagnoses are actually diagnoses where you have an obstruction at the end of the esophagus, and others are actually diagnoses where you actually have impaired propulsion, where the esophagus is not pushing the food and the liquid through the esophagus appropriately. Now, you don't have to really go through this, but this just gives you an idea of how we follow through the process of making these diagnoses. And then, of course, if we don't suspect motility and we're thinking that you have reflux disease, we'll actually put a little capsule here at the end of the esophagus, about 5 or 6 centimeters above that squamocolumnar junction where the stomach and esophagus meet. And we'll measure your acid by looking at the pH in your esophagus over 4 days, over 96 hours. And what we find is this is a very useful test for us to decide whether or not you actually have reflux or you don't have reflux. And with this particular test, we can actually direct therapy. So if you don't have any reflux, we stop your proton pump inhibitor or take you off acid suppressive medicines. And then we start to think about other things, like can this be a functional disorder? Can we try neuromodulators, cognitive behavioral therapy? Or we also make sure we're not missing a motility disorders. But certainly if you have 1 or more days, we stratify how aggressive we're going to be in terms of your acid suppression and your anti-reflux therapy, either increasing your acid dose or maybe even referring you for an endoscopic or surgical treatment for your reflux. Now, this is another more fancy tool that we use that uses a catheter we place down your nose, where we can actually measure air and liquid reflux. And in this example, this is actually the white color represents liquid refluxing up the esophagus. Now, this is a little bit more difficult in terms of for the patient because this requires a catheter down your nose. That other process was a capsule that was placed, and you don't have a wire or a capsule out of your nose, so a little bit more comfortable. But this is a much more accurate way to define people who are not getting better with reflux. So if you have reflux, and we know you have reflux, this is the test that we'll use to see why the medicines are not working. And we can look at all of these fancy parameters to see the reflux. We can look at air and the belching patterns. We can see whether there's rumination, where there's an effort, almost a subconscious effort to move stuff up from the stomach. A very difficult thing to diagnose sometimes, and sometimes you need these particular tests. This is a nice example of that high resolution manometry again. Here's the upper sphincter, the lower sphincter, and the purple color is liquid moving up into the oral pharynx, and there's regurgitation here. This is an example of how we can diagnose something like rumination, which is where people subconsciously, although it is voluntary, bring up fluid and food into the mouth from the stomach by raising the intra-abdominal pressure and pushing it up. And once again, many patients don't even realize that they're actually doing this because it's a learned behavior, and we can effectively treat this with diaphragmatic breathing. Now, also, many times we encounter patients who actually, we initially think have an esophageal problem, but the problem is really more relegated to the throat area. And one of the more common things that we see is globus sensation, which is a lump in the throat. And once again, I show this algorithm just like I did for the esophagus, because as you can see, right after we take a good history and do a physical exam, the next step is really doing the laryngoscopy and endoscopy. And really what you're trying to do here is you're trying to look and make sure you're not missing anything. Here is a little cancer that you might miss. And once again, most people with a lump in the throat don't have cancer, but we really want to be careful. And that's why it's important for us to send you to an ENT doctor for that laryngoscopy. And if that's negative, we will try to treat you for reflux. And if you don't respond, we typically, once again, do an endoscopy. Now, really, when all of these tests are negative, so say, for instance, we see a patient with these esophageal or throat symptoms, the endoscopy, laryngoscopy is negative, there's no evidence of reflux or a motor disorder, that's when we really start to think about a functional bowel disorder. And this is really where we start to think about how patients' esophageal sensitivity interacts with their hypervigilance, their levels of anxiety, and really how does that affect their symptom perception and then their quality of life. And this is really a very cyclical process. And what we find is that we can actually break that cycle and address those hypersensitivity and that anxiety, that visceral anxiety, sometimes with what we call neuromodulators. Now, none of these neuromodulators are FDA approved for this. They're actually off-label, but this is pretty much a very standard of care approach for various things like chest pain, refractory GERD, and globus. But probably what I'm using a little bit more in my practice is really a focus on behavioral approaches, really using hypnotherapy, cognitive behavioral therapy to really divert patients' attention away from the symptoms and help them self-manage their symptoms and live a better quality of life. And I think that this has been a very instrumental part of my clinical practice. So in conclusion, the functional esophageal disorders really require us to go through this very thoughtful process where we look for problems with endoscopy, direct visualization. When we don't see something on direct visualization, we start to think about, okay, is this a physiology problem with motility or is this reflux? And if those are ruled out, that's when we start to recognize that visceral hypersensitivity, hypervigilance, and psychosocial stressors may be at play. And then we target our therapy towards these particular components. So with that, this is a very important slide because once again, it highlights the fact that this is a real problem focused on a real abnormality that can be addressed with neuromodulation and behavioral interventions. So thank you very much for your attention, and I hope this was educational.
Hello, I'm Jan Takker. I'm going to present an introduction on gastric motility disorders. I'm a gastroenterologist at University Hospitals in Leuven, Belgium. So the stomach is a complex organ. It has many functions: initial storage of the meal, then it starts digestion, releases it to the duodenum in a controlled way. It helps to defend against GI infections. It's involved in satiety and hunger signaling, and it helps absorption of vitamin D. And if we look at the physiology centered around meal ingestion, prior to the meal, the stomach is actually contracted. And during the meal, it relaxes to store the meal. We call this accommodation. And then the next phase is empty. Throughout meal intake and after the meal, there's a sensation, a perception, which should be favorable, positive. And also meal intake triggers gastric acid secretion and release of certain peptide hormones. And when the meal moves into the duodenum, gastric acid secretion alters, there's duodenal secretion, and different hormones are released. So all of this is complex and can go wrong to give rise to gastric symptoms and to a number of conditions. In the Rome 4 consensus, these are the main conditions associated with gastroduodenal functional disorders. And I will be mainly addressing functional dyspepsia. I will be addressing nausea, vomiting, and gastroparesis. So functional dyspepsia, this is a just published European consensus, is a condition characterized by postprandial fullness, early satiation, epigastric pain, and burning with a negative endoscopy. Often associated upper abdominal bloating, nausea, belching, and gastroparesis, also from the same European consensus, is a condition characterized by symptoms associated with delayed gastric empty in the absence of mechanical obstructions, and the symptoms are nausea, vomiting, and early satiation and postprandial fullness. So let's go in a little bit deeper into the symptoms. Where are stomach or gastroduodenal symptoms felt? In this square, actually, between the umbilicus, the lower end of the sternum, and the mid-clavicular lines. And the symptoms that can be experienced are depicted here in pictograms: fullness after meals, early satiation, a tightening so the stomach doesn't open to store the meal, epigastric pain and epigastric burning, and there's often also upper abdominal bloating, a sense of gaseous distension. Heartburn is behind the chest bone. Nausea is a kind of sinking feeling in the stomach, and belching, I think, is self-evident. So when patients present with these symptoms, we will usually do an endoscopy, and when that's negative, it's considered to be a functional or motility disorders, and then we can do additional tests. Why should we consider doing additional tests? Well, they may help to explain the symptoms, help to make specific diagnosis, determine the choice of treatment, and predict long-term outcome. any test that does all 4 of these is a very useful, almost ideal test. I will be showing you some data on patient cohorts seen with upper GI symptoms and negative endoscopy. The prevalence of symptoms is shown as the yellow bars, expressing percentage of the population of patients who have them in a moderate to severe fashion. And the patient populations I will be addressing are overlapping dyspepsia and gastroparesis, 2 different groups who have some overlap. So the first test we can do is measure gastric emptying rate. And there's many techniques, but clinically, it's scintigraphy, breath tests, and smart pill that are the relevant ones, the ones that clinicians use. The oldest one and best established one is a scintigraphy. A meal is radio-labeled, it is ingested, and when the patient has ingested the meal and is behind the gamma camera, you can see the outline of the stomach with the radio-labeled meal in there. You draw a region of interest, and you look over time how the radioactivity disappears from the region of interest, and that allows you to calculate gastric emptying time. In the US, there is recommendations on how to do the test, which meal to use, but still I think there's a lot of heterogeneity, and in other parts of the world, this recommended uniform test has not been picked up. In Europe, and actually in our center, the breath test was developed, which uses a stable isotope labeled meal component. 13C is non-radioactive, and that substrate is degraded immediately when it empties from the stomach. It's degraded in the duodenum, digested in the liver, and appears in the breath as 13CO2, and you have an appearance and disappearance curve or a cumulative filling curve. And from these curves, you can actually use different mathematical models to link them to scintigraphy, and so it allows you to get the same type of information as you would get with scintigraphy. Very popular in the US, a little bit less in use in the rest of the world, is the smart pill, which measures pH, manometry, and temperature, and allows to quantify gastric emptying time, intestinal transit, colonic transit, and phasic motility on one manometry port. This is an example of a tracing. You see the drop in pH when the capsule falls into the stomach. You see phasic contractions here. And when it leaves the stomach, you have a higher pH. And further down the tracing, you can also identify a transition point between ileum and colon. And when the temperature suddenly changes from 37 degrees to the surrounding temperature, it means the smart pill has left the body. That allows to measure colonic transit time. Actually, the driver of emptying are high amplitude gastric contractions, either phase 3 or isolated big contractions. And so if you look at the correlation between the smart pill determined gastric residence time, seen as a pH step up, or the phase 3 of the MMC after the meal, this is well correlated. So it doesn't measure emptying directly, it measures an indirect phenomenon, the permission again of gastric phase 3 after the stomach has emptied completely. And can you explain symptoms with it? Well, first of all, if you look at 100 patients, around 30% of them with upper GI symptoms and negative endoscopy will have delayed gastric emptying. And in our hands, in yellow, compared to those with normal emptying in white, they have more fullness, more nausea, and more vomiting. And a couple of series in the literature, especially when patient groups of more than 300 were studied, found similar correlations, mainly with fullness, nausea, and vomiting. So there is a link with the symptom pattern. This is also often used in diabetes, and in diabetics, there's also a correlation between the retention of solids at 100 minutes on scintigraphy and the symptom score. It is a significant, not very strong correlation, but again, if you look at the symptom pattern, 2 of the studies actually show an association with bloating, fullness, but the sample size is smaller in diabetics. And then does it determine treatment? Well, the idea is that delayed gastric emptying through several pathophysiological changes induces gastroparesis symptoms, and that prokinetic drug treatment can reverse that, and that will be addressed in the treatment section of gastric motility disorders. The second one, which I will address shorter, is the gastric electrical rhythm. Contractions in the stomach rise from around this zone and travel down towards the pylorus to empty gastric content. And we now know that these are driven by interstitial cells of Cajal, a special rhythm generating cell network and a pacemaker region here. But now there's a new evolution with a body surface gastric mapping device developed in New Zealand by Greg O'Grady and colleagues, which allows to map in detail the origin and propagation of slow waves. And I think this idea of measuring the rhythm generating symptom is again up for a renewal and a revival. Gastric sensitivity is another one. You know, after the meal, there is perception which should be pleasant. And also during the emptying phase, there is perception. And we can study this by blowing up a balloon in the stomach and looking at the threshold to induce discomfort or pain. And compared to control or organic causes of dyspepsia, let's say a peptic ulcer, patients with functional dyspepsia, so with negative endoscopy, are abnormally sensitive. Here in this study, more than 60% were abnormally sensitive. If we put all the studies together, it's 40% that are abnormally sensitive to gastric distension. And in our hands, in yellow, hypersensitivity to gastric distension compared to the normal sensitivity in white is associated with much more pain, much more belching, and unexplained weight loss. So we call this visceral hypersensitivity. It's a modality that is not measured in clinical practice, but it is a driver of symptom severity in many conditions, including FD, including gastroparesis, and in the lower GI tract as well, in IBS, for instance. The last factor is gastric accommodation. This is the first phase of meal ingestion. You ingest a meal, the stomach makes space for it. And we already have indirect evidence that this is abnormal in functional dyspepsia. In health, the radio-labeled scintigraphy meal is immediately after ingestion, mainly in the proximal stomach, whereas in FD, with normal emptying here, it is in the distal stomach, suggesting that this part does not relax well. The gold standard is the barostat, a balloon device swallowed, lodged into the proximal stomach, inflated with a fixed pressure that allows to measure volume shifts in the proximal stomach. This is the preprandial. After a small liquid nutrient meal, this is a postprandial proximal stomach volume, and you can quantify this. And if you do this type of measurement or alternatives, imaging, for instance, like scintigraphy or with SPECT imaging, you actually find that 44% of patients with upper GI symptoms and negative endoscopy have abnormal accommodation. And in our hands, this is associated in yellow with early satiation and unexplained weight loss. So also this one is associated with the symptom pattern and is present in a subset of the patients. Now, the barostat balloon is invasive. It's a big thing to swallow. It is unpleasant. Nobody uses it in clinical practice. So people have looked for alternatives for the barostat measured accommodation. A simple one is the nutrient drinking test. A liquid nutrient composition drink is dripped into 2 beakers. The patient is asked to drink and keep up drinking by alternating the beakers as they fill and scoring satiation every 5 minutes. And if you do that on one day and you look at the end point, the calories or volume ingested when they stop, this is well correlated to a barostat test on another day. So this is a very simple gastric accommodation testing procedure that you can do in patients. The other one has been manometry. This is a standard esophageal manometry catheter now moved into the stomach. And if you move into the stomach, this is what you get. This is the lower esophageal sphincter with swallows. The single line is a single swallow, esophageal peristalsis. This is the proximal stomach. This is the antrum, phasic contractions close to the pylorus. And here ingestion of a liquid meal is started, and soon after, the pressure in the proximal stomach drops. It becomes blue, lower pressure, because blue is low pressure, green intermediate, red high. So you get a low pressure that gradually recovers. Upon meal ingestion also, the phasic contractions in the antrum are suppressed. And so if you plot this, you get a drop in intragastric pressure followed by a gradual recovery. And this is associated with the rise in satiation score. And if you do this in controls in blue versus functional dyspepsia patients, the drop in pressure is suppressed in functional dyspepsia. The meal volume tolerance is smaller in functional dyspepsia. The rise in satiation with meal ingestion is faster in functional dyspepsia. And the size of the pressure drop is correlated to the tolerated meal volume. So showing that this pressure drop is an indirect measure of gastric accommodation. So how does this work in clinical practice? People are seen with symptoms, fullness, satiation, pain, burning. This is the dyspeptic symptom pattern, or nausea, vomiting. You do the endoscopy, and it is negative to think of a motility disorder. Here you do the endoscopy, perhaps some other investigations as well for nausea, vomiting. If the endoscopy is negative, here you have a functional dyspepsia diagnosis. Here, with negative findings, you have chronic nausea and vomiting disorder. And then if you do the emptying test, it can be normal or delayed. In dyspepsia, if it's normal or delayed, you have dyspepsia with normal or delayed emptying. In nausea, vomiting dominated people, you have, when it's delayed, gastroparesis, when it's normal, chronic nausea and vomiting disorder with normal emptying. So that's what I wanted to tell about gastric symptoms and gastric testing, and I hope you enjoyed this brief presentation. Thank you for your attention.
Hello and welcome back. We hope you enjoyed our very first session of the Norton Educational Series 30th Anniversary Edition. Before we continue, we wanted to just talk a little bit about what we just heard from these three wonderful speakers. And first, let's talk a little about some of the definitions, some of the words that you may not have understood. I know that we had several of the speakers talk about the gastric duodenum. Dr. Chey, can you tell us what exactly is the gastric duodenum?
Yeah, so gastric refers to the stomach, and duodenum refers to the first section of the small intestine. It turns out that there are terminology to describe the first part, the middle part, and the farthest part of the small intestine. The duodenum is the first part, the second part is the jejunum, and the third part is the ileum. So when we talk about gastroduodenum, we're talking about stomach and the first part of the small intestine.
Fantastic. So that makes a little bit more sense. Thank you so much. Another term we heard quite a bit was visceral hypersensitivity. John, can you explain to us a little bit about what that is? I know it's complex,
Yeah.
but if you can give us sort of a high level view, that would be fantastic.
Yeah, I certainly mentioned it a little bit in my talk as we discussed some of these disorders. And really what it is it's an ability for the gut or the bowel to sense things at a lower level. So for instance, the way I describe it to people is, if I blew a balloon up in my esophagus, I may not feel it until a certain volume, but if I blew that balloon up in someone else's esophagus, they might feel it at a very low volume, where even if it's just mildly stretching the wall, that is sent as a signal as pain. And we find that, and we can see that people have different reactions and different triggers for reactions. So even though there might be normal function, that the bolus is going through the lumen, that volume is distending it, it may not cause symptoms in one person, but because it stretches and triggers it in another, they feel that perception of pain. And that can be very, very problematic in terms of quality of life, and really annoying in many ways, because you can feel that over and over. And that is something that we can modulate by effectively treating some nerves to not feel it, not sense it, not get triggered. And that's where you see us using a lot of these techniques like neuromodulators, medicines that affect the triggering of the nerves, and then even some of the behavioral instances like hypnosis, kind of shifting your attention away from those hypersensitive areas.
Fantastic. Thank you so much. So we want to answer some of the chat questions that we had from the audience this morning. And we had two questions that came in with Dr. Ezron's talk from Michigan about the digestive system. And the questions were, what is diverticulitis and what is gastroenteritis? So Bill, can you maybe talk a little bit about those and what those might look like?
Sure, absolutely. And let's start with gastroenteritis. So first thing to point out is gastroenteritis is different than gastritis. I know that they sound a lot alike, but they're not the same. So gastritis is inflammation in the stomach. Gastroenteritis refers to an infection that occurs in the gastrointestinal tract and typically leads to symptoms like nausea, vomiting, diarrhea. So in layman's terms, things like food poisoning or traveler's diarrhea would represent gastroenteritis. And remember that gastroenteritis can be from bacteria, viruses, or even parasites. So any infectious organism that gets into the GI tract and causes inflammation, and that leads to the development of these symptoms: nausea, vomiting, pain. and or diarrhea can cause gastroenteritis. Now, diverticulitis is oftentimes used interchangeably to refer to inflammation in a diverticulum, that is an outpouching in the lining of usually of the colon, but it can occur anywhere in the GI tract. Versus just where we talk about diverticulosis, where we're referring just to those outpouchings without the inflammation. So when people talk about diverticulitis, we're talking about a circumstance where that diverticulum has gotten inflamed, infected, and leads to severe abdominal pain, as well as fever, and is related to that inflammation and infection in a diverticulum.
Okay. And I think we're going to hear a little bit more about that later on in some of our talks in the next session. But thank you for that quick overview. That was great. And so, John, we did have a question on your talk in the esophageal, and so wonderful to have you here after giving such a great talk about the esophagus. And so, one of our viewers wanted to know at what point or when they go in to see a specialist and they're having issues in their upper GI tract, what are some of the things that you really need to hear from them? So the symptoms that they're experiencing, or the things that you need as a gastroenterologist to know to be able to make a really good, accurate diagnosis?
Yeah, so I think that certainly we have these symptoms called warning signs. And one of the first things that I'll ask people, particularly because that could mean that they have either a blockage, there's a stricture, or something that I can take care of, like scarring that's blocking flow. So I'll ask people, are you having trouble swallowing? Do you feel like things are getting caught? Is there pain when you're swallowing? Do you have any evidence that you're having any bleeding, which could be black tarry stools or blood in your stools, or maybe the fact that you might have anemia? Are you losing weight but not trying to lose weight? Those are some of the global kind of warning signs that we look for. But the other things that I actually look for and want to know from patients is how is this affecting your life? Is this affecting your sleep? Sleep is a big deal for us when we deal with throat problems and esophageal problems, because if you're having trouble with your throat and your esophagus, you could be microaspirating. So we're very concerned about your sleep. Obviously, also, we talk about your weight, even outside of a warning symptom. In fact, we track your weight to see how well you're doing. The other thing that I'll probably do a lot in my clinic, especially when people are coming with esophageal problems, I'll actually watch people eat or swallow. I'll give them a glass of water, watch them swallow, see how it's working, look at the throat, look to make sure that the anatomy is changing from an airway to a foodway. How easy is it for them to swallow? So I'll watch them kind of eat. I think those are really the important signs and symptoms that we're looking for in the clinic.
Fantastic. Thank you. That's very helpful. So another question we had during your talk was, you mentioned jackhammer, and that's, I think it's pretty rare. Is that rare?
It's very rare. And in fact, I think that most of the time when it gets used, it's probably not a significant motility abnormality like many people think. Really what jackhammer is it's really a repetitive, really strong contraction trying to force the food bolus or liquid bolus into the stomach. And it can be caused by an obstruction that might have been missed, like a little hernia, a stricture. We see it a lot of times in people who've had operations in the GI tract, but every now and then it can be just related to the muscle. And we're still not exactly sure what causes these kind of really strong contractions that give you jackhammer, but sometimes we can treat that effectively with medicines that relax the smooth muscle.
So if someone has jackhammer, what symptoms would they present with? So if I was to, is there pain, or is there what?
There can be pain, and there can be dysphagia, which means trouble swallowing or getting food and eating and getting it from the mouth into the stomach. But we see a lot of these patients who actually present with heartburn and regurgitation too. And that actually gives us kind of a pause to treat it as a primary motor abnormality if they have symptoms of heartburn with that, because as I mentioned, sometimes we can see this with reflux and a hernia.
Okay. So, and I know that in your talk, you talked about doing the manometry to be able to see how those muscles work. And so that would really give us a good idea. And thank you for that was a wonderful presentation with all the different options there. of what could possibly go wrong, which was a lot, which again underscores the need to go see your physician if you're having any symptoms that persist, like Lynn had mentioned this morning. So let's move on to Jan Tak's presentation. So he asked about, he mentioned something about body mapping. So what is body mapping?
So Jan Tak, as many know, is a world expert on motility and in particular the upper GI tract motility. And he obviously showed nice examples of very sophisticated technologies. And one of those technologies was body mapping. And although that's not clinically available right now in the United States, there are centers using it in research capacities. It's really a very high resolution ability to look at the electrical activity across the upper GI tract. And we know that there's different signals of electrical activity that they can actually characterize by looking at this body mapping. And we think that this may give us a non-invasive test to really look at how the muscles and the nerves are acting in the upper GI tract.
That's technology. It's really an amazing thing in medicine right now. So one of the things that we've heard this morning that we will be hearing throughout the next couple of days is we talk about medications that are FDA approved. So Bill, can you talk a little bit about what that means to be FDA approved? And I think we hear that a lot today as well, right? In other things outside of our gastroenterologists, but.
Well, Cecile, there's a complicated process by which a drug receives FDA approval in the United States. And of course, FDA approval is critically important for patients to look out for because it's really a sign that a medication or a device or a test has gone through a rigorous process of testing to be sure that it's of adequate quality and that it does what people claim that it's going to do. So realize that for a drug, there are phase 1, phase 2, and phase 3 trials. And the ones really to focus on are the phase 2 and phase 3 trials where the clinical efficacy, the right dose, and the safety are all identified. And these trials oftentimes include hundreds, if not thousands of patients. So as I said, it's a really rigorous process to achieve FDA approval.
And so in a normal timeline for a medication, let's say someone wanted to do something for GERD, for example, what does that timeline look like? How long would that sort of take a company?
It varies a lot by the compound and the indication, but probably it's more like a 3 to 5 year process. So it takes quite a long time for a drug to initially begin testing and then to get through all those phases of development and then finally achieve FDA approval. Just to give you an idea, like all the background research that occurs leads to something called a new drug application or NDA. Once the NDA is filed, it's at the absolute shortest a year and usually about 2 years to get through the regulatory process to be FDA approved. So just that from the NDA is at least a year and more realistically, probably 2 years.
Helps to understand why there's so few drugs on the market and why we're constantly doing research to get more. So just real quick, I know we have to move to our next session soon, but we did get a question about how the pancreas impacts the GI system. So who can answer that really quick?
I mean, I can take that a little bit. So, I mean, obviously the pancreas is really important for digestion. It does serve a function in modifying your sugars too, which can affect motility. But I think in terms of how we like to think about it, it's really a digestive organ. And if you lose the pancreatic function, you're not able to break down food appropriately. And then there are malabsorption where now you're not able to absorb these nutrients. And then, of course, the bacteria like to interact with some of these foods a little bit too much. And this is Bill's world too, where people get, a lot of gases that are accumulating and they get bloating and diarrhea. And it's extremely important. It's one of the organs that kind of gets out of the GI tract in a way. We kind of forget it in our motility world. But certainly it's an adjunct organ that's extremely important. And if it's not working, people can have horrible pain, bad, quality of life with bowel movements, and then, obviously malabsorption, not getting the appropriate nutrients and vitamins, which can have devastating effects on the rest of the body.
Right. Absolutely. So it is an organ that I know is small, but very important. So thank you for that question from the audience. So we're going to go ahead and move on to session 2. And John?
Yeah, so as you can see, we're moving down the GI tract as we're moving to the small intestine and the colon now. And in terms of the disorders of small bowel, this is going to be presented by Lucinda Harris, who is once again an expert in this particular field. Currently, she's at Mayo Scottsdale and is definitely a leader in small bowel diseases. And then we're going to shift once again, moving down to the colon, disorders of colon rectum, and that's going to be presented by Dr. Baha Moshiri. She's at the Division of Gastroenterology at Atrium Health in Charlotte, North Carolina. And once again, another world authority on disorders of the colon, anal rectal junction, and the bowel.
Fantastic. And so we'll hope you enjoy it.
Hello, my name is Dr. Lucinda Harris, and I have been asked to talk to you today about motility disorders of the small bowel. I would like to thank the IFFGD for the opportunity to do this talk for you and tell you a little bit more about motility disorders of the small bowel. So what is the small intestine? Well, it's kind of a misnomer to call it small because it's really not so small. It's about 20 feet long. And this is the small intestine right here. It's called the small intestine because of its cross-sectional area. And it consists of 3 areas: the duodenum, the jejunum, and the ileum. And I'm calling it the middle child because it's located between the stomach and the large intestine. One of the things to be aware of from a functional point of view or mechanical point of view is that if there are problems in the stomach or in the colon, the small bowel may be affected as well. It's also the place where digestion and absorption of your food take place. So it moves and absorbs. That's its kind of primary thing. And it's composed of the enteric nervous system. There are over 600 million neurons that are located in both the lining and the smooth muscle of the GI tract. It's been called the second brain because it can operate independently of both the central and peripheral nervous system. And as I said before, what it does is digest and mix the food and absorb nutrients. How it does that is by various cells that are located in the lining of the small intestine, and it depends on something called peristalsis. And peristalsis means that there are waves of coordinated contractions and relaxation that move the food through the GI tract. There's also a little pacemaker within the lining of the small intestine called the migrating motor complex. And it's very important because it helps sweep the food and nutrients through the gut. There's also other wiring. So you think of the enteric nervous system as the nervous system that innervates or works in the lining of the small intestine, but there's a control system, often called the autonomic nervous system, that consists of sympathetic input from the vagus nerve and parasympathetic nerves, which are the splenic nerves. So what is a small bowel motility disorder? What do we mean when we say that? Well, it can be a problem with muscles and or nerves that control the movement in the small bowel. On the right-hand side of the slide, you can see a picture of the inside of the small intestine. The whole group of disorders is often called chronic intestinal pseudoobstruction. And by that, it's meant that the intestine behaves as if there is a blockage, but there actually is no blockage in the intestine. And there are primary and secondary causes of this disorder. So primary chronic intestinal pseudoobstruction is the type of pseudoobstruction that occurs mostly because of genetic disorders. So there are familial visceral neuropathies, familial visceral myopathies, and types that occur sporadically. And there's also something called a mesenchymopathy, where there are defects in pacemaker cells called interstitial cells of Cajal. So these are primarily the genetic disorders, and they can occur in families, and they can have different types of transmission. Now, they are extremely rare, and they estimate that only 100 cases per year occur. There are also secondary causes of pseudo-obstruction, and these make up about 60% of the small bowel dysmotility disorders. These can occur because of infection, like viral infections. Chagas disease is a disease that occurs in South America due to a parasite known as Trypanosoma cruzi. There can also, and probably this is the most uncommon type of pseudo-obstruction, occurs because of connective tissue disorders like lupus and scleroderma. There are also autoimmune causes that occur because of diseases like myasthenia gravis. They can have endocrine causes. Another not uncommon cause is cancer. There can be what they call paraneoplastic syndromes. That means syndromes that are associated with someone having cancer that slows down the motility. There also can be pseudo-obstruction due to drugs, and the most common medication that causes that is usually the narcotic medications that people take for pain syndromes, but also some of the medicines that people use for Parkinson's disease, the L-DOPA medications can cause that. And there can be miscellaneous causes. Another fairly common cause of pseudo-obstruction can be radiation and even Ehlers-Danlos, which is a defect in the connective tissue, which can take many forms and has been coming to more popular discussion lately, can cause pseudo-obstruction. Well, what are the symptoms? That depends a lot on the part of the GI tract that's most effective. It's important to know that men and women are probably fairly equally affected. The disorder can be sort of like chronic low-grade symptoms of nausea and abdominal discomfort, but oftentimes people may have what we call acute attacks. And these acute attacks consist of nausea, vomiting, severe abdominal pain that can be very sharp in nature. It is often also associated with bloating, and constipation is very common. Patients also will complain of feeling full fast, that's called early satiety, loss of appetite, and there often is weight loss. One of the complications that is very common in small bowel disorders is that patients can get what's called bacterial overgrowth, and that can cause diarrhea. So usually the small bowel doesn't have a lot of bacteria in it, but because the intestinal motility is not working to sweep out the bacteria, patients get diarrhea. And bacterial overgrowth is covered in other educational videos. So I will refer you to that because that would be a whole lecture within itself. Other common symptoms are difficulty swallowing, heartburn, chest pain, and the disorder can affect the urinary symptoms of the urinary tract. So patients have symptoms emptying their bladder or getting urine started. How do we diagnose chronic intestinal pseudo-obstruction? There can be blood tests that look for inflammation and autoimmune markers. I've already shown you plain X-ray, but we can also use barium and CT scans and MRIs. Endoscopy can help us rule out that there's no mechanical obstruction. There's a test called manometry, which is a flexible tube that's inserted in the GI tract, either into the esophagus or the rectum, that can take pressure measurements that can suggest this disorder. We also, and you see it pictured here, have wireless motility capsules that people swallow, and we can tell and track this capsule and look at how fast the gut is moving. We can also do that with another X-ray modality called nuclear medicine studies, where we have patients eat a meal that's nuclear tagged, and we can tag how long it takes for food to go through the GI tract. We also use breath testing for diagnosing the small intestinal bacterial overgrowth. There's another modality called radio-opaque marker studies, which are little markers that people swallow, and we take serial X-rays to tell how quickly those markers are moving through the GI tract. Very rarely, we also can do full thickness small bowel biopsies that can look at the cells and see where the defects are more completely. To manage chronic intestinal pseudo-obstruction is to really do supportive care. So most of the symptoms result in problems with nutrition, and so certain diets are recommended. There can also be drugs used, and the drugs that we most commonly use are called prokinetics. And we use antibiotics to treat bacterial overgrowth. We can use pain management, but we try to avoid narcotics because of the fact that they slow down the gut. If there's a cancer, we treat the underlying cause. We also have to pay attention to lifestyle. There can be complementary medications and visceral massage that helps. And in very small number of cases, we can use intestinal transplant. In the next two slides, I cover some of the medications that are commonly used to treat intestinal motility. They oftentimes are not indicated as medications specifically for the disorder. For instance, prucalopride is actually improved to treat chronic constipation. There are really no medicines that are approved by the Food and Drug Administration to treat this disorder. We also use medications called anticholinesterase medications, primarily pyridostigmine, which you can titrate up in small amounts. And you can see that a lot of the medications have a lot of side effects. For instance, pyridostigmine, because it works on muscle receptors, can cause diarrhea and also muscle twitching. Just a moment to discuss small intestinal bacterial overgrowth. The small bowel in good health only contains a small amount of bacteria. There can be a variety of antibiotics that are used. The important point here is that probiotics are not helpful, but promotility agents may help to sweep some of the bacteria out of the gut. So in summary, chronic intestinal pseudo-obstruction is a very rare disorder divided into primary and secondary types. The problem is either in the muscles or the nerves of the small intestine or both. It has both chronic and acute symptoms most often being nausea, vomiting, abdominal swelling and pain, and weight loss. The treatment is mostly supportive. And certainly, as my dog Danny demonstrates, food is very important to us. And it really is an impetus for us to seek more treatments, and research is desperately needed in this area, even though these disorders are rare. Thank you for your attention.
Hi, everyone. Today, I'm going to talk to you guys about disorders of the colon and rectum. And we're covering session 1, which is really pathophysiology and diagnosis. I'm at Atrium Health, which is located in Charlotte, North Carolina, and I'm director of motility here. So the common diseases of the colon will be covered first. These are diseases and syndromes, I would say. So diverticulosis, we will cover, pretty in depth, since this is actually pretty common. Irritable bowel syndrome is also a common disease syndrome that is special to me because it's an area that I do research in. And then inflammatory bowel diseases are ulcerative colitis, Crohn's disease. We'll also cover constipation, but not diarrhea syndromes, as this talk is only 20 minutes. Colonic ischemia, infectious colitis, sigmoid, and cecal volvulus can also develop, and then polyps and tumors. So diverticulosis, this is very common. You know, it's often asymptomatic. So patients who have this condition don't have any symptoms. And this, you can see on the colonoscopy photos here, where there's these outpouchings in the colon. And what is the cause of this is it develops from what we think is herniation of the colon mucosa and what's beyond the colon mucosa, which is called the submucosa, and defects in a muscle layer in the colon that's within the wall. And this occurs at sites that are penetrating blood vessels in the colon. And again, it's extremely common, and it's usually found just incidentally when we're scoping a patient. And scoping a patient means doing a colonoscopy. And these patients can have, other than just having no symptoms, they can have diarrhea, they can have constipation, bleeding can occur. When bleeding occur, we call it diverticular bleed. And they have just red blood per rectum. Sometimes it's like dark blood. And if there is pain in patients who have diverticulosis, it's from either spasms or this underlying inflammation that can occur. And then when the diverticula become infected, we call this diverticulitis. And how it's diagnosed is by a CAT scan that shows there's inflammation in the colon. And most of the time, those patients get placed on antibiotics. There are risk factors for diverticulosis. Those are the risk factors are being on a low fiber diet. So, you know, in the United States, Australia, Westernized societies with low fiber intake, there's a higher risk. Age is a risk factor. You know, 50% of patients over age 70 will have some kind of diverticulosis. And then obesity, use of non-steroidal medicines like, you know, the over-the-counter formulas like ibuprofen, Advil, all of those can cause it. And then drugs like opiates, which is Crohn's disease. There is some diagnostic testing that's, you know, recommended in patients who have suspected irritable bowel syndrome. And these are really recommended in patients who have more of the IBS with diarrhea. And the most important is to test patients who have irritable bowel syndrome and the diarrhea kind for celiac disease, and that can be done by blood tests. And these are the blood tests that are listed here, are IgA tissue transglutaminase and quantitative IgA. We also want patients who have the diarrhea kind of irritable bowel syndrome to have testing with stool tests, specifically for fecal calprotectin and lactoferrin for inflammatory bowel diseases at least once. If they're having a colonoscopy, because they also have other alarm features, such as they're over, you know, we say now actually 45 years of age, you know, blood in the stools, symptoms at night, you know, unintentional weight loss, changes in symptoms, antibiotic use, and a family history of organ disease or organic GI disease, such as inflammatory bowel disease or celiac, that if they're having a colonoscopy, they should have biopsies of the colon so that we make sure that there's not this other thing called microscopic colitis, which is found in, you know, 1.5% of patients who have irritable bowel syndrome. The differential diagnosis for constipation, it's very wide. So what can cause constipation could be medications. For example, NSAIDs, again, things such as ibuprofen, aspirin, Advil, pancreatic enzymes that patients are on for chronic pancreatitis, possibly, although that's a little bit controversial, opiates or narcotics can cause constipation. Some of the antacids, like Tums, can cause constipation. Even some PPIs can cause constipation. These are frequent drugs that our patients take. Bile acid sequestrants can be constipating, and then drugs such as anticholinergic drugs can constipate. Now, other than drugs, irritable bowel syndrome with constipation makes up 20% of the constipation population. 40% of patients who have pelvic floor dysfunction, you know, are diagnosed as having chronic idiopathic constipation. So we'll talk about that, what that means even. And then 2% of the patients who have constipation have something called slow transit constipation, which is an impairment in how the colon is able to contract and move forward. And we can do diagnostic tests for that. And then there's chronic idiopathic constipation, which the US prevalence is like 12 to 19%. So these are high. The diagnostic evaluation is a rectal exam. So the best way that we have as physicians and caretakers and APPs is to do a rectal exam. So the importance of the rectal exam is that it's, first of all, visual. So we look to make sure there's no what's called rectal fissure. We make sure there's no hemorrhoids, which can result from severe constipation and straining. We make sure there's no rectal prolapse, which is a protrusion of the rectum that comes through the rectum as a result of people straining so much to have a bowel movement. And then we can obviously palpate for mass in the rectum, make sure if we feel hemorrhoids inside that we're treating patients for that. And then testing the muscles and seeing if the patient, when we ask them to do squeezes and push out our finger, are able to coordinate the correct muscles to be able to do that. If we feel really hard cemented stool in the rectum, then that can lead to other diagnostic testing that the patient may need. So the most important diagnostic test is our finger, especially for patients who have constipation predominant IBS. And then I would say also for the mixed type IBS patient, but really every patient should get that at least the first time. Now, for severe constipation, that's the 2% of patients who try the relaxative, whether it's over the counter or not, nothing's helping. Colonoscopy is actually just only indicated if you're 45 and up for colon cancer screening. So colonoscopy is not a test that's necessary for constipation, unless the patient has iron deficiency and other stuff going on. Now, there are transit studies that can be done. Those are called whole gut scintigraphy, which is only available in a few centers such as Mayo Clinic. There's SITS marker study. That's a radio opaque marker study depicted here on an X-ray. Then there's wireless motility capsule, which involves a capsule the patient swallows, and it goes through the entire gut. And we look at both the gastric, the small bowel, and the colon motility to see if we can see good contractions or not throughout. That could be one of the causes of constipation. And then there's manometry, where we actually put a probe inside the rectum and we measure pressures in the rectum. We ask the patient to do certain maneuvers. We ask them to strain. We ask them to squeeze. We ask them to rest during the test. And we check the nerves and muscles and how they're functioning in the rectum. There's also another test called the balloon explosion testing. Then we have MRI deprecography, where contrast is placed into the rectum, and we can see if there's what's called a rectal seal, which is an outpouching of the rectum that occurs. You can see it here on evacuation, depicted at the arrow, where there's an outpouching that occurs anteriorly towards the vagina. This back here is the spine. And then we really can look at the anatomy of the rectum and see how is the rectum coming down in the pelvic floor. Is it able to allow the patient to defecate? Then there's acute syndromes in the colon. So these are colonic, what's called pseudo-obstruction, which isn't obstruction, but it looks like it. Obstruction would be complete narrowing of the colon wall, and that ends in surgery. And then ileus is where the colon just doesn't move. It's almost like a paralyzed colon. It won't move. Usually results because the contents of the small intestine are not able to contract and move forward, or it can occur in the colon. And this is usually due to inflammation from some systemic illness or something else going on. It could happen post-op. And there's an extreme pain that occurs with this. So patients usually have extreme abdominal pain. It comes on suddenly. The abdomen is just very distended, tight. Patient may vomit, and then hopefully it resolves completely. The most common cause of an ileus is either abdominal or retroperitoneal surgery. And this is a common cause of like hospitalizations and what revs up the cost of hospitalizations in the country. It usually resolves in 48 to 72 hours. It's really important for any surgeon that operates on the colon or the abdomen to put patients on a drug that can prevent the effects of an ileus, and those drugs do exist. And also to really limit opiates after surgery, because opiates themselves paralyze the colon and the small bowel and the stomach. So giving too much of them can be problematic. This is Ogilvy. There's actually a syndrome that's named after the surgeon who was actually a war veteran in the Balkans and served in World War I and World War II. And this orthopedic surgeon, also the GI, he was a sailor as well. And he defined this acute massive colon extension that can occur in some patients. Usually they're institutionalized or in nursing homes. And, there's a complete extension of especially the right side of the colon, and there's no mechanical cause to this. And usually this is self-limited and hopefully will recover. Otherwise, there is a mortality associated. So the signs are distension. It occurs over 3 to 7 days, very acute, can occur over 24 hours. 80% have, mild to constant pain. There is significant distension usually, some painless. 60% have nausea, vomiting, 50% have symptoms of constipation, and most patients will have good bowel sounds when we listen. But it can also be due to excess dehydration or when the electrolytes like magnesium, phosphorus, potassium in a patient are abnormal. This is what it looks like. So on X-ray, it is this black area is just distension of the colon. It can dilate to like 20 centimeters sometimes. This has a risk of perforation, which is the colon can just pop. And as a result, patients can develop sepsis, and usually patients get really sick. X-ray and CAT scan is the way to diagnose this. And usually the CT scan is better than all the other imaging. This here is a picture, it's a sigmoid and colon volvulus. So you have a sigmoid volvulus over here on the left side, and the colon just is so distended, it's the balloon, it pops like with air. And then here you have a cecal volvulus where it looks like a little kidney bean out here, where the right side of the colon is just completely distended. It's compressing on the left side of the colon, which is over here. And as a result, these patients are also at risk of having a perforation. And with the sigmoid volvulus, we do a colonoscopy to decompress. With the cecal volvulus, which also develops acutely, these patients usually have to go to surgery to get that part of the colon resolved and removed and untwisted. So just to show another picture, there's actually a disorder called, Chagas disease, which affects the esophagus. There's one called Hirschsprung disease, which affects the rectum, where the rectum muscles do not relax. And as a result, patients develop what's called megacolon. And these conditions are all due to these pacemaker cells being lost and deficient. And things that can attack the pacemaker cells in the gut are things like viruses, for example, COVID-19, other infections can affect the pacemaker cells. And these pacemaker cells go from esophagus all the way down to the colon, and they are located in where the nerves in the gut are. So they're located in what's called the mesenteric plexus and the submucosal plexes, and they're also within the muscle layers. And so this is what promotes movement of the gut and helps motility of the gut. So I thought it'd be good for you guys to see the picture of that. And if those don't work, then you get these other conditions that we're talking about here. So this is a SITS marker study where we ask patients to, again, swallow a capsule, and then it breaks up into 24 pieces, and we count how many of these are left after 5 days of ingestion. And we look for these clearance to see if there's a portion of the gut in the colon that's not working. And if they're abnormal, it could be that there's slow transit constipation or the pelvic floor is not allowing relaxation. So when we diagnose patients with dyssynergic defecation, we use this 50 ml watermill balloon, and it's depicted here. And that goes in, it has polyethylene catheter that's attached. We go past the puborectalis muscle that goes around like the sling around the rectum that allows us to have continence so we don't poop on ourselves. And then we see if the patient is able to expel this 50 cc balloon in the 2 minutes they're given. The patient sits on a commode, and that's one way that we can test and see if the patient has dyssynergic defecation. Now, this has to be complementary with another test. So usually for the other test, we use what's called the anorectal manometry. And that test is done in dedicated motility centers and done by some colorectal surgeons around the country who operate on the colon. And this test also helps us determine if the patient has this problem. So here we have the picture of the coccyx bone and the back. And the rectum is depicted here with this angle. And so normal physiology, when the patient is straining to have a bowel movement, what should happen is that that angle needs to straighten up more during that straining. And as the angle of the rectum straightens, the puborectalis muscle relaxes, and that allows stool to pass. So when we don't want normally patients to push so hard, because if they push and strain a lot, they get hemorrhoids, they can get fissures, and they may not actually be able to coordinate the muscles correctly to be able to push it out. Hemorrhoids are pretty common. 40% can cause bleeding. There's a lot of swelling that's involved. Some of them itch. It's in 24%. And then pain does not occur in hemorrhoids unless they are what's called thrombosed, which means the blood supply to the hemorrhoid is cut off. So those are the painful ones. And if a patient has pain, that should prompt evaluation for some other cause that's coexisting with their hemorrhoids. So again, 50% of patients have hemorrhoids by the time they're 50. 10 to 20 million people have active symptoms, and then 5 million patients seek, attention every year for this. We spend a lot of money on over-the-counter medications, and most of the colonoscopies, that we do on an inpatient setting, are done due to bleeding from diverticulosis and hemorrhoids. So these are really common, and then most are just treated with relief formulations that are over-the-counter, and then steroids. So this is the anatomy of the hemorrhoids. You can see the internal ones are inside and past the dentate line. And then you have the external ones that are more outside. And if they get thrombosed, they're extremely painful. The risk factors for hemorrhoids. So lack of fiber and fluid intake has been a potential risk factor. Sitting too long on anything, even at a desk, like we've been doing during COVID, virtual interviews and everything, can be a cause. Sitting too much on the toilet, straining too hard, ignoring the urge to defecate can be all problems. Patients who have connective tissue diseases like scleroderma, lupus, Ehlers-Danlos have increased risk of hemorrhoids. And then any condition that increases the rectal tone can also cause anxiety, etc. So it's usually due to the enlargement happens because of the weakened muscle and the elevated sphincter, which is the muscle in the rectum tone, and then an increase in abdominal pressure. We diagnose hemorrhoids by visually inspecting them. We also, of course, the rectal exam can be helpful because you can palpate it. Anoscopy is the way that we can look at the anus area, and usually it's done by a GI doctor or surgeon. And then flexible sigmoidoscopy is where we use a colonoscope and we go up the rectum and the colon, and we're able to see in backwards view of the rectum and in forward view whether a patient has a hemorrhoid. So in any patient that has a hemorrhoid, we also have to consider what if they have this pelvic floor dyssynergia, which is, again, so common in patients with constipation. They could have what's called the anal spasm that's causing a fissure. We'll talk about proctalgia fugax and what that is. And then, of course, an abscess in the rectum, which is an infection around the rectal area, can cause problems, and especially that's seen in patients who have Crohn's disease. So anal fissures, it's almost like a paper cut of the rectum. The rectum has a lot of nerve supply, and it can be extremely painful to have these rectal fissures. So these are patients that have either acute or chronic pain. 90% of them are located posteriorly, so towards the spine. Any trauma, like a hard stool, sexual practices can cause fissures. Inflammatory bowel disease patients, especially Crohn's patients, have a higher risk. We have to make sure there's not cancer infiltrating, but most of them are not related to any cancer. They can happen post-op, and then infection is it. Moving on to fecal incontinence. So this is fecal leakage. There are structural reasons why patients would have fecal incontinence. There's stool characteristics that may be a reason, such as even having hard stools, and then functional abnormalities that can cause it. Fecal incontinence is highly prevalent. It's seen in 9% of the population, and it's actually common both in men and women. In women, it's 9%, and in men, it's actually 7%. And in people who are over 70 years of age, it's 17% is the prevalence. So it is very, very high. We do have diagnostic testing for fecal incontinence. That's done with, again, an anorectal manometry to see if the sphincter pressures, the nerves are okay. There's ultrasound that can show if there's a defect in the rectum. For example, a woman who had a vaginal pregnancy maybe 30 years ago and had an episiotomy would be at risk. And then there's testing that we can do with EMG, which is done to distinguish whether there's a nerve or muscle problem. And those kind of have fair evidence behind them. So the summary of all diagnostic testing we have, there's functional assessments with the anorectal manometry that's done with this probe and catheter. There's ultrasound to see if the sphincter muscles are intact. There's defecography. This is fairly new, but it's kind of a nice way of evaluating. The MRI is new. There's also barium defecography to see if the there is an evacuation disorder, if there's a structural problem, for example, sometimes the bladder is falling down and is putting pressure on the rectum, and that's the cause of patient symptoms. There's EFG, which is done when patients go through physical therapy, which is very effective for a lot of these pelvic floor disorders. Then there's pudendal nerve motor latency, which we didn't talk about, which is a way to assess the sacral nerve function, especially in diabetics. And then there's new stuff like this little depiction here that looks like a wine glass that's flipped, but for the rectum, where we actually evaluate if the rectum is able to distend adequately. Some patients have poor compliance and the rectum is not able to distend appropriately. So then there's polyps, right? So of course, this is not a talk on colon cancer screening, but it's really important to get some kind of colon cancer screening, whether it's a colonoscopy, virtual CT colonoscopy, fecal DNA testing. It's important in patients who are age 45 and up, and those who have risk factors or family history of colon cancer. April was Colon Cancer Awareness Month, just like it was IBS Awareness Month, and it is really important to be cognizant of getting screening tests done. So polyps can develop into cancer, and colonoscopies save lives. Now, for the functional rectal pain syndromes, this is proctalgia fugax and levator ani syndrome that we'll talk about. Levator ani syndrome happens more in women. They're usually younger women. It's a rectal pain that's intense. It's can happen intermittently for 2 weeks, and it can last over 20 minutes at times. It's vague, dull type of pain. It doesn't awaken the patient at night most of the time, and it worsens when the patient is sitting or defecating. And usually walking and lying down helps it. So this muscle that's in the rectum kind of spasms, and that can be very painful. Then there's something called proctalgia fugax that happens in young men, really type A personalities, high-performing folks can have this. It's a sharp stab-like pain, so this is very painful, as opposed to like an ache that happens with levator ani. Wakes up the patient. It's usually induced by stress, where the patient just kind of tightens their sphincter all the time, and it's a smooth muscle dysfunction, and patients who have IBS can also have it. Anal rectal manometry, which is depicted here, is the way we diagnose it. So we test patients' squeeze, we test their muscle control, we test their relaxation, and all of that in a color topography as we depict here helps us determine whether patients have these conditions that we talked about. So lastly, happy birthday, 30th birthday to IFFGD. You're 16 years younger than me. So, still in your youth, and I'm sure you'll have fantastic accomplishments as the years will roll on. And I'm excited to be working with you guys on several projects that this great team of ladies and gentlemen, but a lot of ladies have really formed. So it's great to have you guys really advocate for our patients. Thank you so much.
Hello and welcome back. I hope you enjoyed those two presentations from Dr. Harris and Dr. Moshery on the small bowel, or the small intestine, and the colon. So first, with Dr. Harris's talk, she, is, an expert in the small bowel. And I know that one of the things that we hear a lot about here at IFFGD is questions about that relate to food. And one of the big things that we hear is about gluten and gluten sensitivity versus celiac, and why that's important, and why are doctors always looking for that. Can you talk a little bit about that issue with gluten?
Sure, I think I can take this one.
Okay.
Celiac disease and gluten sensitivity, there's a lot of overlap and discussion about this, and people get confused, but celiac is actually a specific disease that is diagnosed with abnormal test results that suggest that there might be this autoimmune process that's destroying the ability of the small intestine to absorb stuff. Gluten sensitivity is really kind of more of a reaction to the gluten, and it's a little bit harder to define because there's not a distinct blood test for that. In fact, many people who have gluten sensitivity get those symptoms, but their testing comes back negative, their biopsies come back negative that don't show any abnormalities. So that's where the distinction is. But I think, in terms of gastroenterologists, when people come in with all different types of complaints, whether it's diarrhea, bloating, abdominal pain, and many times we want to rule out celiac disease because it is pretty common. Depending on where you live in the world, it could be 1 in 100 people have celiac disease. And then if you layer in all the people who are kind of sensitive to gluten, you know, then you're looking at a pretty high number of people. So it's really important to remember that when you come in with these complaints and vague symptoms, we look to celiac a lot to rule out, but there are people who are sensitive to gluten who don't have celiac disease, and those people tend to avoid gluten and they feel better. We don't know if it's that they're avoiding other things too when they avoid gluten that they feel better, but nonetheless, if they're feeling better, we don't really care. I think that's the most important thing when we're dealing with these patients. So it's an important topic. You're going to hear a lot about it when you think about gut health and gut, you know, diseases in general.
Hey, Ceciel, can I make one comment too?
Absolutely.
You know, and what John mentions raises a really important point, and that is that this term non-celiac gluten sensitivity is probably a bit of a misnomer, because for celiac disease, where individuals have a disease that's genetically mediated and they're reacting to the protein in wheat, gluten, that's different than for patients that have non-celiac gluten sensitivity, where they could be reacting to, as John pointed out, any of a number of different things. There may be proteins that they're reacting to. More importantly, and oftentimes, they're reacting to a sugar in wheat called fructan. And so a better term for those patients than non-celiac gluten sensitivity is non-celiac wheat intolerance or wheat sensitivity. That's a more holistic term that is technically more accurate. And we should all be using that term and not using non-celiac gluten sensitivity.
Fantastic. And I know that some people, they will take themselves off the gluten and different wheats and then they feel better. And is there anything that they should be concerned about in doing that? You know, making such an altercation in your diet long term? Is there any risks of being on this diet long term?
Short answer is no. You know, a gluten-free diet now, there's such a wide range of foods that are available that are gluten-free that you can take a very healthy diet that's gluten-free now. You know, early on when we first started to do this, there were a lot of concerns about nutritional deficiencies related to a gluten-free diet. Those have largely gone away. So, you know, people can live a gluten-free lifestyle and still be very, very healthful in 2021.
That is so fantastic to hear. Wonderful. So let's move on to Dr. Moshery's talk. She made a comment when talking about diverticula again, which is a huge topic in the GI community. So when she was referring to diverticula, she said that sometimes they form due to a herniation in the colonic mucosa or submucosa. And so that seems very daunting to me. Can someone break that down a little bit easier?
Yeah, it is a little bit confusing. And, you know, at the risk of getting too complicated, it's important to draw a distinction between true diverticuli, which involve all the layers of the visceral GI tract, so in the small intestine or stomach or colon. True diverticuli involve all the layers of the wall of that organ. But colon diverticuli, which are what are most common and what lead to diverticulitis, are actually pseudo diverticuli. So they're not true diverticuli. They only involve the most superficial layers of the colon and not the whole wall of the colon. You might ask, well, how does that work? Well, remember that in the muscle that surrounds the colon, there are arteries that pierce through the muscle and go and provide blood flow to the more superficial layers of the colon. Where those arteries come through the wall of the muscle in the colon, if the pressure gets high enough, actually the superficial layers of the colon can herniate through those holes in the smooth muscle where the arteries come through. And by the way, this is also the reason why occasionally one of the more serious and dangerous complications of diverticulosis is rupture of those vessels that are coming through the same opening as that pseudo diverticulum, and that can lead to massive arterial bleeding. So the take-home message for people in the audience is colon diverticula are not true diverticula. They're pseudo diverticula coming through where those arteries come through the smooth muscle layer and only involve the most superficial layers of the colon.
And so involving arteries means people may find the blood in their stool.
That's right. That's right.
Because of that. Wow. So we do have a lot of patients that contact here at IFFGD about diverticulitis. And one of the common questions we get is about food and how do you eat if you have diverticulitis. And this is, I understand,
Yeah.
is a chronic condition, correct? I mean, it's something that you probably, if you were prone to have them, you will probably continue to have them. Is that
Yeah.
correct?
Well, yes and no. So diverticulitis is an acute event that will occur and either resolve on its own. And by the way, oftentimes it does resolve on its own without any treatment, or will require antibiotics.
Mhm.
But then things get better and patients usually do reasonably well for some period of time. They may very well have concurrent IBS, irritable bowel syndrome, that causes them to have abdominal pain and altered bowel habits, but that's not necessarily from the diverticulosis itself. So diverticulitis tends to cause acute intermittent symptoms. But you're right, there's a lot of confusion about diet, like what to do about your diet when you have a history of diverticulitis. In fact, for years and years and years, I think when John and I were
Yeah.
training, we were both taught, well, you need to avoid foods with seeds. You need to avoid nuts.
Right.
And it turns out that in large epidemiological studies done by a number of different investigators now, that's all false.
Yeah.
It turns out that those things are not contraindicated. You can eat seeds, you can eat nuts. They don't increase your risk of developing diverticulitis. John, I don't know if you have any other comments.
Yeah, no, I think it's really important to make that that statement so that people understand that, you know, we tend to tell people what they can eat all the time, and that restricts people's behavior too much, and that affects your quality of life. And I think it's really important for us to debunk a lot of these kind of diets that get thrown out and this misinformation in many ways. And you know, the other thing too that we should let the audience know, that just because you have diverticulosis doesn't mean that you're going to get bleeding or diverticulitis. It's rare, you know. I mean, less than 10-20% of people will have something that's related to their diverticulosis. So if you hear that diagnosis, it just lets the doctor know that you have that. And if you do develop belly pain or bleeding, that potentially the diverticulosis for bleeding or the diverticulitis for the pain can be at play.
You know, a good way to think about this, I always think about, like in your world, I always think about the analogy for a hiatal hernia, which is that there are a lot of people that have diverticulosis. There are a lot of people that have a hiatal hernia, but don't necessarily develop disease or symptoms as a consequence of those anatomical structural findings. So it's just important for people in the audience to realize that just because you have diverticulosis doesn't mean you're going to get diverticulitis or bleeding. Just because you have a hiatal hernia doesn't mean you're going to necessarily get severe acid reflux, Barrett's esophagus, or esophageal cancer.
Yep, exactly.
So are there any, so nuts and seeds are good to go, popcorn. Is there anything at all with diverticulitis that you would say, well, maybe talk to a dietitian about?
No, but here's the thing. Yes, but not in that sense. So what I would say is that one thing that people with diverticulitis should do is to consume a high fiber diet, because a high fiber diet will help to regulate one's bowel pattern. If you're constipated, it makes your stools a little bit more soft and makes you a little bit more regular. If you have loose stools, it tends to add a little bit more substance. And that's all good, because what we want to avoid is abrupt changes in pressure in the colon and straining. Okay, because straining tends to aggravate or make those diverticuli worse. So regulating the bowel habits, and the most natural, easiest way to do that is with fiber, is actually a pretty universal prescription for patients with diverticular disease.
Okay, fantastic. Well, that was very educational, and I hope that you found that very helpful as well. I know it's a question we receive here a lot at IFFGD from social media, and also through our email address and our phone line. So just to bring a note to that for those of you who are watching today, IFFGD is here for you as patients, and please feel free to email us at any time, not just today with the program, but anytime that you have questions. We have an email address that you can email. It's iffgd@iffgd.org. You can also communicate with us via social media, direct message on chat, with Facebook, Twitter, or any of our social media channels. We do monitor those regularly, or there's a contact form on our website. So please do never hesitate to reach out and ask questions if you need help with your digestive illness. So we are going to be moving to our first break of the day, and it's a break in a sense, except that we wanted to add a little something in case it's something, if you are looking for something to do during the break. And so over the next 2 days, we're going to be showing some videos during our breaks from doctors Brandon and Craven, and they're going to be demonstrating and talking about various techniques that are used with people with chronic illness. And these can be chronic illness of any kind. Today, obviously, we're focusing on the GI illness community. But these two wonderful therapists are going to be talking to you about different techniques they use with their patients to help them with their GI illness. And this first break, we're going to have Dr. Brandon, and she is going to introduce something called grounding techniques. We hope that you enjoy this break video, or if you choose to take a walk outside or grab something to eat or drink, just return back to us at 12:05, where we will resume our programming. Thank you.
Hey everybody, my name is Dr. Claire Brandon, and I'm a psychiatrist that focuses on chronically ill patients that have psychiatric issues as well. And my special focus is in gastrointestinal psychiatry. So I'm really excited to be here with everybody. I'm really looking forward to being at the conference myself. And I'm hoping that in our break times here, I can help guide you through some relaxation, some meditation, and some work on how to relax a little bit more, maybe get a little bit more interested in psychotherapy, psychiatry, and mental health as we go along, to consider it as part of your treatment team, your loved one's treatment team, or if you're a provider, to think about including mental health in your patient's care. So, I just want to give you a little bit of an overview here, what we're going to think about today. A lot of times my patients think that meditation feels very overwhelming. They don't like to do it. And I'm here to say today that in this 3-part series that we're going to do in our break times on mindfulness, meditation, and calming the autonomic nervous system, meditation doesn't have to be overwhelming or resemble what a Buddhist monk might do in silence and dedicate their lives to. In any GI disorder and any chronic medical condition, actually across the board, what we know is that our fight or flight response is at play at a higher rate than in the average person on any given moment. We're running away from the bear at all times, and it can feel like we're in this acute stage of inflammation and of irritability at all times. So today during breaks, we're going to learn a few techniques that I like to teach everybody, all my patients, my colleagues, my friends, to decrease the intensity of the stress response and to take back control of your autonomic nervous system. I'm going to be teaching you a few different techniques to use in situations where you might feel stressed. And I want you to stay tuned because, we're going to also talk about my favorite apps that might help you get a little bit more into the mix of this. So on our first break here, what we're going to be talking about is something called a grounding technique. And we're going to break it down for what is it, how does it help, and when should you use it? And there also is an app that I'm going to suggest for you guys to check out and try out. So first of all, what is a grounding technique? It's something that helps us to refocus our attention back on the present moment. So when our anxiety gets too much, when we feel stressed out, when our mind starts going 100 miles a minute, thinking about the worst case scenario, potentially, at the time of panic or other symptoms, we might just lose a little bit of track of our brain and bodies. And sometimes in gastrointestinal illness, that responds in the way that we're feeling urgency to run to the bathroom, might be feeling more pain. We're less feeling like we have the resilience to tolerate some of the symptoms that go on with our gastrointestinal illness. It might also get in the way of us taking our medications on time or doing things we know are helpful for us, like exercising, eating healthy, drinking water. So we want to use the grounding techniques to try to bring our awareness back and utilize our senses to shift and take back control of our bodies. So how does this actually help? when our brain jumps to pain, stress, sadness, and panic, we want to try to retrain the brain. We want to make this a practice response initially so that it turns into a habitual response. Therefore, our brain sort of clicks in every time we feel stressed. It might immediately go into utilizing grounding techniques after we've been practicing it really thoughtfully for a while. When would you use this? It's a useful technique basically anytime we feel stressed. You can use this in a really focused way and make a sort of bigger deal out of it, or you can figure out ways to do it in a quieter way. You may be in a meeting and you're feeling stressed out. You may be at a dinner or date and you're feeling stressed out, or in class. And it's important to try to practice this outside of the acute situations that might make you feel stressed, so that it is a little easier to know how to incorporate it and your brain jumps right to it. And you can employ it in a little bit more of a stressful moment. So, we're going to try out a grounding technique, and I'm going to talk you through it here. And think about, we're going to use our sense of smell, and we're going to use our sense of hearing, and we're also going to use our sense of seeing, right? So in the room with you, I want you to try to think about all the different things you can see that are the color blue. Blue can be a really calming color. It can help us refocus. It can help us feel energized. So, right now, just looking around, you may be able to see a window and look out at blue sky. Maybe there's blue somewhere on your computer. Maybe you have something blue on. I have a blue on my bracelet right now. So you're looking around and trying to find this. And as you go along, it seems a little simple at first, but you're actually really trying to distract your brain to look at different things than what your brain is jumping to and thinking about. Remember, running from the bear. Well, if we're looking for things that are specifically blue, our brain overrides and we say, oh, we must not be in distress right now. Another opportunity you can think about doing is listening for sounds that are in the environment. There might be ambient sounds. For instance, I have a sound machine outside of my office that I can hear. I might be actually listening just to music, right? I'm a violinist, so I really enjoy listening to string instruments. It sort of brings me back, brings a sense of calm. Maybe you have something like that as well that you can do and listen to. And you also might just want to look for a sound that generally you find calming. There are sounds on all kinds of apps that you can listen to, such as chimes or low ambient ringing sounds that can be really, really calming for you. And that would be a really great way to use your sense of hearing. And then finally, a sense of smell. So you might have things that are in your environment at all times that are really great to utilize for sense of smell. And I'll give you a few ideas for how to have a go pack of grounding exercises with you. They're pretty simple and straightforward because they're in our environment all the time. You might have coffee with you, actually smelling that coffee. A lot of times in perfume stores, they'll have coffee beans because it helps to redirect your sense of smell. Your smell gets confused when you smell too many perfumes. And we can use it in the same way for grounding exercises, actually. Your senses get a little confused and you bring it back to being calmer with smelling coffee beans or smelling your morning coffee. If you have a favorite hand lotion or a favorite perfume that you're wearing, you can do this really subtly, by brushing your hair, and you're also smelling your perfume on your wrist at the same time. Cologne, hand lotion, anything that works for you to be able to feel that sense of calm. There's also, you can buy lavender, put lavender in a little satchel, keep it in your desk and have it out, or smell it when you need it to calm down and feel refreshed. But all those things are really great ways to find a sense of smell and to reignite your senses so that you're feeling a lot calmer. Other things you can always use are sense of touch, right? That's a really strong sense for us. Using a stress ball can be really helpful, focusing on that, feeling the texture of the stress ball. touching different textures. So if you have something on your desk that helps you to feel, the metal sensation, or feeling some kind of a smoothness to a texture, all those things can really help you to ground yourself into that sense. And then finally, one thing that's really, really helpful, and I teach all my patients, is using temperature sensations, actually. So if you go into a meeting and you'll always get really nervous, drinking icy cold water can help you to calm that nervous system down. The vagus nerve, which is a cranial nerve that comes out of the back of our head, down our spine, it helps to target the heart and the lungs and our gut, actually. And when you're having icy cold water, that comes back into a rest and digest mode, right? Your brain and body get sort of shocked a little bit into that, and your body says, oh, okay, we're not running from the bear. A similar thing happens when you just touch something cold, or you have an ice pack in your hand or on your cheeks. And that can really help you to get a sense of calm, bring yourself back into the moment, and feel a little bit better in the situation. So, thinking about this, how do we what apps might we use if we're just starting off on this? There's a really great app called Clear Fear, and it has a lot of these techniques, especially sound, especially breathing, and you can look at that and help yourself sort of talk out of a panic attack. It's in a section called Get Immediate Help, and if you're in a panic attack, it will talk you through feeling your feet on the ground, feeling grounded in the moment, and really experiencing a sense of calm. You can do it over and over again, and you always have it in your pocket on your phone so that you can get focused, get grounded, and utilize that. No one will know what you're listening to. You can put in headphones, and it's a great app to have with you if you get stressed out in conferences, in meetings, in airplanes and things like that, or waiting for a doctor's appointment potentially, or a procedure. So that's the end of our first chat here about grounding exercises, ways to help yourself stay calm. Stay tuned in our next breaks, because we're going to be talking more about other techniques that we can utilize, including progressive muscle relaxation and using breathing to reset our autonomic nervous system. So looking forward to seeing you guys at the next break. Have an awesome conference, and I will see you soon.
Hello and welcome back. We hope you enjoyed that break session with Dr. Brandon on grounding techniques. Stay tuned throughout the program over the next 2 days, and we'll have more sessions on how different techniques can be used for chronic illnesses throughout the week. And so we are going to start our next session, but we did have one enduring question from this morning's session, John, and it was on your talk, and it was about PPIs and some confusion about, especially around testing with PPIs and when they work or when they don't work. Can you just maybe quickly circle back on that?
So proton pump inhibitors are very effective medicines at reducing acid in the stomach, and they're a treatment for reflux disease. But it's very important to remember that it doesn't work for everybody, because maybe it's not reflux related to acid. It could be non-acid reflux, volume reflux. So it's really important to realize that they're great medicines, but they're not perfect. And many times we will be doing physiologic testing to assess reflux. And the way we do the testing is really important, because you really want to focus on the question. So if the question is, do you actually have reflux? You wind up taking people off the proton pump inhibitor and studying them off the medicine, because then you're looking to see if they have abnormal acid exposure in the esophagus. So if the first question is, do you have reflux? That's how we answer it. We take you off the medicine, and then we look for the abnormal acid exposure. The other question that we tend to ask is, why isn't the PPI working? Why is that proton pump inhibitor not working? And in that case, we will study you on the medicine to see why the medicine is not working. Sometimes it's not effectively suppressing the acid, and you are getting more acid in the esophagus. But sometimes you're actually having non-acid reflux. The medicine may be controlling acid, but because you have a hernia or a sphincter that's open, you're having non-acid reflux. So it's really important to remember that you're trying to use the medicines and do the studies on medicines or off medicine to ask two specific questions.
Okay, well, that makes so much more sense. And we thank you for your question from the audience that came in this morning. apologize we didn't have time in the earlier break to be able to discuss that, but thank you, John, for clarifying that for us. And we will go ahead and move into our next session. John, you want to do it?
Yeah, so we're moving on, and the next session, session 2, which is our short bowel syndrome and intestinal failure, we're going to have a dual approach here with a gastroenterologist and a surgeon. Dr. Adam Stein is a gastroenterologist who actually focuses on small bowel disorders, small bowel absorption and nutrition. He's an expert in hyperal and nutrition through the vein. He's going to be complemented by our surgical colleague, Dr. Mercer, David Mercer, who's at the University of Nebraska, who really is a transplant surgeon, really went there to start an intestinal failure unit, intestinal transplant, and liver transplant unit, but really has become primarily focused in intestinal rehab. So once again, when the small bowel's not working. So we've got a great opportunity to hear from a gastroenterologist and a surgeon on these disorders. And the other section that's going to be really nice with this is that this is going to be complemented by 2 patient stories. So we have a patient perspective on short bowel syndrome. Swapna Kakani is going to talk about her life experience with this and how it's impacted her. And then we're going to look at someone who's had to deal with intestinal failure, and that's going to be John Mahalachak. And he's going to talk to us about living with intestinal failure. So a really nice session where we go from the physician perspective to the patient perspective.
Thank you, John. And just before we start that, I will remind you that some images that are presented in these presentations may be graphic. We are hearing from a surgeon, and there will be images during Dr. Mercer's presentation that are during a surgical operation. And so those are very graphic images of the human body under surgery. So that's just a warning for those in the audience who might be sensitive to that sort of thing, that Dr. Mercer's talk will have some graphic images. But we will go ahead and start this, this panel discussion and panel presentation with these 4 speakers.
Thank you very much for allowing me to talk to you today about short bowel syndrome and intestinal failure. Thank you to IFFGD for inviting me. This is going to be just a broad overview of intestinal failure, which includes short bowel syndrome. The biggest thing to know about intestinal failure and short bowel syndrome is that the intestine is a very unique organ. Different parts are responsible for doing different things. And depending on which part of the intestine is potentially impacted will depend on what sort of problems you might have associated with the intestine or short bowel syndrome. And just to keep in mind, a general overview of the digestive system is as things travel through the GI system, they go to the esophagus, stomach, duodenum, which is part of the small intestine, jejunum again, which is part of the small intestine, and ileum, part of the small intestine as well. And then they finally go into the colon. So this is an overview or a map of the intestinal system. And it shows what areas of the small intestine in particular are responsible for absorbing and maintaining your health. So as I eat something, it travels through the esophagus, through the stomach, into the small intestine. The duodenum is the first part. That's primarily responsible for absorbing heavy metals, things such as iron, copper, magnesium. Then it travels down into the jejunum, where sugars and proteins are starting to be absorbed, and then finally reaches the ileum, where things like fat and fat-soluble vitamins are absorbed. The very last part of the small intestine, called the terminal ileum, has a very unique role in absorption of a certain vitamin called vitamin B12, bile, and even more fat. The stomach and the colon don't really absorb a whole lot. The colon mainly absorbs certain fats, but mostly water, and water is absorbed throughout. So intestinal failure is a broad umbrella term, meaning the intestine is not absorbing what it needs to in order for you to maintain your health. Short bowel syndrome is a term under intestinal failure that means part of the intestine has been removed. And part of that intestine that has been removed causes you to have nutrition issues. And just like this real estate map shows, what part of the intestine is, it really depends what part of the intestine is removed in terms of what sort of health issues you might have. So intestinal failure, by definition, is when the body is unable to absorb enough fluid or nutrients to stay healthy. Many different causes of intestinal failure, short bowel syndrome being one of them. But really, when you talk about intestinal failure, there's two groups of things that could potentially happen. One is having a medical condition that leads to problems with absorption of either fluid and or nutrients. And then the other is a surgical condition where surgery leads you to have these issues. Under the medical condition umbrella, there are many things that can cause the intestine to fail. I've listed several of them here. There's more in your packet, but in general, there's either anatomical issues, flow issues, or issues with the tissue itself. So anatomically, you can have blockages or obstruction. Things like tumors can block flow through the intestine, scarred tissue. You can have congenital disorders like Hirschsprung's disease, so on and so forth. Cancer beyond tumors can also cause issues with intestinal absorption. If you've had radiation, sometimes radiation can damage the intestine. Other cancers can cause proteins to build up in the intestine, such as amyloid, which block nutrients and fluids from being absorbed into the intestine. Beyond that, you can have issues with flow, or what we call motility through the GI system. People whose stomachs don't work, that's called gastroparesis, they can eat, but the food doesn't travel past their stomach, so they get problems with pain and things like that. You can't maintain your nutrition like that, even though the rest of your intestine works. You can't get food through the stomach to get to the rest of the intestine where things get absorbed. There's other issues with pseudo-obstruction. People with systemic sclerosis, which was formerly called scleroderma, and things like that can also have flow or motility issues, which cause you not to be able to take in enough fluid or nutrients. When you have issues with the actual tissue itself, like inflammation caused by Crohn's disease or problems with blood flow to the tissue itself, you can get food and fluid to the areas of the intestine that they need to go, but the tissue itself is so damaged that it can't grab onto the nutrients and then absorb it into the body. So all these things are medical conditions leading to problems getting enough fluid or nutrients into the body. Now, surgery is a unique thing in terms of it causing problems with fluid and nutrient absorption. Typically, the causes of intestinal failure from surgery are due to removing extensive portions of the small intestine and or stomach. So when a surgeon goes in and removes parts of the intestine for whatever reason, could be Crohn's disease, could be cancer, could be ischemia, problems with blood flow, you're left with a shorter area of intestine that's responsible for absorbing, and that absorptive capacity, or that area of the intestine that is left behind, just really isn't big enough in order to absorb as much fluid or nutrition as it needs to. Put it another way, your small intestine, which again is responsible for most of the absorption, is about 15 or 20 feet long. That's a lot of surface area to absorb a bunch of stuff. And if you sliced open the small intestine, laid it out flat, all these peaks and valleys, which are called villi in the small intestine, you laid those flat as well, it would be somewhere in between the size of a tennis court to a football field. Now, if you start removing big chunks of that, you can imagine that all of that surface that's normally used to absorb fluid and nutrients is taken away. And when food and liquids flow through the intestine, you might not be able to absorb as much as you need to in order to survive. And that's called short bowel syndrome. The other cause surgically of intestinal failure is when somebody has an ostomy, or part of the small intestine or a colon is brought out to the skin, and instead of emptying when you sit down and go to the bathroom to have a bowel movement, it empties into a bag on the belly. That's fine in and of itself, but sometimes people can empty too much. That bag or that ostomy leads to rapid flow of contents through the intestinal system, and it flows through so rapidly you just can't absorb enough. So that's called high ostomy output. That's another reason people could have intestinal failure. So what do you do about it? When you have intestinal failure, things such as short bowel syndrome or the other things that we just talked about, how do you treat that? How do you fix that? The main thing you need, in my opinion, is a strong medical team around you. This diagram came from an article published 7 or 8 years ago that goes into detail about what sort of team you need if you have intestinal failure. You need somebody who's going to be your quarterback, who's going to oversee your medical treatment. In this example, this is a gastroenterologist, but it could be a surgeon, it could be a primary care provider, somebody else, but somebody who's going to oversee everything and make sure that you get the treatment that you need. Everybody with intestinal failure is a little bit different. There's no two people alike who have intestinal failure, mainly because there's so many different things that come into play when you have intestinal failure. So when you have intestinal failure, you need a team around you, and you need a multidisciplinary team, not only your quarterback, but also people like dietitians, pharmacists, radiologists. Sometimes you need a nurse or an infectious disease provider, other people who can help oversee your care and contribute when bumps in the road happen. Because when people have intestinal failure, bumps in the road do happen, and that's okay. But you need an individualized treatment plan, and you need a medical team surrounding you. So this diagram is a useful tool to look at and show your team just to make sure you have everybody you need. So with your team surrounding you, and that's easier said than done, but with putting together a team, there are a number of different steps that we go through in order to make sure people with intestinal failure get the treatment that they need in order to maintain their nutrition and hydration, their health. Step one, first thing is hydration. You need to stay hydrated. Hydration is the thing that is going to injure you or potentially kill you the fastest. If you're dehydrated, you're going to have problems with your organs, mainly kidneys, but other organs can be involved. And if you are dehydrated for long enough, your kidneys can shut down, and that can be significant to your health and could even cause death. So hydration is the most important treatment to think about. So things like drinking enough fluids, and the fluids that we tell people to drink are non-caffeinated, without artificial sweeteners or things like that. Caffeine is a diuretic. Artificial sweeteners move through the system very quickly. And we ask people to eat first and then drink. Your dietitian, your gastroenterologist, primary care, they can design a drink menu for you, which includes both liquids as well as different amounts of fluid that you need to drink every day. Step two is eating. Not everybody can eat by mouth. Some people have tubes, some people get fluids and nutrition through an IV, things like that. But you need to maintain your nutrition. After your hydration is taken care of, nutrition is next. You need, if you can eat small, frequent meals, snacks, those are great because you don't want to overwhelm the system all at once. You want to keep the system going at a regular rate. If you have a feeding tube, that's certainly fine. You need to design a feeding tube plan with your dietitian or physician. And then finally, if you need IV nutrition, that's called TPN, we manage that as well. The third thing in terms of treatment that you need to have in mind is medication. There are a ton of different medications that we can use to help with absorption, fluid balance, things like that. People use acid blockers, not for heartburn necessarily, but to reduce the amount of fluid that your stomach and small intestine produces. We use medications to slow down the intestine, things like loperamide, difenoxylate, opium tincture, and codeine. That's to slow things down so that the intestine has the ability to absorb better. The slower things move, the more time there is to absorb. And then finally, we have hormones that we can use, things like octreotide or teduglutide. Those not only help with absorption, but they can actually increase the number of cells that are available to absorb things. They don't necessarily elongate the intestine, but they cause all those cells to grow and divide, which allow us to absorb and pick up nutrients. So this is just a general overview of intestinal failure. Please look at your packet for more information and ask questions as things come up in the multidisciplinary session. Thank you very much.
Hi, everyone. I'm Dave Mercer. I'm a professor of surgery at the University of Nebraska Medical Center, and I direct our intestinal rehabilitation program. I'm one of the transplant surgeons, but I must say I spend most of my life trying to avoid doing transplant surgery wherever is possible by helping short bowel patients to become TPN independent wherever they can. So they've asked me to give a little talk today on surgery and short bowel syndrome, and it should build off of the talk that you had from Adam. And so I won't go into too much detail about short bowel syndrome and what it is. And really, we'll talk more philosophically about surgery, because in a short 10-minute talk, I can really just introduce the basics and some of the simple concepts. I just have a few disclosures. I'm fairly involved in all of the clinical trials in our field working on growth factors. None of the growth factors really have an impact on my talk today, but sometimes when I'm talking about things that get me excited and about where the future of the field is, I could allude to some of them. And so just to let you all know that that's the work that I'm doing. Okay, so I told you this was going to be philosophy, and that's what a lot of it is going to be. So here's my first sort of philosophical point about surgery and how surgery relates to short bowel syndrome. So there's many different surgeons who are involved in the creation of patients with short bowel syndrome, but I would say there's very few people who should actually be involved in treating it. So what do I mean? Well, for anyone who's a patient out there watching this, you all would have had a surgeon, whether it was when you were a child or it's been a series of surgeries as you're an adult, or perhaps some more singular catastrophic event that led to the loss of a lot of your absorptive surface. So that's going to be whatever surgeon happened to be around or was treating you at the time that the event occurred. For those of you that are medical professionals, these are well dispersed across the whole population. Now, the thing is that people that are forced to deal with these emergent situations, or who are doing the different operations where perhaps bowel gets removed, are not necessarily the same set of people who should be dealing with the consequences once the patients are already short. The surgery becomes pretty specialized. And I can tell you one thing about surgeons being one is we kind of have sometimes the arrogance of the idea that we can really look after everything. And, you know, we all like to think that we're good surgeons and we do good technical work, and I'm sure most of us do. But the issues that come in treating patients with short bowel are very, very specific, and the details really do matter. And I think that the surgeons need to be intimately involved with the team that are looking after you. In our program, I'm there with every patient along with my GI colleague. It's going to be different in different places around the country, but what you really don't want is sort of the surgeon du jour, you know, somebody who's just happens to be the person who's around that day. Because while they may be able to perform the simple mechanics of the operation, they don't necessarily have the investment in the decision process that's involved in things. And I'll touch on that a little bit later on. This is a great big figure that I put together for a chapter in a textbook. And most of it doesn't matter to any of you. I just wanted to make the simple point that if something happens and you lose absorptive surface, so that means a bunch of intestine gets lost. Well, what do? Initially, you stabilize that patient. You start the parenteral nutrition, start them on their TPN if that's what they need. And then you really want to look and say, okay, are they truly short bowel? Did we lose quite a bit? Maybe we're at 50% where we should be or something like that. And what I'm going to say is very simply, almost every one of those patients should be considered for transfer to a specialized intestinal rehab center. Now, that doesn't mean everyone in the country has to come to Nebraska. That would be great. You're all welcome, but certainly there's centers of excellence at different spots around the country. They are relatively few and far between in the adult population, a little more well-developed in the pediatric population, but I think this is really important. It doesn't mean that everything has to be done in a rehab center. It doesn't mean you have to give up a relationship with a surgeon who you really, really trust and you've been with for a long, long time. But you probably need a little bit of input. That person could end up doing your surgeries, but it helps to get some input from someone who's seeing a lot of volume, someone who's looking at all of these issues, especially as you get into the more esoteric and rare operations. Okay, so let's talk a little bit about what I believe about surgery and things that I think are important. One of the most important things is early restoration of continuity. So what does that mean? Fancy words, it says put everything back together again as soon as you can. Whatever you have on the inside, to the extent that it's possible, we should try to use that. We should try to use that to help you absorb calories, help you absorb fluid and electrolytes. So we're big believers in really aggressively trying to get back to the operating theater as quickly as we can and get on with things. Generally, I want to do that as soon as I think it's safe to do. So when patients are sent to us from other institutions, which is fairly common, I usually want to be around 2 to 3 months after the last time someone was in their belly. That lets the dust settle for us surgically, the adhesions settle down, the inflammation isn't so bad, and we can usually do things. There are occasions when I'll push that back a little bit, but generally that 2 to 3 month range is about where I am with most of my patients. I can tell you guys, when I first started doing this, 15 or 16 years ago, we weren't as good at managing. We didn't have the same technology we have to manage TPN. We didn't have some of the surgical tools that we have, and we didn't have growth factors. We didn't have a whole bunch of different things. And so we really had to get every bit of intestine. It was important to try to get, as much as we could. And while that is still important, I must say our ability to get patients off of TPN with shorter and shorter lengths of intestine has allowed us to have a little more freedom to say, gee, that piece of bowel isn't that good, and we're not going to use that. And instead, we're going to focus on this 60 centimeters of really good intestine. Because, almost every patient we've got who's got 40, 50, 60 centimeters of small intestine is going to ultimately come off of TPN. Depends a little bit on how much colon you have. But so it's just, as the field has evolved, our decision making has evolved. My final point here is I believe in restoration of continuity. I believe in getting everything hooked up, but there are times when having an ostomy is your best option. And what this tends to be is, if you're the circumstance of you're the patient who has fairly short bowel, and your bowel movements are so intrusive into your day that you just can't, you can't get out of the house, you can't get out of the bathroom. Sometimes you're better off having an ostomy as far along in the bowel as you can, so that you can have the freedom to not be in the bathroom all the time, to not be having accidents, to be able to go and shop, go to a movie, go out for dinner. And so I think that's something that, again, you build up a relationship between a patient and a surgeon and a team, and you talk about that for the individual. Now, here I've been talking to you about surgery, but this is probably the most important point as a surgeon, which is avoid surgery whenever you can. I always tell our patients the best surgery is no surgery. That's what you want if you can avoid it. So we try to do everything we can to not operate. And what does that mean? Well, we may want to change diet. If you're an adult, a lot of times people come to us and they're eating the wrong things. And we say, here's the things that would be better for you to eat. We change your eating pattern. We're all used to eating 3 square meals a day, but if you have short bowel syndrome, 3 square meals a day isn't the best pattern for you. You should probably be grazing all day, eating 6 meals or 7 meals, each one just a small little nibble. Nobody wants to spend 10 hours a day sitting at a table eating food, but you can have little snacks all over the place and just grab them here and there as you go. We may need, in some cases, things to make your intestines work better. In some cases, things to slow them down, so anti-motility agents. We may need antibiotics at times, although I would argue to most patients, if you're needing antibiotics to improve your function on the inside, there's often something that needs to be fixed. Because if our intestines are working forward and flushing forward the way they should naturally, generally, you're going to be able to function without antibiotics. If you've been on antibiotics chronically and you stop them, you'll feel turbulent because all of your flora are jumping all over the place because you just removed the antibiotics, and people go, oh my gosh, I need them. I have to be back on them. And they become a little bit like a narcotic. You have this antibiotic withdrawal. If you can just ride that out and get through a few weeks, it settles down and you can come off the antibiotics. And occasionally we need probiotics. But the point of this is, there are occasions when I see someone with a fistula where I know surgery has to be done right away. But where it's not so straightforward, I'll try to do everything else possible before we go to surgery. But sometimes you get stuck. Even the best of teams just get jammed up. So that's where you come in as a surgeon. So let's talk about some of the common, just again, large areas of things that might come up. The first picture represents obstructions, and the second picture represents dilations. So obstructions. Well, obstructions can be a little more common in the course of your short bowel syndrome, but they, believe it or not, bad obstructions that don't relieve tend to be more rare over time. Why is that? Well, the big obstructions where you have to go emergently to the operating room because something really bad has happened require usually the ability of things to twist or turn on the inside, where they can get kinked and blocked completely. But as your bowel gets a little more adhesed on the inside, that freedom of movement is limited. So you might get obstructive symptoms. And these are the kinds of obstructions where you get the crampy abdominal pain, stuff's not going through very well, you need a nasogastric tube, but it does tend to settle down. And 90% of the time, that's going to get better over time. And you want to avoid surgery Because if you're going in to treat adhesions, we know those adhesions are going to come back. And so while sometimes you have to do that, and I've done that on many occasions, if you can avoid it, you want to avoid it. Now, dilation. Dilation is a phenomenon that occurs in short bowel patients where the bowel gets stretched up and it gets bigger. And we're not always sure why it occurs. It can occur because the bowel is blocked. But really what we're talking about here is dilation that occurs where there's not an obvious blockage. So when the bowel gets dilated, imagine a thin tube that gets really, really stretched up. Well, that tube wants to squeeze forward and push food out, but it can't. It squeezes, but the contractions don't allow for a propulsive motion. And so then there's a series of operations that we can do called enteroplasties that take advantage of the dilation to try to correct it and improve the way things work. This next image kind of shows you demonstrably what's the difference between if your bowel is dilated or not dilated. If you think about a big pipe and water is flowing through the big pipe, well, for all of the volume of water coming out of that pipe, a relatively small percentage of the water is touching the sides of the pipe. And touching the sides of the pipe is absorbing. So if it doesn't touch the sides, you can't absorb it. Most of it shoots through the middle and you have this big forceful outflow of fluid. That's diarrhea. So that's your bowel movements, and that's losing the calories that you need to grow and develop or to stay healthy and come off TPN. If we can take that big tube and turn it into a smaller pipe, a much higher percentage of the fluid on the inside is touching the sides that you can absorb. And so your output goes down. And so a lot of the times that's our goal, is to reduce the size down and restore that volume to surface area ratio. One of the common ways we do this is an operation called a step procedure. So if you're dilated and you have this big dilated tube, we can use a stapling device that seals the bowel and splits it into a V, as you can see in the sort of the center image and then in the rightmost image. And what that does is it takes this big dilated tube and it turns it into a much more narrow zigzag tube. And that restores the function beautifully. It actually alleviates most of the dilation symptoms. This can be done fairly simply. It's a fairly straightforward operation to do, but there's a lot of detail. And so to do it properly, you really need someone who's doing a lot of these. And I will tell you, it's a fair question to ask that surgeon if someone's telling you about this. Well, how many have you done? Because if they're telling you the truth, most of them have probably only done it once or twice. Whereas if you're in a big center, you're in a place like ours, we've done it 150 times. And so you want to try to get to the centers where people have got more expertise in these things, because the devil is in the details. This is an alternate way of approaching dilation. It tends to be used maybe sometimes more in adults or when patients have a longer length of intestine. It's called a longitudinal excisional tapering. So the idea here is if you have a great big tube of intestine, we can align those staples in a different direction, sort of parallel to the length of the bowel. And we can work along trimming the excess off, and in fact, getting rid of the outside of the bowel and leaving us, like in this picture here, with a much more narrow tube of bowel that's restored down to its normal size. So now suddenly you go from big dilated intestine that isn't squeezing, gassy, miserable, bacterial overgrowth, all that kind of stuff, to nice, small, narrow bowel that can squeeze beautifully. Now, when you do a tapering enteroplasty like this, you can see that curtain of intestine on the outside that's all removed, and that's just going to be discarded. So you have lost absorptive surface by doing this. But the reality is, if that surface wasn't really working for you in the first place, losing it doesn't really change very much for you. And in fact, when you do an operation like in the picture that you can see here, the fourth image, you end up with much better absorptive function, even though you have less intestine. So coming towards the end of just this very brief introduction to the role of surgery, and I'll tell you, we'll have the question and answer session coming up, and that'll give us a really good chance to go into specific issues with people. But I would say, from a patient perspective or the perspective of a team, when you're considering a short bowel patient, simplistically, I would say if you're not moving forwards, then you're going backwards. What do I mean? Well, I mean that every week really, but every time you meet with your providers, and ideally much more frequently, you should be saying, what can I do to make my life just a little bit better? That could be a little less TPN volume, so I don't have to pee so much at night, or less frequent lab draws, maybe changing my hours, because 14 hours intrudes on my day, but if I could get to 10 hours, I could do it while I'm sleeping and it would just be simpler. So, and then of course, trying to come down off of TPN. So trying to cut my calories, cut my volume, become more enterally independent. I would say from a patient perspective, if you're not making progress, if your needs aren't being addressed, if you're not doing something to make your life better each time, you're probably going backwards. And you need to sit down with your team and you need to say, hey, yeah, what's going on? What's our goal? What are we trying to do here? Sometimes people can almost get forgotten about, and you're just on TPN and you're used to it, the team's used to it, and suddenly 3 years has passed. And in some circumstances, that's not the end of the world. Maybe you just want a break. You don't want to be working with stuff all the time. But I think in the grand scheme of things, we really want to be looking at what can we do to make life better all the time. So I guess I like to think, and I share with our team all the time, you know, guys, if we're not moving forwards, we're going backwards. So what are we going to do better? I believe in transferring early to specialized centers. I think you should. It's never going to hurt you to get more information. Anybody who doesn't want you to get another opinion, you have to really wonder about that person in the first place. Because I'm as specialized at this as anybody in the country. And if somebody said, look, I feel like we're struggling and I want to go see somebody else, I would immediately give them a list of 10 people who I trust, who I value their opinion. I'd say, look, let's go see what they got. Maybe they're thinking of something I'm not thinking of. But I think getting people involved in helping you is a really important part to your care. I believe in restoring continuity early, and we talked about that. I think you should avoid surgery whenever it's possible, but you should not hesitate when it's needed. And I do think sometimes surgeons who are frightened of the inside of an abdomen because it's hostile will sometimes delay surgery. And I often get poor patients coming here with fistulas, for example, who've been, you know, with this fistula for 2 or 3 years, sometimes in the hospital in long-term care because they can't get out, can't manage. And all they really needed was, you know, sort of tightening up your belt, getting a little brave and fixing it. And so I think you can't hesitate when it's time to do something. And maybe experience in doing a lot of these cases helps you to not be hesitant. Knowing when or when not to operate is really the most important job of a surgeon. It's the technical elements are important, but it's the deciding up to when is the right time to do it. It's really the most important thing for the surgeon, for the patient, and for the ultimate success of that relationship. So everyone, that's the end of my introduction to the role of surgery in short bowel syndrome. Thanks very much for your attention.
Hi, my name is Swapna Kakani. Thank you, IFFGD, for inviting me and having me speak. I will be sharing a glimpse of my 30+ year journey with short bowel syndrome. I was born with a congenital defect of the small intestine called multiple intestinal atresia in 1989, 31 years ago. In 1989, the prognosis to live long with short bowel syndrome and on IV nutrition was unknown. It was actually the surgeon who told us, take one day at a time. But more importantly, my parents were the ones who said, we are going to appreciate each day alive and healthy with this new baby girl. And together as a family, we are going to fight for every milestone, regardless if it comes or not. This is going to be our new normal. I want to say now a kind of a disclaimer that because I was born in 1989, it is important to know that this is just one example or one journey of living with short bowel syndrome long term. And the field, the treatments, the advancements in IV nutrition and medical care for short bowel syndrome has changed drastically in the last 3 decades. The decisions that we have made as a family may be different than the decisions other families may make or even have the options to make today. From day 2 of life, I became dependent on nutrition from an IV, TPN, total parenteral nutrition. I received TPN anywhere from as little as 3 nights a week to 7 nights a week. The infusions could last as little as 8 hours to as long as 16 hours. I would get most, if not all, my calories from TPN, as well as my feeding tube, my stomach. I received nutrition from a gastrostomy tube called enteral nutrition. I have received enteral nutrition 16 hours a day, every day for my first 20 years of life. And TPN, I have received for the last 28 years and counting. There have been only 3 years as a child that I did not receive TPN, but I did not grow or gain weight. I was told, go eat, please eat anything, whatever you would like. And in the 1990s, we did not know the diets we now recommend for short bowel syndrome and intestinal failure. It was really for the purpose of getting familiar with food. But although I could eat, I was not very interested in eating. And I ate like a bird. I would eat the same meal, drink the same drink for hours at a time. My favorite food, potato chips. The salt I would crave because of the amount of output I was losing. So this is a perfect example of who I was as a child, headbands and all. It's a glimpse of me in the wild, eating potato chips and getting fed with my hot pink nutritional backpack. As a family, we were going to redefine what normal meant for living with a chronic disease, living with short bowel syndrome. No one had defined that, and we were going to beat expectations. I went to eat my feeding tube out, regardless if I was eating or not, to enjoy the party first and foremost. Participate in cultural activities, having to hide the feeding tube underneath my dresses. But I participated and danced just like my peers. And then as a high schooler, did a lot of civic service activities. One example was Habitat for Humanity, of course, the one activity that is in the heat and requires physical stamina, but I love doing it with my backpack on. In my 31 years, I've had 31 central lines. Of those 31 central lines, 25 have been infected by bacterial or fungal infections. But one of my most favorite numbers is that I've had the current central line I have now for the last 5 years and counting. We unfortunately had to repair it a couple months ago, but thankfully we were able to repair it and not replace it. So 5 years and counting. And my most favorite number is that it's been 14 years and counting since my last central line infection. Going to school, I went to school just like my peers, but I went with 2 backpacks. One was my nutritional backpack and 2 was my academic backpack. I went to school like the true turtle, and I was pertinent to not use my backpack as a weight, as a burden, but rather as a driving force to move forward, to educate my peers, and to understand what it is to live life with IVs and tubes. It was my normal to go to school with IVs and tubes. In the middle of college, I had one more abdominal surgery with the hopes of this one hopefully being the last, but this one being the one that lets me be free of IV and tubes, or at minimum be free of TPN. Unfortunately, it resulted in complications that then resulted in more surgery, more complications at centers all across the United States. For the first time, I was getting adult care. I had no transition of care. Instead, I was referred from a pediatric center to an adult center, and that was it. My parents and I put my care in our own hands. The complications I developed were called fistulas. I had fistulas between my skin, my small intestine, my large intestine, and also my bladder. I was urinating food and bile, and the same food and bile would drain spontaneously on my skin. I was raw both inside and outside. I was struggling to find motivation to move forward. I had to stop college and move back home. It was at this time that our family learned the hard way, the importance of right care at the right place at the right time. We traveled to subspecialty centers across the country discussing my next option. I made the difficult decision to remove my small intestine and large intestine, which I fought for my first 24 years of life, to then only be dependent even more on TPN and IV fluids 24/7, no food by mouth, and all my GI contents drained into a drainage bag that I held on my leg. But this didn't stop us. I was going to continue to defy the meaning of disease. The picture on the left, we went to Big Sur in California, rode the Pacific Coast Highway with my backpack on. You would never know in the picture on the left that I was receiving TPN or IV fluids 24/7, and I had a drainage bag on my leg and I could not eat solid food. We ended that trip at a family wedding on the right. And in this period of time, I graduated from college. But the next step was soon, and that was transplant. I made the difficult decision to have a small intestine organ transplant. In June of 2014, I was on the waiting list only for 15 days. Since the transplant, I've had highs I've only dreamed of since I was a child. I no longer have a feeding tube. I can eat to my heart's desire with some limitations. And the best part is I don't have pain before, during, or after eating the meal, something I was very accustomed to growing up. But with the highs comes lows. Transplant is not a cure. It can be an exchange of hardships. I've had bacterial and fungal infections requiring more surgery. I've had hip replacements due to a bone disease. I now have a permanent stent in my right ureter, and I have had to get back on TPN to maintain weight and hydration. This is what today looks like. A lot of times chronic disease can be overwhelming. But what my dad always says is, Swamna, you cannot live just for today, because he knows, a lot of people in my family know that I run 100 miles per minute, but rather you have to live for tomorrow. So with chronic disease, a lot of what we do is continuing to show up at doctor's appointments, show up and having to make hard decisions, coordinating care, managing our symptoms daily, weekly, monthly. It has, because of the 30 years of doing this, I've learned that this part of our lives cannot be sacrificed, and respecting the process and the journey allows us to thrive not only for today, but really more so for tomorrow. 65 surgeries in 31 years has taught me that, one, we have to speak up as individuals with chronic diseases, with chronic rare diseases. Your view is important. It is unique. It is okay to be the educator, the trainer, to teach others what it is like to live with the disease, teach decision makers, doctors, and more. We are our best advocates. I wish I was told that when I was younger. Next is knowing that you are not alone. Find others. My life has been changed drastically by finding fellow gutsy gals. We have met each other through Facebook, Instagram, social media, as well as conferences. We now call ourselves gutsy gals with good for nothing guts. It is the text between these women and more, and phone calls, that drive me to continue fighting every day, because I know that someone else gets it. And finally, respecting the big picture. This is what drives me to continue to fight and be an advocate and fight for the milestones we dream of, regardless if they come. Because it is understanding how far we have come to then appreciate how far we will go. Thank you.
Hi, everyone. My name is John Mahalchek, and I'm here to share my perspective on living with chronic disease and intestinal failure. Just before I start, I wanted to say a big thank you to IFFGD for this invitation, not only to share my story with you guys here today, but also for many other opportunities they've given me over the past year or so. So today I'm going to kind of briefly just in one slide here, just discuss intestinal failure. And then the bulk of the time, I'm going to share with you my journey, some tips and tricks I've learned along the way. And then at the very end, I just have a challenge I'd like to pose for everybody. So intestinal failure occurs when your body is not able to properly absorb nutrition and fluids when you take them in orally. And because of that, patients then have to rely on intravenous nutrition, which is called TPN, or tube feeds, which is called enteral nutrition. That, along with the TPN, sometimes you also require additional IV fluids as well. This can happen for many different reasons. Common ones, short bowel syndrome, inflammatory bowel disease, among others. And this is kind of where my story becomes a little bit different. A lot of these disorders are things you're born with, but for me, as you'll see in a second, that wasn't the case. So as I would say, most GI stories are complex, and mine is no different. It seems to me, talking with other folks in the community, that these very rarely come in singles. Once you get one GI disorder, it's not uncommon to end up with multiple. So my story starts in the freshman year of college. I was getting ready for finals, and I had an episode of severe abdominal pain with some nausea and vomiting. Not quite sure what was going on, went to get checked out, and it turned out that my gallbladder had to be removed. After that, I ended up getting recurrent episodes of acute pancreatitis. So my pancreas enzymes would go very high. I'd end up in the hospital without withholding food to make the pancreatitis go away, and then getting treated with medications and fluids. This was happening for a while, and as I said, when I would be in the hospital, I would end up on enteral nutrition or tube feeds to kind of give my pancreas a bit of a rest. This progressed, and I ended up having a total pancreatectomy with auto islet transplant. So with this surgery, what they do is they go in, they take out your pancreas, they take the islet cells from your pancreas and they put them into your liver. So your liver then does double duty. It works as a liver, but it also has those islet cells in it to prevent you from becoming a brittle diabetic. When they do this, they also do a Roux-en-Y gastric bypass procedure where they adjust the exiting of your stomach, and then they take out portions of your small bowel as well. When that happened is when I was first really diagnosed with malnutrition. And as a result of the surgical anatomy changes and some other things going on at the time, I wasn't absorbing anything. So I ended up being placed on total parenteral nutrition, or TPN. So I have a port that's in my chest, and I was getting all of my nutrition as well as IV fluids via that port. I also, as a result of the surgery, ended up with gastroparesis. So my stomach wasn't emptying properly. And even when it did empty, things were not moving through sometimes at all, but definitely not at a normal rate. Because of that, I had a feeding tube placed as well that would allow me to empty my stomach so that I wouldn't vomit, and then to eventually try to switch over to enteral nutrition so that I could get off some of the TPN. So as I mentioned, that's what happened right after the gastroparesis. And then this led kind of to multiple gastric revision surgeries, my most recent just being back in March. So now I have, they've taken out like the bottom third of my stomach. as well as a good portion of my small intestine. And I have, aside from the port that I mentioned earlier that I use for fluid and medication, I also have two feeding tubes now. So I have one that's just in my stomach, and that helps keep my stomach empty due to some of those gastroparesis syndrome symptoms. And then I have the J tube, which goes into my intestine, which, due to the malnutrition and the issues with my the intestinal failure, I can get enteral nutrition when I'm able to absorb. And thankfully, for the past few years, I've been able to stay off of the TP and the IV nutrition to keep my gut working, but it's always a possibility that we may have to go back or forth. My nutrition markers are monitored very closely so that we can make sure I'm getting the adequate nutrition that I need. So with that, so the IV fluids run all night, and then the tube feeds run all day. So I'm always hooked up to my backpack, just making sure that I'm getting all the nutrition and everything I need. So that's kind of my journey. So through this journey, I have learned quite a bit. And those are some things I'd like to share with you now. And probably the biggest thing I've picked up on is that treating chronic illnesses requires a team approach. It's not something you can do by yourself. And every team requires a leader. So after establishing my team and switching to something at my hospital called the Enhanced Care Program, my hospitalizations dropped to less than 2 per year. This is something that happened recently. I've only been in this program for about 2 years, but it's been absolutely remarkable. As you'll see in a second here when I show you who's all on my team, it's a multidisciplinary care setup, which means I have different healthcare providers from across the spectrum who are all working together to help keep me healthy. And I was lucky enough to live in a city here in Pittsburgh that has a large academic center. So thankfully, I did not have to travel across the country to put my team together, which I understand is something that happens quite a bit in this area. Having said that, I did make one trip to get a second opinion from a physician in Nebraska who I met at a conference. But I do have to say I've been very lucky that I've been able to stay at home during all of the care that I've needed. So, like I said, my team's multidisciplinary. It has a lot of people on it. So I have a primary care physician, as I mentioned earlier, that we call that the enhanced care physician. And she's my leader. She's responsible for my day-to-day care and kind of keeping everybody else on the same page. I also have a GI nutritionist who makes sure my nutrition markers are okay, handles any problems that would occur with my central line or my feeding tubes. I have a dietitian, again, who helps me with the tube feeds and different additives and things that I would need for my nutrition. A pharmacist to keep all my medications straight. A home infusion company to help make sure I have all the supplies I need at home to keep me out of the hospital. I also have a mental health therapist, and I think this is understated. I just want to spend a second on this. I have become a firm believer throughout my experience here that you cannot have good physical health without good mental health. Did not realize this at the time, but looking back, as I was getting sick, I also was experiencing some severe cases of depression. So working with a mental health therapist has really made a huge difference in my care. And I like to share this with everybody because I do know that there is stigmas attached to mental health. And as my therapist tells me all the time, you know, if you're somebody who's going through a severe chronic illness and you're not a little bit depressed, she would be a little bit more worried about you. So I do just like to share that with everybody as well. I also have a surgeon on my team. As I said, I've had multiple gastric revision surgeries. So he's able to help with that, and he's able to help with my feeding tubes as needed. I have an endocrinologist. This is due to that total pancreatectomy I had. So they help keep my sugars in balance for me. I also have a pain management physician on board and then a physical therapist. So there is one person I left off of my team, and I did that on purpose, and it's me. So I am also a critical member of my team, and you are a critical member of your team as well. As patients, we have a lived experience that cannot be taught in textbooks. However, to be an effective team member, being prepared for your appointment is very important. So I'll show you here in a second, but I use a worksheet to document all my visits, and then I keep all these pertinent records in a binder. Here is the worksheet. It doesn't it didn't copy over to the screen real well, so I'll kind of glance over it, but I will make this available through IFFGD or through a link at the end, however we decide to go down that route. But it basically just lets me document everything that happened at the visit, so any issues that were addressed, changes in plans of care, new medications, and then anything I need to complete follow-up. So going over kind of my story now, I do want to just end, I have a couple seconds left here with just a challenge for everybody. So I hope that today I've been able to show you that there's power to share in sharing your story. And with that, I would challenge everyone here listening today to share your story with one other patient or a healthcare provider. It doesn't have to be somebody you go to see that you have a physician relationship with. And then as a follow-up to that, at your next GI visit, just tell your GI provider why you love IFFGD and the resources they make available. So thank you so much for allowing me to share my story with you. If you have any questions, please feel free to reach out via email. And I look forward to chatting with everybody during the Q&A. Thank you.
Hello and welcome back. We hope you enjoyed that very informative session about short bowel syndrome and intestinal failure. I know you heard from a physician, a surgeon, and then 2 patients of living with short bowel syndrome and intestinal failure, which was a lot of information to take in. Before we move to some questions that we have, I do want to welcome you back to the Norton Educational Series 30th Anniversary Edition. For those of you who are just joining us midday on Saturday, welcome and thank you for participating in this virtual event. This event is in honor of Nancy and Bill Norton, the founders of IFFGD, who started this organization 30 years ago from their kitchen table as a way to help other people understand better living with GI illness. The IFFGD organization was founded on a desire to educate, and we try to continue that tradition today through this Norton Educational Series. With me for this hosting session is John Pandolfino. Those of you who missed his introduction earlier, he is one of the world experts in GI illness. He practices at Northwestern University, where he is the chief of the GI division, and he is absolutely one of the top experts in the esophageal area, which is upper GI, and gave a wonderful talk this morning about esophageal disorders. If you missed that, please remember that both days of programming will be available on our YouTube channel and on our website starting on Monday. And so you can always watch, rewatch, share with your friends who may have missed the program, and be able to refer back to that. So going on to this session, which is about short bowel syndrome and intestinal failure. Dr. Mercer talks about an ostomy for people with short bowel syndrome. And he actually says that sometimes that can be very beneficial if there's a lot of output. How often do you see this happening in your practice?
Well, I mean, it's certainly something that does happen. It doesn't happen for everybody, but certainly it can be something that helps people's quality of life. You know, it's pretty amazing what has to happen with the GI tract. When you think about, you know, we drink about 2 liters of fluid a day. We make a lot of saliva that we swallow. And then there's a ton of secretion of fluids into the small intestine. And in the end, if you think about it, just kind of roughly, we take in about 10 liters, or there's 10 liters delivered to the small intestine, and it has to absorb about 9 liters, so 90% of that. And then it delivers another liter to the colon, and the colon has to really take out about 90% of that, so that we were left with, when all is said and done, about 100 cc's or 100 milliliters of fluid or material at that point. So it's no big surprise that there are a lot of fluid shifts that occur. And depending on where the dysfunction is in the small intestine and which part of the small intestine is not working very well, you know, it can affect different things. And sometimes it's easier for people when they're delivering these huge amounts of volume to control that with an ostomy, as opposed to actually having it be dumped into the colon, overwhelming the colon, and then having diarrhea. So there are definitely some opportunities to improve people's quality of life with ostomies. We see that often too with people with chronic constipation. When delivery to the colon is going to be an issue and there's a backup, it helps decompress that obstruction. So definitely different options. And I think these are things that require a really good communication between your gastroenterologist, your surgeon, your pharmacist, your dietitian, everybody, and most importantly, the patient, because I think in the end, the patient's preference is really the thing that's driving. We know that you're going to tell us how to improve your quality of life the best way.
So just leading from that, we had a great question from the audience during this session, and that was about building sort of a healthcare team. So John Malachek mentioned his team, and I think that that is something that sounds great. But how could somebody how do they do that? How do you figure out who your team members should be? And
yeah. So if you think about it, when you think about a team, a multidisciplinary team, especially in GI and these kind of problems, you typically have a gastroenterologist, then you'll have probably a surgeon, you'll have a pharmacist, a dietitian, potentially behavioral health to help. And then even on top of that, the primary care physician to help with a lot of other problems that may be affected by the fact that your nutrition is affected. So if you think about all of those particular people on your team, it can be pretty daunting. Are you going to be able to come to clinic on one specific day where all of those people are available? Well, no. What you need to have is great communication. And I think now one of the benefits of Zoom and these telemedicine visits is now that you don't have to coordinate everything into one clinic where you come in and you have 5 different providers who are there to see you. Now you can interact with them separately, and then they can communicate between electronic medical records and amongst themselves. And now it's a little bit easier to do that. But as you said, probably the most important thing is picking the right people, right? So I think, one of the things is that you have resources like IFFGD that can direct you to the physicians that actually do feel comfortable taking care of these particular problems. And I think that's the most important thing is, do they have experience? Do they work with other people? So always look for people who already have relationships with surgeons. For instance, at Northwestern, we tend to pair each other up with other providers. So for me, I know that my surgeon is Eric Hungnes. We work together. I have a behavioral therapist that I work with and a dietitian that I work with right off the bat. So we have that team established. So when you come to see us, it's already there. Now, sometimes you may want to pick the right people. And what we're seeing now with telemedicine is that you can actually have team members that are not in the same institution. So there's not that restriction, and I collaborate with people on the West Coast, on the East Coast, on patients, and we work together. So there's a lot more flexibility now with developing a multidisciplinary team.
fantastic. And I guess the key is really communicating with your gastroenterologist or whoever your primary physician is that this is what you want to build. And would you consider the quarterback of the team to be the gastroenterologist?
Yeah, most of the time I would say probably is the gastroenterologist. I think in some instances when you see someone like Dr. Mercer, I think when they have such a specialized clinic, Dr. Mercer could certainly be the quarterback in that situation. But for the most part, I think it winds up being the gastroenterologist. Remembering though that they have to work in collaboration with their primary care doctors, their behavioral medicine providers, dietitians, and of course the surgeons when needed.
Fantastic. So another thing that has come up during this session that I wanted to just touch on briefly for the audience is the use of tube feeding. And so I know there are different types, there are different options, and they're not one size fits all. And how do you as a gastroenterologist or a physician sort of make that distinction for different patients?
That's a great question. In fact, Dr. Stein, who provided one of the lectures, really taught me a lot about tube feeds, because one of the things that happens is that when people get placed on tube feeds initially, it's typically in the hospital. And one of the things I didn't realize is that there is a disconnect between what happens in the hospital and what people need when they become outpatients. So what might be good for someone when they're hospitalized and acutely ill may not be the right tube feed when they go home. And what we find out is that patients come in and they've been on the same tube feed for a year, 2 years, 3 years, and no one has really done an effective job looking to see whether or not that is a carefully curated recipe for that particular patient and the disease that they're dealing with. And this is really where I think working with someone who's a specialist in small bowel diseases and nutrition is really important, because these tube feeds can be tailored for specific diseases. In fact, they can also be tailored to accommodate other problems that that patient may have, whether it's kidney disease, diabetes. So it's extremely important to think about all of those things. So for instance, one of the biggest mistakes I made early on is that when I had people on products that had a ton of lactose in them, and patients would be having bloating and diarrhea, and they learned to live with it. And if they would have come to me, or if I would have been more well-versed in tube feeds at that point in my career, I would have known that I can find products that have less lactose for those particular patients. And of course, as I've learned throughout my career, now we can actually tailor this. So we can look at caloric content. If we need to deliver more calories with less volume, say for instance, someone's got overflow in their ostomy, we can reduce that actual volume by increasing the calorie counts. So there's a lot we can do to tailor your nutrition therapy by using different types of tube feeds.
Fantastic. Again, the underlying message here is to talk to your doctor and make sure that if something is bothering or you're having symptoms, like Lin Chang said earlier, that you mention that to your physician. I think so often as patients, and I know that I'm guilty of this personally, is that I will have something that I deal with, and then I get with my doctor and I think, well, that's not really that big of a concern, and I don't think to mention it, when actually it might be something that you can help me with. So that's fantastic. Thank you so much for those two things. And so next we are going to be doing another 2 break videos this time, and over the next 30 minutes we will be hearing from Dr. Brandon and Dr. Craven. And again, these are behavioral techniques for people with all types of chronic illness, not just GI illnesses. So feel free to share these with your loved ones. But they are talking specifically about gut health here today. During this break, we will talk about body scan meditation, different than the body scan technology that John talked about earlier today. But this is a type of meditation, and that will be with Dr. Craven. And then following that, Dr. Brandon will talk to us about progressive muscle relaxation, another wonderful technique that can be used at home to help you when coping with your GI symptoms. So we hope that you enjoy these 2 presentations, and we will see you when they're done.
Hello, my name is Dr. Meredith Craven. I specialize in GI psychology, and today I will be leading you through a body scan meditation. The body scan is a wonderful way for both new and advanced students to practice a mindfulness meditation. The body scan uses a mindful stance to pay attention in a purposeful way and a curious way to our physical sensations, allowing us to experience and connect to our physical body in a non-judgmental way. The body scan has many benefits. This practice aligns our minds and our bodies, and we can begin to notice many different physical sensations. We may notice tightness, discomfort, or even relaxation. Paying attention to these sensations in a non-judgmental way and focusing on our breath can help calm our minds. And this practice also helps change our experience with and relationship to pain, including in our digestive system. We will be practicing the body scan mindfulness meditation for about 12 minutes. To begin, please find a comfortable position. You could be seated on the floor, seated in a chair, lying down, or even standing. Whatever position you're in, please make sure it's one in which you feel supported and comfortable. Once you're in this position, you can allow your hands to either rest gently in your lap or by your sides. Once you're ready, go ahead and close your eyes or allow them to remain open with a soft gaze. Begin to deepen your breath. You may want to use diaphragmatic breathing here. We want ourselves to have a long and slow inhale and a full exhale. Breathing in fully and deeply. And exhaling slowly and deeply. Breathing in through the nose and out through the nose or the mouth. Feeling your abdomen rise and fall. Rising as we inhale and falling as we exhale. Letting go of any tension, of any judgment, of any sense of expectation as you exhale. Begin to let go of any noises around you, allowing your attention to shift from the outside to the inside. Using your breath to ground and center your attention in a curious, non-judgmental way. If you notice that you're distracted by sounds or thoughts, simply notice this distraction and see if you can let it go, refocusing your attention back to your breath, to your body, and to my voice. And now shift your attention down into your feet, beginning to observe the sensations in your feet. You may want to wiggle your toes a little bit, feeling your toes against your socks or your shoes, just noticing with a sense of curiosity. You might imagine sending your breath down into your feet, as if the breath is traveling through the nose, throat, lungs, belly, all the way down to your feet. And then as you exhale, it flows back up through the abdomen, lungs, throat, nose, and out again. As you're ready, with the next exhale, allow your feet to dissolve in your mind's eye and move your attention to your ankles, calves, knees, and thighs. Observing the sensations you are experiencing throughout your legs. Breathing in and out of the legs. If your mind begins to wander during this exercise, as minds tend to do, gently notice this without judgment. And as best as you can, simply allow your experience to be your experience, as you bring your mind back to noticing the sensations in your legs. Breathing into and out of the legs. And then on your next out breath, allow the legs to dissolve in your mind's eye and shift your attention to the sensations in your lower back and pelvis. If you notice any discomfort, pain, or stiffness, there's no need to judge this. See if you can simply notice it, observing and allowing the sensations to be in the moment just as they are. Allowing each out breath to free you from any tension you may be carrying. And on your next out breath, very gently shift your focus to your stomach and the internal organs here. Observing how all sensations rise and fall, shift and change moment to moment. Noticing how no sensation is permanent. As you continue to breathe, bring your awareness to the chest and heart region, noticing your heartbeat. On your next exhalation, go ahead and shift your attention to the upper and mid back. Again, seeing if you can use your breath, sending your breath to these areas of your body. Allowing each exhale to create a bit more space to release any tension. Continuing to breathe slowly and deeply. On the next out breath, shift the focus from your upper and mid back to your hands and fingertips. Seeing if you can channel your breathing into and out of this area with a sense of compassion. Again, noticing if your mind has begun to wander. Gently notice this without judgment. In fact, you can gently congratulate yourself for this awareness and allow your mind to once again come back to the breath and the body as we now shift our attention, our awareness into our arms. Sending our breath into our arms. Noticing any sensations, and perhaps with that exhalation, you may experience that your arms soften and release tension. Continue to breathe. And with the next exhale, shift your attention to the neck, shoulder, and throat region. Being with the sensations that are present in this moment. As you breathe, you may feel tension rolling off your shoulders, or you may not. See if you can kindly allow whatever is present to be here in this moment. Continuing to breathe slow and long. And on the next out breath, shift your focus and gently direct your attention to the scalp, head, and face. Curiously observing all the sensations occurring in this area. Noticing the movement of the air as you breathe in and out of your nose and or mouth. Allowing any tension to softness, using the exhalation to soften and release any tension you may be holding. And now let your attention expand out to include the entire body, encompassing your body as a whole, bringing into your awareness the top of your head all the way down to the bottom of your toes. Experiencing the gentle rhythm of the breath as it moves through the body. Feeling your entire body encompassed in breath, breathing in fully and exhaling fully. Continuing to take full, deep breaths as we begin to come to a close of this practice. Using your breath to take in all of the energy of this practice. Knowing that you can bring the sense of peace and relaxation that you may be experiencing into the rest of your day. As you're ready, you can bring some gentle movement into your fingers and toes. And then bringing some awareness to the sounds in the room that you're in. And as you're ready, slowly opening your eyes, coming back into the moment, into the day, thanking yourself for this time, this gift, and I thank you too.
Hey guys, welcome back. We are on break number 2, and as promised, we're going to think a little bit about progressive muscle relaxation. Now, just to catch you up, if you missed our first break, we're talking about ways to be mindful, to meditate, to take back control of the autonomic nervous system, to help us feel more calm, in more control, especially if we have a chronic medical condition, or anxiety and depression that go along with those conditions? How can we do a few behavioral techniques to help ourselves calm down, stay present, and feel a little better? So in our first section, we talked about grounding techniques, and definitely want you to go back and check that out and see if you can listen and get a few tips from that. In this section, we're going to talk about progressive muscle relaxation. And what is progressive muscle relaxation? You may have heard of this before, although actually I find a lot of people haven't heard of it. And I think it's such a great technique to be able to use to think about how to actually really take back control of the nervous system. So this is a physical relaxation technique. It helps you to create a feedback loop in your body and brain to tell your brain that you're in control, relaxing, we're not in danger. It's actually been studied to help with sleep and anxiety. There's quite a bit of research study to show that if you're really struggling to sleep, that doing this during bedtime in bed, when you're already feeling a little bit sleepy, can really, really help your brain to relax and settle into a higher quality sleep. So this can be done, all over your whole body. We're going to go through a full body technique, but you can also just tailor it to parts of your body. So once we go through the full technique, we'll talk a little bit about that. But think about being in a meeting, maybe you're in a Zoom meeting, just like we are right now. Different ways that we can just use particular parts of the body to utilize this relaxation technique. When we go from head to toe, you're going to see that maybe there's a part of your body that is more impactful, maybe you hold more tension in that part of your body. That would be a really great place to make sure you spend a little bit of extra time, think about utilizing this progressive muscle relaxation there. When we think about how this actually helps, think about how your muscles might tense when you're feeling more anxious. And if we override the system by tensing and then actively relaxing, that actually sends a signal to our brain that it's okay to relax and we're not in danger. So that's what we want to practice. Again, thinking about when we were talking in the first section, running from the bear at all times. If you're able to squeeze and release your muscles, your brain has a better sense that you aren't running from the bear anymore. So let's talk through an actual practice of progressive muscle relaxation. While we go through this, we want to focus on both thinking about how the muscles feel and thinking about how the difference feels from squeezing to relaxing the muscles. We're going to go through this sort of generically, just touching different parts of the body and doing some breathing while we're doing this, right? Don't forget to breathe because you're so focused on squeezing the muscles in your body. So if you feel comfortable, I would love to invite you to close your eyes and to really think about what's happening in your body and what you're experiencing. So even thinking about this maybe as a bit of an addition to a grounding exercise. So if you have your eyes closed, taking a deep breath in, when you exhale, thinking the word relax each time. And I'd invite you to squeeze all the muscles in your face, thinking about scrunching your forehead, squeezing your cheeks, squeezing so hard your ears might come up a little bit, the temporalis muscles in your face, they're all tightening, tightening, tightening. And with a deep breath in and then exhaling, you're releasing all of the muscle tension in your face, in your forehead, in your temples, in your jawline. Thinking about doing that another time with a big inhale, we're squeezing our face, we're holding it. Maybe have another breath in and out while you're holding this tension in your face. And with an exhale, release and think the word relax. Deep inhale in and an exhale out. Now let's think about squeezing our shoulders up to our ears, almost like we're making earrings for ourselves, squeezing really, really tight, feeling the tension in our back and our shoulders, up, 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 feeling it in the back of our neck, noticing where the tension is while we're taking a deep breath in and exhaling and relaxing, letting all of that muscle tension go, letting those muscles recoil and feel the release of that tension. And let's take a deep breath in again and out, thinking relax. Now let's think about our arms below our shoulders, thinking about our bicep muscles, squeezing, squeezing, squeezing as tight as we can, squeeze from the biceps, squeeze the forearms, squeezing really tightly, making fists, tightening those up. Everything gets crunched into your body. Taking a deep breath in and exhale and release all of that tension in the arms, letting them feel heavy, resting on our laps or on our arms of our chair, feeling how the difference between the tension versus the relaxation is very apparent now that you're doing it actively. Taking another deep breath in and exhaling, thinking relax. Now focus on your abdomen. Now for us in GI, this is a very important part of our bodies. We hold a lot of tension here. We can feel a lot of pain here. So taking a deep breath in and tightening up all those abdominal muscles, all the core muscles, squeezing, squeezing, squeezing. Inhaling and exhaling, relaxing, letting all of the air go in and go out on our deep breaths, in and out, and letting that all go, feeling that relaxed sensation. Let's do that one more time. Inhaling and squeezing, squeezing our abdomen, squeezing tightly, feeling all those really strong muscles that keep our core, that keep our organs, everything really, really tight. And now exhale and release that tension. Now let's think down to our legs, our biggest muscles in our body. Some of the biggest muscles in our body are our calves, our quads, our hamstrings, everything that can get very, very tight, especially when we're sitting a lot. And now that we have been in COVID for a long time, thinking about our thighs specifically to start off with, and maybe our glutes as well, some of the other really big parts of our body. Taking a deep breath in and squeezing, squeeze your glutes, squeeze your thighs really, really tightly, keeping your feet both planted on the ground so that they're equally getting squeezed. Another deep breath in and an exhale, relaxing those muscles, letting everything just feel like jello, totally relaxing in, sinking a little deeper into the chair that you're in. Taking another deep breath in and exhaling, thinking the word relax. Thinking about our calves and our feet now. Inhale deeply and exhale. And on your next inhale, thinking about squeezing your calves really tightly, pointing your toes up to the ceiling, really, really high, like you're taking your foot off of the gas pedal, tightening all those muscles in the front of your leg, in your calf, the back of your leg, in your feet. You could even curl your toes, creating a little extra tension. Taking another big inhale in, and then exhaling and releasing all of that tension, feeling that relaxation just flow over you and be warmth, and knowing that those muscles really, they were able to tighten, they were able to relax, and that you overrode your brain in thinking about that relaxation technique. Now, as we said, this is a full body technique. You could do this after you've done it a few times. You could do this easily for yourself in bed, thinking these inhales and exhales, thinking relax, and helping yourself focus and calm down and go to sleep. The other piece of this is if you find yourself utilizing this or wanting to utilize this in a more public setting, you could think about utilizing just the lower part of your body, maybe squeezing the thighs and glutes, maybe squeezing the calves and the feet, even doing your squeezing your hands underneath the table or below your computer so that you're able to utilize this technique, but you're not also scrunching your whole face if you're in a video chat. or if you're on a meeting or in person somewhere. So think about different ways that work for you in this technique, and think about the feedback that it creates for your body. Again, I would suggest that you try practicing this when you're not in duress, so that you can feel a little bit more comfortable with employing it and utilizing it quickly when you are in need of doing that. Now, there are a few different apps that I think are really great for this. One is called the CBTI Coach, and it was developed actually by the Stanford VA. It has a progressive muscle relaxation, 9-minute progressive muscle relaxation recording in there under tools. So I would definitely encourage you to check that out. And then Insight Timer is another app that also has a lot of really great relaxation techniques like progressive muscle relaxation. So that's it for this section of techniques of relaxation. I hope you feel a little bit calmer, a little bit more relaxed, maybe a little more focused. And if you fell asleep, that's okay too. Just know that you should use it for bedtime and maybe not as an energizing technique in the middle of a conference. So shake yourself a little bit, get yourself alert and ready for your next talk. And I'll see you in break 3 when we chat a little bit more about using breathing to reset your autonomic nervous system.
Hello, and welcome back to the Norton Educational Series 30th Anniversary Edition. I'm here again with Dr. Lin Chang from UCLA and Dr. John Pandolfino from Northwestern University. Before we continue on, we just keep getting lingering questions from this morning, which is fantastic. Please keep them coming and keep up with the comments. We really appreciate the great interaction that we're getting this today and this afternoon. So John, there was a question about bile reflux. And so what is that? How is it treated? Can you tell us a little about that?
Yeah, so I touched upon it a little bit, but I probably wasn't specific enough before. But bile reflux is what we call non-acid reflux. So typically what happens with proton pump inhibitors, because they're so effective, they can really suppress the acid in the stomach really well. But what happens is people still reflux the gastric juices. They're just not as noxious or caustic because there's not as much acid. But if you think about it, there's still digestive enzymes and bile. So bile reflux is really just the reflux minus the acid. But nonetheless, bile can injure the lining of the esophagus. And if it gets all the way up into your throat, it can also cause irritation in your throat and maybe even get into your lungs and cause irritation in lungs. So bile reflux is essentially a non-acid reflux. We typically see it more in people who are on PPIs and effectively controlling their acid.
Okay, so something to keep in mind, again, to speak to your physician about if you suspect that you might have some bile reflux while on PPI medication. So we're going to go ahead and move into our next session, which is on irritable bowel syndrome. And again, like the short bowel syndrome session, we will be having a physician begin, and then we'll be followed with 2 patient stories. And so the physician for this session is actually going to be Lin Chang, who is here with us today. So we're lucky to have her for the question and answer session afterwards. And she'll do an introduction about irritable bowel syndrome. And then she'll be followed with 2 patient stories.
And the 2 patients that are going to share their stories about having IBS, one is Deb Catton, and she has IBS with constipation, and then Lisa Strakowski, who has IBS with diarrhea. And they're going to tell their journey of how long it took for them to get a diagnosis and treatment for their symptoms.
Hello, I'm Lin Chang, and I work at UCLA, and I'm very honored to be able to speak at the IFFGD 30th anniversary. And my talk today is Physician Introduction to Irritable Bowel Syndrome. Next slide. So the objectives of this fairly concise talk are to define irritable bowel syndrome, or what we know as IBS, to review the diagnostic approach to patients with irritable bowel syndrome, and to briefly discuss the pathophysiology of IBS and review the treatments for IBS with diarrhea, which we call IBS-D, and IBS with constipation, which is referred to as IBS-C. Next slide. So this shows the key results of a study done by Ollie Paulson and others, where the prevalence of functional bowel disorders, which we now call disorders of the gut-brain interaction, were assessed in the United States, Canada, and the United Kingdom. This was using the Rome 4 criteria, which is a little bit more strict diagnostic criteria. But what you can see from this study is that 1 in every 4 adults in these countries has one of the 6 functional bowel disorders. And the pie diagram shows you these different functional bowel disorders. IBS, that comprises almost 5% of the population, functional constipation, functional diarrhea, functional bloating, opioid-induced constipation, and unspecified bowel disorder, which means that the patient has chronic bowel symptoms, but it doesn't quite meet the symptom criteria for these other defined conditions. Functional bowel disorders are more common in women than in men, but they can occur in both gender. They become less common after midlife. And I'm going to tell you more about them in the next slide. So these are key organic diseases that we think about when we're assessing the differential diagnosis for IBS. And many healthcare providers are always concerned they're missing some other diagnosis that explains their symptoms. And these are some of the main organic diseases that we think about: colorectal cancer, inflammatory bowel disease, microscopic colitis, bile acid diarrhea, celiac disease, food intolerances or sensitivities, congenital sucrase isomaltase deficiency, and small intestinal bacterial overgrowth, which is known as SIBO. Next slide. So since IBS is really a symptom-based diagnosis, this is a diagnostic algorithm that we often go through when we see a patient with IBS symptoms. So we always start off on the left upper box with the symptoms, because that's really what the patients present with. So patients who have recurrent abdominal pain that's associated with defecation and or disordered bowel habits are the main key symptoms of IBS. And when we see them, we do a medical history, includes surgical history, psychosocial, dietary, medication history, do a physical examination, and a digital rectal examination is important in these patients as well for a number of reasons, looking for a rectal mass or for pelvic floor dysfunction, particularly in patients with constipation. We also assess if the patient has alarm features. And the alarm features are important because if the patient has alarm features, which I'll describe in a moment, we might do more specific investigations than we normally do if they don't have alarm features. And I want to show you what those alarm features are. So next slide. So these are alarm features that are more indicative of having an organic GI disorder of the a structural disorder or biochemical disease, inflammatory bowel disease, celiac disease. So the alarm features for IBS symptoms are symptom onset after the age of 50. Now this is new symptom onset, not an exacerbation of symptoms, but they've had symptoms earlier in life. It's new onset after the age of 50, unintended weight loss, so they're not on a diet, of at least about 10% of their body weight in 3 months, rectal bleeding that is not caused or confirmed by hemorrhoids or anal fissures, or if the patient has melena, which is black stools, nocturnal diarrhea, waking up in the middle of the night to have bowel movements and diarrhea, fever, family history of colorectal cancer or polyps, inflammatory bowel disease or celiac disease, and unexplained iron deficiency. Those are the alarm features that may take us down a different path, diagnostic path, than if they didn't have it. Let's go into the next slide. So this is just showing, again, the algorithm, but if a patient does not have alarm features, there's limited screening tests that we can do. And this shows you on the bottom table a lot of the culmination of a lot of different guidelines around the world on the diagnostic evaluation of patients with IBS symptoms without alarm features. And you can see that we do order for patients with IBS with diarrhea symptoms, celiac serologies, fecal calprotectin, C-reactive protein, We can consider bile acid diarrhea testing, Giardia stool antigen in the United States, because Giardia is prevalent. And in patients with constipation symptoms, we may consider an anorectal physiologic testing for dysenergic defecation. It is not currently recommended to do routine stool testing for infections unless there's a history to suggest they have an infection. Routine colonoscopy under the age of 45, food allergy or sensitivity testing, or lactulose or glucose hydrogen breath testing. Now, we want to do routine colonoscopy just by the guidelines that we have, but that's in all individuals. You don't have to do anything different specifically for patients with IBS symptoms if they don't have alarm features. Next slide. So if the patient has had these limited screening tests, they don't have alarm features, it's negative, and then we look to see if the patient meets the Rome-4 criteria for IBS, which is abdominal pain at least 1 day a week in the last 3 months. And the pain has to be associated with 2 out of the 3 features, or at least 2 out of the 3 features. Related to defecation, so the pain gets better or worse after a bowel movement. The pain is associated with a change in stool frequency, having more bowel movements per day or less bowel movements per week. And the pain is associated with a change in stool form, loose, watery stools, hard, lumpy stools. The patients have to have these symptoms that have started at least for 6 months ago, but they're more active in the past 3 months. Next slide. So let's get back to our diagnostic algorithm. We did limited screen tests, they're negative. They meet the criteria for IBS. And then we tried to subtype the IBS by bowel habit predominance, IBS with constipation, IBS with mixed bowel habits, IBS diarrhea, or IBS unclassified. That means that the patients have pain that's associated with defecation, but when you really look at the stool form, neither of the 2 extremes of stool form are really predominant of at least 25% of bowel movements. Next slide. Okay, so we use the Bristol Stool Form Scale to define IBS bowel habit subtype. We want to do the bowel habit subtyping because a lot of the treatments for IBS normalize stool form and bowel habits. So we have the Bristol Stool Form Scale, widely known as 7 different types. This is the range which we see in the general population. And we define IBS-C and IBS-D and mixed by the predominance of the stool type. Next slide. So for IBS with constipation, the patient will have at least 25% of their bowel movements, hard, lumpy stools. And this correlates with slower transit time through the colon. And they have less than 25% of the loose watery stools, which is type 6 or 7. Next slide. Now, IBS diarrhea, on the other hand, at least 25% of bowel movements are loose watery, the type 6 or 7, and less than 25% are the hard, lumpy, drier stools, type 1 or 2. And IBS mix, as you can see in the next slide, is really a combination of both extremes. At least 25% of the bowel movements are type 1 or 2, and at least 25% of the bowel movements are type 6 or 7. And this Bristol Stool Form Scale does correlate with transit time. The type 1 or 2, the constipation type, means that the stool moves through the colon slower. And the type 6 or 7 stools, loose watery stools, the stool moves through the colon faster. Next slide. Now we know that there's a spectrum of bowel habit, these different disorders of gut-brain interaction or functional bowel disorders. If you look at the x-axis, that's the scale of pain. So if you move to the right where the patients have more pain and they have bowel habit abnormalities, they have IBS or could have IBS. On the y-axis, you can see constipation and diarrhea. If you move up the y-axis, that's constipation. So patients with pain and constipation, that's IBS with constipation. But if they don't have much pain on the left upper panel, but they have constipation, that's functional constipation. If they have more diarrhea, less constipation, but not much pain, that's functional diarrhea. And if they have diarrhea and pain, then it's IBS with diarrhea. So this is really along a spectrum. Next slide. So now we know, we refer to functional GI disorders as disorders of gut-brain interaction. And that's because a lot of scientific evidence show that these are a group of disorders classified by GI symptoms related to any combination of the following: motility disturbance, visceral hypersensitivity, altered mucosal and immune function, altered gut microbiota, and altered central nervous system processing. Next slide. The IBS pathophysiology is really multifactorial. There's a lot of environmental factors that can increase the risk of IBS, a genetic predisposition or familial predisposition. There can be triggers like food, GI infection, inflammation, and then we can get disturbances in the gut-brain interactions, and we could have some gut peripheral abnormalities that can exist in IBS patients, like altered intestinal barrier function that is termed in the lay public as leaky gut. The bacterial flora can be altered, and the patients have increased visceral sensitivity and can have abnormal GI motility. Next slide. For treatment, there's really a graded response. You really determine first if the patient has mild symptoms, moderate, or severe. If the patient has mild symptoms, we want to give dietary lifestyle advice, give a positive diagnosis of IBS, and explain about the condition, why patients have it, and reassure them. Patients with moderate symptom have symptoms that really start impacting their quality of life. And in those patients, we do everything we do in the patients with mild symptoms, but we do continuity of care, manage stress if symptoms are stress sensitive, and we start using pharmacotherapy. For patients with severe symptoms where it's really severely impacting their quality of life, we do also what we do in mild and moderate symptoms, but we start introducing psychological behavioral treatments, continuity of care, central neuromodulators. Next slide. This just shows an overview of the IBS with diarrhea treatments. A lot of it is directed towards the gut, where we want to affect the microbiome. We may use antibiotics, diet, probiotics. If we think the patient has bile acid diarrhea, we may use a bile acid binding agent. For patients with more enhanced gastrocolonic response, meaning that the colon will contract or have more spasm in relation to meals, we may use an antispasmodic like peppermint oil. There are also 5-HT3 or serotonin type 3 antagonists that can reduce symptoms of IBS with diarrhea. And then we have opioid receptor modulators that work peripherally and can help reduce diarrhea and in some cases pain. And then neuromodulators can target the central nervous system as well as the gut and can reduce symptoms of IBS with diarrhea, like pain and diarrhea. Next slide. And then we have IBS constipation treatments, and a lot of them overlap with chronic constipation treatments, which is where patients have chronic constipation, but not really predominant pain. And we have a lot of gut-directed treatment like prokinetic agents that increase the motility of the bowel. We have prosecretory agents that increase the secretion of electrolytes and fluid and could improve stool form and also can reduce abdominal pain. And then there's bulking agents for more of the patients with mild symptoms, stimulant laxatives, as well as osmotic laxatives. Next slide. We also have behavioral therapy options and targets. We know that this is a gut-brain disorder that can lead to more maladaptive responses where symptom-related anxiety, which I think is protective and completely understandable, but it can lead to more catastrophizing thoughts, a hyper-aroused system where the patients could lead to difficulty sleeping, more stress-sensitive symptoms, more activation of the cortisol system that we call the HPA system. And it could be more of altered central nervous processing of information, lead to amplification of symptoms. And all of these lead to pathophysiologic mechanisms that we can target with behavioral therapy, like gut-directed hypnotherapy, cognitive behavioral therapy, mindfulness-based stress reduction, and relaxation training. And a lot of these modalities can be used in concert with medications and also diet as well. So you can see that we're moving towards a more integrated approach of diet, lifestyle, medications, behavioral treatment, reassurance, education, and then establishing a therapeutic and successful patient-provider relationship. Next slide. So we really come to the biopsychosocial model that Doug Drossman really brought into the disorders of gut-brain interaction field, where we look at risk factors of early life environment, leading to psychosocial factors and physiologic changes in the gut and the brain and the interaction between the two. And they all can interact and affect each other. It leads to the IBS presentation of symptoms, comorbidities, and behaviors, and that can affect outcome. So I think it's important to look at the patient as a whole individual, think about the different factors that can affect their symptoms or the development of IBS and the triggering of IBS symptoms, and then target treatment that is really patient-centered and relevant and important for that patient. So thank you so much for your attention. And I know during the meeting, we'll have a lot of time to talk about the specifics. Thank you again to IFFGD.
Hello, my name is Deb Caton, and I am so glad to be a part of IFFGD's 30th anniversary edition of the Nancy and Bill Norton Patient Education Series. I want to thank Carolyn Eiler and the IFFGD for asking me to share my patient story with you today. If there's anything I have learned while living with a functional GI disorder, it is that while we may all share an understanding of living with it, each of us has a unique experience. I have learned that what works for one person will likely not work for another. This is a constant source of frustration for many of us. However, we have the ability to learn from and support one another through our struggles and successes. I've spent many hours, days, even years feeling quite alone in my struggles with my functional GI disorder, but I hope that sharing my story with you today will help you know that you are not alone. As far as I can tell, I was born constipated. No, my mother never told me that, but I can't remember not being constipated. I have vivid recollections of tear-filled episodes in the bathroom, my mom on the phone with the doctor, begging him to help me go. Once he suggested a suppository. 10-year-old me wanted nothing to do with that once I found out what it was. I've also always struggled with food. I am Greek, and big meals were common. This did not work for me at all. I spent most of my life hearing constant variations of, why don't you eat more? You're too skinny, you eat like a bird, from all of my family. I hated it. Apparently, they viewed my food intake like this. In reality, I ate all the time, and my favorite snack was ice cream with lots of chocolate syrup, but big meals just weren't my thing. I just ate small things all day long. Despite my apparent lack of appetite, I was athletic and always moving, and I was a gymnast for 8 years. When I was 8, I had a traumatic experience that impacted the rest of my life in ways that I'm only recently fully understanding. On a family trip to Florida, a girl vomited all over me in the back of our car. It was a complete nightmare. And from that, I developed what I now know is called emetophobia, or a fear of vomiting. During college, my GI problems reared up again. I was so constipated that I would tear and bleed when I tried to have a bowel movement, and I developed hemorrhoids that were very painful. I also started to feel sick quite often, but I could not figure out any one cause. I didn't ask a doctor or my parents for help. Instead, I started trying to fix it myself. I decided that drinking pop was giving me stomach aches, so I stopped drinking it. Then I started self-medicating, carrying around a bottle of Pepto-Bismol to drink when I felt sick. Nothing made it better. I just figured this was how my life would be. Around 2005, I began to feel bloated and sick after eating even a small amount of food. So I finally saw my very first GI doctor. He determined that I needed my gallbladder out and that I should avoid red meat and fatty and fried foods. He also gave me my first official diagnosis of IBS. He did not say what subtype, nor did he offer much in the way of solutions. Things did not get better. Over the next 10 to 15 years, I began to slowly feel worse and worse. The episodes, as I came to call them, became more frequent. Constipation, diarrhea, bloating, then periods of feeling fine. I kept functioning though, not seeking answers from doctors or anywhere else. I also experienced increasing anxiety. I sought counseling on a few occasions and started taking an antidepressant. It helped my anxiety, but I still did not seek help for my GI problems. My episodes got steadily worse and more frequent. For instance, on a trip to Arizona in December of 2018, I spent most of one night crouched on the hotel bathroom floor, sweating and shaking, nauseous and scared, praying I would not vomit and that it would just go away. Through the next year, these episodes became more random. They would appear out of nowhere in the middle of the day or wake me out of a sound sleep. I was getting scared. So once again, I decided to work on finding my own solution. In July of 2019, I stopped taking my antidepressant after 10 years. I thought maybe it would help. It didn't. I also discovered the low FODMAP diet and figured eliminating possible trigger foods might help. It didn't. By September of that year, I began to lose weight and I went to see my second GI doctor. I had a colonoscopy that showed no organic problems and was told once again that I had IBS and to manage it with diet. By October, I had lost 5 pounds and food was a constant stressor. I was afraid to eat, but not eating wasn't helping me feel less sick. Finally, in January 2020, I called the University of Michigan GI department. Their first available appointment was at the end of March, but because of COVID, my new GI doctor never saw me in person. He started me on some medications, including Remeron and Linzess. Based on my symptoms, he said that I likely had IBS with constipation and pelvic floor dysfunction. I had never heard of that before, but he was right. During May of 2020, I had another colonoscopy, an EGD, an abdominal CAT scan, and an abdominal X-ray to try to figure out what was wrong. At the end of May, I went to the emergency room because I discovered, severely constipated. I stayed for 3 days and had an anorectal manometry study and a defecography done. Those tests showed that I definitely had pelvic floor dysfunction. Pelvic floor dysfunction is the inability to correctly relax and coordinate your pelvic floor muscles to have a bowel movement. The next several months are kind of a blur, but by June, I had dropped to 80 pounds. I was severely malnourished, constantly sick and in bed, and generally not functioning. I could hardly eat, and even when I did, I felt sick and feared vomiting. I was emaciated and struggled to do basic things like shower or cook or clean. I was frustrated and depleted and scared. I kept thinking I could handle it, that it would somehow get better, but it didn't. Every aspect of my life was impacted: my work, my parenting, and all of my relationships. Finally, on June 25th, 2020, I checked myself into the hospital. I was there for a week. While I was there, I had many tests done, including a gastric emptying study, and I had an NJ feeding tube placed. This fed right into my deepest fears of vomiting because they thread the tube up your nose, down your throat, through your stomach, and into your small intestine. The next week in the hospital was one of the hardest of my life. I cried all the time, and my body did not like the liquid nutrition I was receiving, so I felt sick constantly. I spent the next 7 months on a 24-hour liquid tube feed, which provided enough calories to survive. My weight gain was incremental and painful, and I had to have the tube replaced 3 times. I spent most of these months with what I came to call my team of doctors, including my GI doctor and nurses, a dietitian who specializes in GI disorders, physical therapists, a GI psychologist, a trauma therapist, and a psychiatric nurse practitioner. I had a new mini pharmacy of medications, and in August, I slowly restarted the antidepressant, which helped immensely. Apparently, stopping it in 2019 may have led to the worsening of my IBS-C. I learned that our guts have more than 30 neurotransmitters and that 95% of the body's serotonin is found in the bowels. I learned about the gut-brain axis and practiced gut-directed hypnotherapy. I also began 5 months of biofeedback and pelvic floor physical therapy. I slowly relearned how to eat solid food, though I often felt terrible. There was no such thing as a good day, only less bad days. In early February 2021, I reached my goal weight and weaned off the tube feed. Happily, I maintained my weight and had my tube removed on March 3rd. I still have a long way to go, but I continue to heal both physically and mentally. I can't easily summarize all I have learned over the last 18 months, but I will try to hit the highlights. First, I have learned how small your world can become because of your functional GI disorder. We likely have all experienced this in one way or another. It's not easy to begin to expand my world again, but I work on it daily. I've learned that you need to listen to your body, especially when it comes to medicine. Instead of jumping into full dosages of medication, I started small and built up, and it helped me so much. Along with this, I learned patience. I've always had high expectations of myself, but I've learned to slow down and give myself credit for what I have accomplished. I've learned to seek out valid, reliable, research-based sources of information, including organizations like IFFGD. I've also learned that whenever possible, we should find and enlist the help of qualified professionals instead of trying to fix our GI disorders on our own. We must keep looking for people who will truly listen to us and understand that the answer may need more than a handout and have the knowledge and desire to find answers and resources. I have learned that you must advocate for yourself, sometimes loudly, to ensure you get the best care you can, to be heard and to be understood. Perhaps most importantly, I have learned that I'm stronger than I ever realized. I did not get to where I am today alone, and I will be eternally grateful to my family, friends, and innumerable medical professionals who helped to get me here. But I made it through situations I never thought I could, and I'm stronger for it. Having and living with the functional GI disorder is part of who I am, but I believe I don't need to let it define me, and I'm hopeful about making my life bigger than it has been for the past few years.
Hi, everybody. My name is Lisa Strykowski. Thank you so much to IFFGD for allowing me to share my IBS-D patient story with everyone today. So I started off fairly uneventful other than infant reflux. My poor parents who had a newborn that would projectile vomit. That was my biggest problem as a child in regards to gastrointestinal distress. I outgrew it and had a fantastic childhood and teenagehood, doing all sorts of cool things. I had no limits. I could travel. I could do everything that I loved, had no problems. That all changed around 1999. I started to experience stomach problems. I had a lot of loose stools, stomach aches, cramping, bloating, urgency, tiredness, migraines. My gut would flare up a few times a week, mostly in the mornings. My 15-minute commute to work would include 1 to 2 bathroom stops along the way. So I learned to travel with my little bag, as you can see in the picture, that had all sorts of supplies in it, including medication, extra toilet paper, extra ointment. Let's just say it would just get a little awkward at security checkpoints at some places. So that went on for a few years, and around 22, I finally mentioned my frequent stomach aches to my primary care provider. I was told that I probably just had IBS and that I probably just had nerves that went to my gut. Over-the-counter anti-diarrheal medication was fine as needed for my symptoms. I had blood work done. I tested negative for celiac. At the time, this was only offered as a blood test. And I started taking over-the-counter anti-diarrheal medications as directed. And I also got a prescription for zolmitriptan because I was also experiencing migraines with my stomach ache. So I was taking 4 to 6 milligrams of loperamide daily after a while. And around 27 years old, so 8 years after my symptoms started, I reached out to my primary care again because the amount of medication seemed excessive to manage these symptoms. So again, I tested negative for celiac. I was finally referred to a gastroenterologist, had a colonoscopy, and was told again that it was quote unquote just IBS. Around the age of 30, so that was around the year 2010, my gastrointestinal disorder kind of leapt up, you know, got a little more intense. Around the age of 30, I had my gallbladder removed, and I had a gallstone the size of a golf ball that was found 5 years prior when I was pregnant during a routine ultrasound. It had flared up. I had my gallbladder removed, and that actually took away so much of the pain that I was experiencing because of where it was radiating. It was just assumed it was part of my IBS symptoms. So that felt so much better. I was still taking loperamide daily. And when I was around 32, I actually had a really bad case of acid reflux. And when I went to see the ENT that I was referred to, he looked at my chart, and he was the first medical professional to suggest that based on my symptoms and medication, I had either a food allergy or sensitivity. I visited with an allergist, and they were the first to suggest that even with a negative blood test for celiac, I could still have a sensitivity to gluten. And they suggested that I give it up for a little while, which I did. My gut health improved tremendously. I no longer had migraines, so I didn't need the zolmitriptan anymore. However, I did keep the loperamide on hand for those occasional IBS flare-ups. Around the age of 36, I started to develop an intolerance to the loperamide, severe stomach cramping and constipation after taking even a small dose of the medication. So I tried to take it as little as possible, but I was either at one end of the spectrum or the other. I was either having an IBSD flare-up or I was having severe constipation. And either way, it just was not working out. So I tried to keep taking the smallest dose possible, but eventually I had to stop taking the loperamide. So by this time, my IBSD had flared up with the worst symptoms I've ever experienced. It lasted for about 3 months. So 2 months into that, I was just kind of waiting to see if it would get better. I would, you know, because it had never lasted that long before. I would go to the bathroom before I left for work, race to work with my 15-minute commute, and I'd be hitting the bathroom again really quick. I had to plan my entire day around a bathroom. So again, after 2 months, this just didn't, it just kept going. It wouldn't let up. So I reached out again to my primary care, and I was told not to take loperamide anyway, because I needed to let whatever needed to come out. A new medication was available for IBSD, but I couldn't take it because I no longer had a gallbladder, and I would risk the chance of getting pancreatitis. So I was referred to the gastroenterologist that I saw originally for my colonoscopy almost 10 years prior. And I was prescribed amitriptyline, which is originally an antidepressant, but because they were starting to see that maybe there was a brain-gut connection, a brain-gut misfire, that this would actually help. And it did. It helped tremendously at first, but eventually I started getting panic attacks from the medication. And I kind of figured, you know, is medication no longer an option for me? Even though I hadn't tried many, I didn't know if I wanted to try more. So I weaned myself off of the medication and started looking for a new approach on my own. As you can see, a little bit of humor here. I would always go prepared everywhere I went, and I had a lot of time to think. So I thought back to when I gave up gluten and I felt better, and I thought maybe I should start looking at what's causing the symptoms and stop looking at treatments. And so I thought back again, and I thought, well, no one had suggested nutrition other than gluten for me. So I thought, well, let's try looking at nutrition again. So I went online, searched around, and I found the FODMAP diet. As a disclaimer, if you have access to a nutritionist, I highly recommend doing this with somebody as support, someone who can guide you through this process. I did this on my own. I eliminated all of these foods from my diet, reintroduced them a little at a time, logged all of my food choices, my reactions, and I found that I had additional food sensitivities. So in addition to the non-celiac gluten sensitivity, which I have to avoid wheat, rye, and barley, I could also no longer eat legumes. Beans, chickpeas, lentils, cashews, and peanuts were now off the list. Anything made from legumes, including peanut butter and hummus, and also peanut oil. Again, I do recommend working with a nutritionist because I did find that while these foods were triggers, I didn't consider products made from them as well. So they can help guide you through that process. I also had to now avoid raw apples and pears as well as corn kernels. So moving ahead, before and after FODMAP, I started FODMAP on April 5th of 2017. A year and a half later, after following FODMAP restrictions, adding intermittent fasting to my diet, and focusing on a diet with high protein, low carbs, and good fats, July of 2018, I was doing my first fitness shoot. Please do not be, it's a bit of an illusion here. I did intermittent fast the day before. And again, as you can see, some days, May of 2018, I was, nice flat stomach. June of 2018, I had my food baby. So even now today, even though my symptoms have improved, they are not cured. Some days I am Lisa on the left, some days I am Lisa on the right. My flare-ups are less frequent, they're shorter in duration, but I'm still managing with only nutrition after 5 years of this journey. I'm still avoiding those trigger foods. I do try them periodically. They do still bother me. I still experience occasional and mild flare-ups, gas, bloating, and urgency. And again, it's been fairly consistent for the last 5 years with only nutrition. So that's my story. Thanks again so much for IFFGD for having me today.
Hello, and welcome back to the Norton Educational Series 30th Anniversary Edition. My name is Ceciel Rooker. I'm the President and Executive Director for the International Foundation for Gastrointestinal Disorders, or IFFGD. Thank you for joining us today for this very special anniversary event, where we are learning about all sorts of GI conditions and topics related to your digestive health. We do apologize for the chat incident through the last session, and we have disabled the chat so that you are not going to be able to chat with one another. However, if you use the chat feature, that will be sent directly to IFFGD. We will be cataloging any questions or comments that you do send in, and we will be able to address those during these moderated host sessions. So please do keep your comments and your questions coming, because we will be able to address those. We will just not be able to make them public for viewing until we can make sure that we don't have any more interference. So this was a great session, Lynn. Thank you so much for your physician introduction to irritable bowel syndrome. Obviously, I mean, as your presentation said, it affects so many people. It's really high prevalence and is really something that is of a severe concern to so many patients. So one of the things that you mentioned in your talk was the word organic. So can you define the word organic for us?
Every time I write that, I have to pause because, the classic way that we think of organic is that you have to find something biochemical, structural, anatomic that will explain the symptoms. But as science is progressing, we are finding physiologic or biologic explanations for the symptoms. So every time I say that, I think I mean it in a classic sense, like having inflammation that you can see in the bowel, like inflammatory bowel disease or clearly celiac disease as organic diseases. But you can really, IBS is an organic disease. It's just not in the classic sense.
Okay.
I guess that's why I would put it.
And you talked about behavioral therapy, and then of course both of our patients alluded to that as well. So what percentage of your patients, each of you, do you think were you referred to behavioral therapy with irritable bowel syndrome?
Well, I work in a tertiary care referral center, and so most of the patients will have more severe symptoms. And with greater severity, there's more difficulty managing the symptoms. And so many patients could benefit from behavioral therapy. And also there is a coexistence with psychological symptoms, and they can benefit from that as well. So for me, I would say over 50%, but not everybody probably should be referred to behavioral therapy. And I've learned that from our GI health psychologist. And John, you probably have the same, situation. So because it really is a gastrointestinal skills-based approach. So if there is maybe not as well controllable general anxiety or
Mhm.
depression. Many times it's recommended that they should get treatment for that,
Mhm.
and then later on be more suitable for a GI skills-based approach.
Okay.
You know what I mean? But it is very helpful for stress-sensitive symptoms and for, you know, catastrophizing where you can anticipate some negative events happening that with your symptoms. But no, I don't know if everybody at that time is the right suitable candidate, but a majority definitely.
Fantastic. And what about you, John?
Yeah, so in the esophagus, we're probably about the same rate, I think, if you look at the group of patients that we see at a tertiary care center. But similar, I think even people with organic disease can benefit from behavioral therapies because it really allows you to shift your attention to more positive things. You don't perseverate on the symptoms and you don't let it rule your life. But for us, you know, the patients who come in with heartburn that's not related to overt reflux, they don't have inflammation on their endoscopy, they don't have horrible acid reflux on their pH testing or their reflux testing. These are patients who I can feel comfortable reassuring them that they're not going to injure their esophagus. And I think reassurance has a huge power when we present it that way, that you're not going to hurt yourself by not being on an acid medicine. And then what we need to do is shift your attention away from those symptoms. So for us, you know, particularly in the esophagus, we really like cognitive behavioral therapy, and we also like hypnosis. So hypnosis is something that we do a lot of, and getting patients to think along those lines about shifting their attention. So we use it a lot.
Fantastic. So we actually had a question from someone in the audience, and they were asking if you had found experience with helpful to have people do relaxation techniques with Globus.
So Globus in particular, we've had a pretty good effect with. In fact, hypnosis for Globus, we've published papers on this, 75–80% response rates in these patients where, you know, they visualize, you know, an ice cube melting in their throat, and this kind of relaxes that area and just shifts them away from that sensation. And Globus probably is a physiologic event that we're just not able to really appreciate. But it's something that I think we can characterize and we can educate patients. And yeah, they essentially relax to the point where they don't care about that particular thing anymore. It's probably still there, but it's not as important and it doesn't affect their quality of life as much.
It's not even just shifting, right? It's reframing the way you're perceiving your symptoms. Because it's not like you don't want to even think about your symptoms, but instead of thinking there's a blockage or there's fire here, having that cooling sensation. So it's kind of, it's really reframing how they're viewing it rather than completely distracting them. Although distractions to some extent part of the intervention.
Yeah, and I do think, you know, teaching patients how to self-manage too is extremely important because, you know, a lot of these things we can't fix completely, and accepting that we can't fix them completely and that we have to in parallel try to improve the symptoms while we're trying to work it up and figure out what's going on. But more importantly, kind of saying, okay, well, you know, let's work around this. You've identified triggers, you know, you know what's going to happen and manage that yourself. I think it's empowering for patients to be given those cognitive techniques and abilities to deal with the symptoms.
I also think that, you know, a lot of times we see, as a healthcare provider, we see the patient for 15 minutes, an hour, whatever the period of time.
Yeah.
But the other 24/7 time, they're in a different environment. And I think to understand what they're experiencing and applying that behavioral technique or just the reassurance or the education is really important because that's most of the time they're going to spend. So we get a snapshot view at that moment, but it's really important to try to understand what they're experiencing most of the time, which takes time and a lot of reflection.
Fantastic. So you mentioned tertiary care center, both of you, and so Northwestern, UCLA are tertiary care centers. Can you just really quickly tell us what that means?
Usually it's patients that have already seen primary care physicians and have even seen community physicians like community gastroenterologists, but they usually are requiring or seeking more specialized care. So often, like Northwestern definitely has a specialized center for esophageal disorders and GI, and UCLA also for different conditions. So it's really more an expertise level of care, but it tends to be patients with more severe or refractory symptoms.
Fantastic. And for those of you at home, if you're looking, thinking maybe it's time for you to visit a tertiary care center, please reach out to IFFGD and we'd be happy to help you to try to find one in the disease state area that you are looking for. So back to irritable bowel syndrome, and this is all great conversation, and we appreciate the questions and obviously appreciate both of your time. So if you're seeing someone for the first time and we've got a suspected IBS patient, what are some of the key symptoms, key things that these patients should be talking to you about in that initial consultation to get the right diagnosis for them right off the bat? What are the important things that maybe people forget to tell you that you wish they had told you up front?
I think it's always good to start off as open-ended and not be so, not so many of these yes/no questions. Because if you start off more globally open-ended, then you can really figure out what the patient's coming for you for. So I usually will say, you know, what brought you in here? What during this time do you want to make sure we address? And I always think it's good to address what's the most bothersome symptoms, which are usually always the symptoms that impact their quality of life the most. So I really want to get at is what they're seeking. You know, some patients are just saying, I just want to confirm the diagnosis. I really want to just use some lifestyle or dietary modification. I don't really want to go on a medication. And then there's other patients that really want you to explain things, or they said, just, I want the pain to go away. So I really try to get from their perspective, what is it that will be helpful for them? And, you know, if they want to start on a certain topic, we'll go there because I think that's really important. But I try to just get the symptoms that assess the symptoms so I understand what the diagnosis is. I actually don't find that to be the hardest part. The harder part for me is, or the more time-consuming part, is trying to understand the illness behavior, the way they're managing their symptoms, any coexistent conditions, what have they tried before, what are their expectations, how do they think about their condition? Because that's the way that it should be approached, and every patient is different. So to me, that takes more time, but I think it's a really important part.
Fantastic. And John?
Yeah, I think, you know, what Lynn said about the symptoms, and, you know, for me, I don't think patients care so much how many times a week they have heartburn. It's more, well, can I go out and enjoy a meal with my family without the fear of being embarrassed? You know, for us with swallowing issues, you know, the other thing is choking. You know, so people may say, yeah, I get food caught, but that's not really what's bothering them. What's bothering them is when they're sitting home alone and they're scared they're going to choke and may go unconscious. So a lot of what we focus on in those initial interactions is not like, you know, do you have this symptom, how many times? It's more, how is this impacting you, and how does it affect your ability to live a good quality life? And I think that's the more important thing, and that's why being open-ended is really helpful.
Right. And for patients to understand that maybe starting with that in the beginning, I'm here because this is what I'm worried about. This is what's impacting my life. And then moving into the question. That's fantastic. And definitely great advice for all those people watching at home. So what about daily diaries? So you hear a lot about that. Is that helpful? Not helpful?
I think it's very helpful for a patient to understand what symptoms they have, and what makes it better and what makes it worse. And sometimes it's hard to remember like what you ate 2 days ago, you know?
I don't think I could.
So it's helpful for them to do it real time. But to always include the most bothersome symptoms, the severity, and what factors potentially could trigger them. So when you're looking for flares, you know, you want to see what started their symptoms for the first time, or what triggers their flares. I think it's important. I do think, though, that it's good to do it for maybe a set period of time, maybe 2 to 3 weeks, to get a good assessment. And depends how frequent their symptoms are, and if they're going to start a new intervention. I don't think it's probably great to do it all the time, because then it gets you a little too focused on the symptoms. But it's helpful. It can be helpful for different reasons.
That makes sense.
Yeah, I mean, we use diaries a lot in the esophagus because most symptoms are triggered with food, and we always try to find those triggers. But I agree, we don't want that to become the sole focus of your life and have you keyed in on that, because that then becomes something that propagates hypervigilance and can make you worse. So we really try to be a little bit more lenient and for short periods of time directed. Okay, we've changed this intervention. Let's see how it works. Okay, it's better than before, but certainly not something that we want you to do every day the rest of your life.
But you know, I think it's important about daily diaries for patients is that they should look at the diary and they should look at the associations and the fluctuation and the triggers. So I usually say to them, well, when you looked at it, what did you learn from that? Because this is all about empowering the patient for self-care.
Right.
You know, not for them to say, well, you're the doctor, you should look at it and tell me. I will tell them, but I want them to look at it too, so they learn how to manage their symptoms. And I think that's really important.
Absolutely. That's part of advocating for yourself.
Yeah.
And really learning how to do that. So, so what I'm hearing is 2 to 3 weeks. Probably good to do it right before your next doctor's appointment so that you can come in fresh with this is what's been happening for the last few weeks. And then, you know, moving from there. Fantastic. Thank you so much. And so what we want to do is move ahead now to our keynote lecture. And Lynn, I'm going to let you introduce our next speaker because I know that he is as special to you as he is to me. Someone that I've worked with for many, many years, but someone that I know that you work very closely with as well. So
yeah, he's terrible. No. I think Doug Drossman is one of the most special people in this world. And I really think that functional GI disorders are on the map because of him. Many years ago, a lot of people didn't even believe these conditions existed, but he is a emeritus professor of medicine at UNC. He also has his own center, Drossman Care Center. I don't know if I got the name completely right. He's also was the president of the Rome Foundation, which is a really important academic organization that helps to validate, do research, and education for these group of disorders called functional GI disorders or disorders of gut-brain interaction. But he really is, I think, the father of functional GI disorders. And I think he's the only person that could actually give this talk on the history of functional GI motility disorders.
And he is also a longtime friend of IFFGD, having been one of the early on board members, serving on the IFFGD board for over 20 years. And so very special to the organization. And we're really thrilled to have him do this keynote lecture for us today. And I hope you enjoy it.
Hello, my name is Doug Drossman, and I'm really pleased to be able to give this keynote presentation on the history of these disorders and the history of IFFGD. This is pretty important to me since I've been around a while, since the beginning of IFFGD, and maybe the beginning of a lot of the more modern aspects of the functional GI disorders, going back about 40 years. So I'm at University of North Carolina and Rome Foundation, and I have my own practice. And let me begin by telling you about the history. It was Josh Billings who said in the 1800s, a good set of bowels is worth more to a man than any quantity of brains. Now, to begin this history, I think we have to understand historically the way the concepts of illness and disease have modulated over time. We talk about illness as the person's perception of ill health, the way they feel. We talk about disease as objective measurement or evidence like endoscopy or X-ray. And the way people see illness and disease depends on belief systems or what we call explanatory or folk models of the time. And as science moves on, it reinforces certain concepts and eliminates others. For example, the concepts of psychogenesis, that psychiatric factors cause these GI disorders, or biomedical reductionism or mind-body dualism, has been replaced by a more integrated biopsychosocial model. So in Western civilization, there was an interaction between the mind, mind and body relating to two competing concepts. Holism was the concept that unifies mind and body, and dualism separates mind and body. It was over over 2,000 years ago when Plato and later Aristotle and Hippocrates said the greatest mistake in the treatment of disease is that there are physicians for the body and physicians for the soul, but the two cannot be separated. That concept in Western civilization was critical, and then it evolved over the next few centuries, hundreds of years, to a point where dualism came into place, and this was in the 1637 by Rene Descartes. Now, up until this point, the body couldn't be examined as related to medicine because the spirit was thought to reside in the body. There was holism. And so medicine was really based on symptoms, examination of urine and the like. But when Rene Descartes separated the machine-like body, res extensa, with the thinking mind, res cogitans, the mind was lifted out of the body, the spirit and the mind was lifted and was now separate from the body, so the body could be dissected. And what that led to was more than 300 years of science relating to morphologic examination of the human body, pathology, histopathology, X-ray, endoscopy, and the like. But back then, when people had symptoms that couldn't be explained by morphology, they were stigmatized. They were thought to be possessed. And later, they were thought to be insane. And these patients who had behavioral abnormalities or unexplained symptoms went into the insane asylums. And in fact, science wasn't even allowed at that time, actually until about the 20th century when the mental health was added to the curriculum in medical schools from the ideas of Benjamin Rush. Now, it was 10 years ago that when I gave a keynote at the IFFGD meeting, that I said the concept of separation of mind and body is dominant and pervasive in Western thinking, and this has had negative effects on research, patient care, and the patient-physician relationship. What I mean by that is when we think about these disorders, we often in medicine separate disease, which is the verifiable or organic aspects, the machine-like body, from the patient's perception of ill health or the illness. Now, from a hierarchical standpoint, this is what's considered legitimate, and this is always under question. You can't validate the patient's experience of illness, only the objective measures. And that's led to these functional GI disorders, which don't have structural bases, as be considered second class. Now, the fact is that we learn in medical school to diagnose disease, but patients come to us with illness, as shown here. And in this study by Kurt Kroenke in 1989, when you look at the top 10 symptoms brought to a primary care clinic, an organic condition was found in only about 10% of the patients coming. So while we want to diagnose disease, we're often working with illness. And if we create a grid of the degree of disease and the degree of illness, as shown here, you can see that when you have illness and disease, you have what's called rightful suffering, COPD, cancer, and the like. When you have the absence of both, you have health. But when you have illness in the absence of verifiable disease, you're often considered to be psychosomatic or functional. And that's where these disorders tend to be. George Engel, one of my mentors, was an internist and psychoanalyst. And in 1977, in his seminal publication in Science, identified the concept of the biopsychosocial model, which was really an integration of understanding illness and disease from biologic, psychosocial, and biologic and psychosocial parameters, and we'll talk about that later. Going back a few hundred years, we have to see how GI physiology emerged, because GI physiology underpins a lot of our understanding of these disorders. 1,000 years ago, Moses Maimonides said man should strive to have his intestines relaxed all the days of his life. So even then, they recognized that abnormally functioning intestines create problems. Now, if we go back to 1822, William Beaumont, who was a general in the army, studied a soldier named Alexis St. Martin. He was shot in battle and developed a gastric fistula. And he did experiments on this and noted that milk coagulated when he took it out of the stomach. And he also noted that the stomach was churning. And this led to the understanding of acid secretion and of digestion. A little bit later, Walter Cannon studied cats and looked at the effect of stress. And he found that when cats were stressed by a growling dog, and they were seen on X-ray doing a barium study, they had reduced intestinal motility. So fear and stress led to reduced motility. Later came Ivan Pavlov, who, as you know, taught about the conditioned response. And one of the conditioned responses was secretion when seeing food. And Pavlov learned that if he cut the vagus nerve, he abolished the gastric acid secretion. And this was the cephalic phase of acid secretion, again, showing how the brain could be affecting GI function. Moving up to the 1940s, Stuart Wolf, shown here, and his patient Tom in the background, was studying physiologic experiments on Tom, who at age 9 burned his esophagus with clam chowder, and the surgeons at New York Hospital performed one of the first gastrostomies. So Tom fed himself for the next 65 years of his life. And Wolf noted the way the stomach mucosa looked under stress. Overwhelming stressful situations leading to symptoms of fear led to pallor and reduced motility in the stomach, similar to Cannon's experiment. But challenging situations that made the patient frustrated or angry led to reddening and increased secretion and increased motility, similar to when anticipating food. Next came Hans Sallier, who studied the effects of stress on the body, called the general adaptation syndrome. And he found that stress, in addition to producing adrenal enlargement, caused gastric erosions. Tom Almy, one of my mentors in the 70s, was a gastroenterologist who did studies on human subjects, and he looked at the effects of stress on colonic motility. One of the studies was done with medical students, perhaps before IRB and permissions, but he did an experiment with medical students where he was doing a sigmoidoscopy with the medical student in the knee chest position, and he implied to the student that there was a cancer present in the sigmoid colon, and he looked at the contractile state of the bowel, and you can see it went up. He even faked taking a biopsy of the colon by putting a piece of potato in a jar of formalin and showed it to the student, and the contractility went up until the hoax was explained. George Engel again did some work with the effects of emotion and physiologic expression in personality development. And this was Monica, who was studied. She had an esophageal fistula and was tube fed. And he studied her into her 40s doing videotapes and interviews. And one of the things he found was that the way she held her grandchild was not cuddling the child, but holding the child out. And then he had videos of her when she had her baby, her first child, doing the same thing. And then at age 6, when holding a doll, held it out. And when he asked her why she did that, she said it just didn't feel natural to hold it close. And he went back to show how this young lady, as a baby, was not held or cuddled, but was tube fed from a distance. Again, showing how early factors can affect development. Bill Whitehead, a collaborator of mine and a good friend, promoted around 1990 the concept of visceral hypersensitivity, along with other investigators such as Joel Richter in the esophagus and others. And his promoting of visceral hypersensitivity began to move us away from motility being the full explanation for these disorders. Here's one of his studies in 1990 showing that when you do rectal distension, you can get an increase in pain reporting in normals, but a greater response in IBS. And this was after adjusting for motility. It was again established that stimulus can increase motility in IBS, leading to greater response. So we had two factors: increased motor reactivity and increased sensitivity of the bowel in response to various stressors. So we've taken you through the physiology. Let's talk about the concept of looking at symptoms, not in terms of specific symptoms of diarrhea and constipation, but as syndromes, that is, entities like IBS. That meant developing symptom clusters that categorize clinical entities. Now, one of the earliest descriptions of a syndromic entity was Richard Powell's report of 4 women with occasional pain in the intestines and derangement of their powers of digestions with flatulence and a sense of suffocation. Maybe a better description was a Cumming, who reported that the bowels are at one time constipated, at another time lax in the same person. How the disease has two such different symptoms, I do not profess to explain. Back in 1962 was the first compilation or studies of a group of patients that he called irritable colon syndrome. There are 130 cases, and what was unique about this case series was it was the first description of subcategorization of diarrhea predominant and constipation predominant. And he also identified that about 23% of the patients began their IBS or irritable colon with a dysentery or an infection. So here's the first reported case of post-infection IBS. Now into the 80s, pharmaceutical companies were looking to do treatment trials. The FDA was looking for ways to make a diagnosis, but there was no way in the early 80s. It was done by exclusion. In fact, Ken Klein had done some work at the time to show that there was not one consistent way to identify a patient for clinical trials. You'd have an IBS study with someone with diarrhea, someone with constipation, someone with pain and no bowel movement. So there was no ability, and so diagnosis was made by an exclusion, which meant it was not cost effective. There was no limit to the number of studies you could do. In the late 80s, Aldo Torsoli, who was the professor in gastroenterology at the University of Rome, became president of the International Congress of Gastroenterology in Rome. And he came up with the idea of setting up working teams which bring together consensus documents by experts from around the world using what's called the Delphi approach, where individuals would work together to come to consensus. And the first one to be done for the GI disorders was for IBS, and that was to develop diagnostic criteria by consensus. And that was through the Delphi method. Now, the other thing that advanced our work was that of looking at certain academic and educational societies. The first came out in 1979. Around the 1990 came IFFGD, and I'll say more about this later. But to encapsulate it, Nancy Norton, who was a patient and a patient advocate, had a mission to develop a patient-focused nonprofit organization. She worked hand in hand with Bill Norton, who was the secretary treasurer. And originally, this was the International Foundation for Bowel Disorders, focusing on bowel problems and fecal incontinence. And then Nancy was looking to make a difference to reduce the stigma seen with these patients to educate physicians and to be a resource for patients. But she became engaged with the FBG and later on with other organizations, and came to meetings and collaborated. This became the International Foundation for Functional GI Disorders to cover a broader spectrum in '96. And then the International Foundation for Gastrointestinal Disorders in 2018 to cover non-functional GI disorders, such as GERD, gastroparesis, and the like. And so they expanded, they did professional meetings, patient educational material, more about that later. And their mission was to inform, assist, and support people affected by GI disorders. Nancy retired about 2 to 3 years ago, and we welcomed Ceciel Rooker, who was actually the executive director of the Rome Foundation, working very closely with me to helping build the organization. And then she left our organization, became the executive director of IFFGD in 2017, president in 2018, and the rest is history with the accomplishments she is doing now. This was an organization, as we said, that began with Nancy and Bill. I remember in 1992, Grant Thompson and I were at DDW, and we went to the exhibitor area and saw Nancy and Bill behind this table, the International Foundation. We said, "Who are you?" And we had a wonderful discussion, and we brought them to the first FBG meeting, and the rest after that was the growth of their organization. And this was done very methodically. And let me take you through the years. They were founded in '91. The first thing they wanted to do was to have a call center to answer patient questions. They produced a magazine. They began their collaborations with other organizations. In 1995, they produced the first of 10 biennial international symposia that brought in 400 to 600 people, very remembered by all of us who were there. It was a networking program. It brought in clinicians, students, scientists, pharmaceutical industry, regulatory agencies, and the like. Very meaningful. And actually, this symposium is very similar to that. They changed their name in 1996. They developed slide sets and guidebooks. In 1997, they developed their website. The website opened up for IBS, constipation, gastroparesis. They began IBS Awareness Month through Congress. They developed educational videos. They then designated GERD Awareness Week. The first public service announcement was shown on television. All of this was instituted by Nancy and Bill. They began to work more with GERD. They then began NIH-sponsored programs on fecal and urinary incontinence, which continued to the present time. By 2002, Nancy was testifying at the House Appropriations Committee to increase NIH funding, and it continued every year after. They published a very large and meaningful survey called IBS in the Real World, which had impact on FDA and Congress. They began the first research awards in 2003, which have continued. They developed a consensus conference. They submitted written testimony to the US and Senate appropriations for funding. Another survey was done. They began to go to the media by creating a reporter's guide. They drafted and proposed the Functional GI and Motility Disorders Research Enhancement Act and put this bill into Congress, and that's been promoted every year since. As we see here, introduced in 2013. They then began Advocacy Day, where they brought scientists and clinicians to Washington to go door to door to the Congress and to speak on these disorders. And then they started a research program of giving awards. And then in 2014, Nancy received the Lifetime Service Achievement Award by the Digestive Disease National Coalition. In 2015, more about the Research Enhancement Act. They gave more testimony. They set up Gastroparesis Awareness Month. Then they report the Reporter's Guide. In 2017, Nancy retired as president and Ceciel came on. And things have continued. The advisory committee, the Latin ambassador program, an educational series, and an advocacy connection newsletter. Since I was on the board until about 2 years ago, I decided to contact my former board associates and ask them to say a few words. Nancy Norton founded IFFGD with a dedication to people often suffering alone who needed clear and accurate information about GI health. She and Bill devoted their lives to growing an organization of integrity, advocacy, broad reach, unlike any other that continues to assist people around the world. Michael Cohen talked about how she developed the organization from a grassroots operation from her home to an international known organization. Nancy Hartman talked how she possessed the highest degree of integrity of any business leader, and they were specifically recognized and lauded by industry for consistently maintaining complete absence of bias. Jeanette Trees talked from their personal experience in coping with life-altering GI disorders. They channeled their isolation, frustration, and pain into a quest to find solutions, inform, and give support. So Nancy and Bill, I want to thank you for all you have done to advance education and legitimize the field for our patients.
Hello and welcome back to the Nancy and Bill Norton Patient Education Series 30th anniversary event. You just heard from Dr. Doug Drossman, who is a professor emeritus at UNC and also the president of the Drossman Care Center in Chapel Hill, North Carolina. Also a longtime friend of myself and someone who has been a great influence in my life. And we're very pleased to have him speak this afternoon on the history of functional GI disorders and IFFGD. And you know, before we move to the next session, I know both of you have been involved with IFFGD for a very, very long time, longer than I have. And did anything over the last 30 years that you maybe stuck out or things you want to share?
Well, I just really want to commend Nancy and Bill for all the dedication that they've given to IFFGD and all the patients with these conditions. And I know that it started with a lot of the experience that Nancy had as a patient and applied it. And one of my first talks as a faculty member really in this field was giving it at IFFGD. But I actually learned a lot about what the patient experiences through Nancy. I mean, one of the things that that I remember is that a lot of times people think that a lot of the patients have anxiety, general anxiety, but I think it's very normal and protective to have anticipatory anxiety because of the unpredictability of the symptoms. And what she said, it would be actually abnormal not to have that. And so all of us think it's abnormal to have it, but it would be abnormal not to have it. So I think I learned that, and also learning that there are some events that happen in life, whether you have surgery, and that could really trigger your symptoms for a prolonged period of time. So I think a lot of what she has taught me is just the patient's experience, you know, that you don't really always appreciate when you're talking to them.
Absolutely. Nancy and Bill are very special to me and strong mentors in my life, and just the impact that they have made in the field with the patient perspective, the work that they did on Washington, and of course the meeting. And John, you were sharing a little bit earlier with us before about your thoughts on the meeting, and wanted to hear your thoughts.
Yeah, I guess for personal perspective of things, as someone who focused primarily as a physiologist and motility person, I was in this world of just thinking about plumbing and anatomy and stuff. And really, this organization opened my eyes to the fact that I was probably only focusing on half of the patient, or maybe even less, if we really count this, and really getting that exposure. And I remember the first time I was asked to give a talk, it was on Globus. And, Globus was actually something I wasn't all that interested in my practice, but when I was asked to look at that and learn about it, and then come and give that talk and be exposed to that meeting, it really changed. It was a pivot point for me, thinking about more of this brain interaction and how the GI nervous system is interacting with the plumbing and anatomy that I've been studying all these years. And it had a profound effect. And I think that's something that this organization did. It complemented a lot of the other societies that maybe weren't focused on this aspect of the patient. And that's something I'm definitely excited about being part of this today and sharing that experience.
I mean, Nancy and Bill also did a lot of work talking to the NIH
Yes.
for
Mhm.
increasing research funding, went to Capitol Hill and
Mhm.
lobbied a lot for these conditions. But I do remember the meeting, the IFFGD meeting, where everybody would travel internationally. Okay, so people traveled all the way to Wisconsin for this
Yeah.
meeting. And everybody who was anybody, as we said, or anybody who was interested went to this meeting. And a lot of it was just to see our colleagues and share information. But I think a lot of it was a tribute to Nancy and Bill. People wanted to do it for them too.
Mhm.
But so much great information was there. So I remember these meetings very fondly.
Yes, absolutely.
Yeah.
One of the things that I've heard over and over again from so many people in the field is how much they miss the networking
Yeah.
and the opportunities to be with their peers in this very, very select GI subgroup, right? And there's not a lot of people studying functional GI motility disorders. And so to have this meeting, it was always very special. And it was something that was a great legacy to IFFGD and to from the Nancy and Bill Norton. So that was fantastic. So we hope you enjoyed learning a little bit about the history of functional GI motility disorders and also IFFGD. And please, if you would like to learn more, look at our website. We have a lot of great information about all the work that was done by the Nortons and by the organization through the last 30 years. Our very last session of the day is going to be another physician-patient perspective video series. And this will have 3 videos in it. And John, do you want to?
Yeah, sure. So section 5 is bacteria in the GI tract, and we're going to focus on SIBO and H. pylori. And we're fortunate to have Bill Chey, who many of you have already been introduced to this afternoon and morning. Bill is obviously an expert on H. pylori and is going to share some new updates on H. pylori, and I think that's going to be an excellent session. We're going to move on to Dr. Darren Brenner, who is also one of my colleagues at Northwestern, one of my faculty, who's going to focus on small intestinal bacterial overgrowth. He's an expert in this, runs our motility lab at Northwestern, and is really well known for his work in breath testing in terms of SIBO. And as Ceciel mentioned, we're going to finish this off with a patient perspective, and our patient will be Tina Aswani Prakash. And she's going to be talking about how she's been living with SIBO since 2015, and also talk a little bit about some of the stuff that she's gone through in her childhood. So really, once again, keeping with the model of the patient with the physician, looking forward to this session.
Absolutely. And we hope you enjoy it.
Good picture, Bill.
Hello, everyone. My name is William Chey, and I'm a professor of medicine and nutrition sciences at Michigan Medicine in Ann Arbor, Michigan. I'm so pleased to join you today to talk about Helicobacter pylori infection. Before I start the talk, I want to thank the IFFGD for involving me in the Norton Education Series. I'm so excited to participate and to tell you about this very interesting story of H. pylori. As we start the discussion about Helicobacter pylori, we have to go back a number of decades to discuss the timeline, the history of peptic ulcer disease. Remember that ulcers are these punched out abnormal areas in the stomach and first part of the small intestine called the duodenum that can lead to significant bleeding or even rupture of the wall of the stomach or duodenum. It's what we call perforation. And for years and years, decades, and for decades, in fact, the dictum for the cause of peptic ulcer disease was no acid, no ulcer. In other words, doctors and scientists felt that ulcers were resulted from excess production of acid in the stomach. And so, not surprisingly, the attention in terms of development of treatments were all aimed at trying to figure out a way to neutralize or reduce acid production in the stomach. In fact, the earliest treatments involved the ingestion of dairy products like milk or the ingestion of eggs, so-called sippy diet, that was thought to neutralize acid in the stomach. This led to the development of something called the doll's milk drip, where a tube was actually placed into the stomach and milk was dripped into the stomach in the hopes of neutralizing stomach acid and in that way helping with ulcers. Just before the turn of the 20th century, surgeons began to do operations where they actually would resect the part of the stomach that was responsible for producing acid. And then in 1943, surgeons figured out that they could actually cut a nerve leading to the stomach called the vagus nerve, which is responsible for stimulating the cells in the stomach that produce gastric acid secretion. So by cutting this nerve, they could actually lead to a reduction in acid secretion. And then putting two and two together, surgeons figured out that they could actually resect part of the stomach and cut the vagus nerve and potently reduce acid secretion. By the 1960s, physicians and scientists had figured out that they could use antacids instead of surgery to neutralize stomach acid, and also medications that were available at that time called anticholinergics, which are medications that inhibit the stimulation of the stomach to produce acid. Now, unfortunately, these therapies didn't work very well, and also they could lead to significant side effects. So anticholinergics led to drowsiness, constipation, a whole host of different side effects, which were quite unpleasant for patients. In the 1970s and 1980s, there was a very important discovery of a class of drugs called the histamine 2 receptor antagonists. These were drugs that actually more potently and for longer periods of time inhibited the production of acid in the stomach. And they were thought to be revolutionary in terms of the treatment of peptic ulcer disease and also conditions like gastroesophageal reflux disease. In fact, these H2 receptor antagonists like cimetidine, which is also known as Tagamet, or ranitidine, also known as Zantac, were some of the first blockbuster drugs. These are drugs that actually accounted for more than $1 billion in sales on an annual basis. Then in 1982, Robin Warren and Barry Marshall turned in a very important scientific report where they suggested that the primary cause of inflammation and ulcers in the stomach and duodenum, so peptic ulcers, the primary cause of peptic ulcers was a bacteria called Helicobacter pylori. Helicobacter pylori is a spiral-shaped bacterium that lives in the mucus overlying the lining of the stomach. Now remember that the stomach, because it produces lots and lots of acid, was for years and years thought to be a sterile environment. In other words, no bacteria were thought to be able to live within the harsh acid environment of the stomach. But this particular organism, Helicobacter pylori, figured out a way to burrow into that mucus gel overlying the lining of the stomach, and in that way protect itself from the very harsh acid environment of the stomach. And the discovery of Helicobacter pylori and its association with development of intense inflammation in the stomach, and eventually, for some individuals, development of peptic ulcer disease, led to a so-called paradigm shift. That is, a complete change in the way that we thought about peptic ulcer disease, from this dictum of no acid, no ulcer, to peptic ulcer disease and gastritis being an infectious disease, not unlike syphilis or strep throat. Now, as you might imagine, the scientists and also industry that had been benefiting or had put forth this idea that ulcers were the consequence of acid, and now a multi-million, multi-billion-dollar industry of producing drugs that suppress acid production in the stomach. There was a lot of resistance to this idea that gastritis and peptic ulcer disease were infectious diseases. And in fact, Barry Marshall and Robin Warren put up with a lot of negative feedback as they tried to put this idea forth that led to this paradigm shift in the way that we think about gastritis and peptic ulcer disease. In fact, when they were eventually borne out to be true, they actually received the Nobel Prize for Medicine in 2005. And I want to share with you this story. When Barry and Robin turned in their original report of a series of patients in which they observed this unexplained bacteria overlying the stomach lining in individuals with this intense inflammation in the stomach, they turned this report into the Gastroenterological Society of Australia, and they received notification in regards to their presentation in the form of this letter, which said, "I regret that your research paper was not accepted for presentation on the program of the annual scientific meeting for the Gastroenterological Associate or Society of Australia to be held in Perth, Australia in 1983. And if you hone in on this next section, the number of abstracts we receive continues to increase. And for this meeting, 67 abstracts were submitted, and we were only able to accept 56. So of the 11 abstracts that were not accepted to this meeting, it turns out that one of them accounted for the Nobel Prize in Medicine in 2005. So something to take away from this, a remarkable story of determination and even stubbornness that led to a paradigm shift that helped us to recognize that in many patients, inflammation in the stomach and peptic ulcer disease is actually an infectious disease. So let's turn our attention now to H. pylori infection. H. pylori turns out to be one of the most prevalent infections worldwide. In fact, more than half of the world's population is infected with this particular bacteria. In the United States, that prevalence is a bit lower, but still, a third of people in the United States are infected with H. pylori infection. If you look at this map which depicts prevalence of H. pylori based on geography, what you notice is that the southern states in general have higher prevalences or a higher rate of H. pylori infection than the northern states. And this is particularly true if you look at the rate of infection amongst African Americans, Latinxes, and Asians, where the infection rate is higher than in American-born Caucasians. In fact, it's been argued that one of the biggest drivers for H. pylori infection in the United States in the coming years will actually be immigrants. Now, there are a number of clinical consequences related to chronic H. pylori infection. I reviewed some of them with you already. The idea that the most common cause of gastritis is H. pylori infection. A very common cause, the most common cause, identifiable cause of peptic ulcer is also H. pylori infection. But very importantly, H. pylori has now been assigned the designation of a class 1 carcinogen by the World Health Organization. So in other words, H. pylori seems to be associated in the pathogenesis or development of gastric cancer. Now, the good news is that only a very small minority of patients develop peptic ulcer disease, probably 10 to 15% at most of individuals with H. pylori infection will go on to develop an ulcer at some point in their life. Most of the time, they won't even know. And an even smaller, infinitesimally smaller percentage of individuals with H. pylori infection will go on to develop gastric cancer. But nonetheless, one of the most common identifiable causes for gastric cancer is H. pylori infection. There are also a number of other diseases which have been associated with H. pylori infection. So patients with unexplained upper abdominal pain or dyspepsia, it turns out that H. pylori infection is a potential cause for those symptoms. Also, individuals who are starting therapy with aspirin, so like if you had a heart attack and you get started on aspirin, or non-steroidal anti-inflammatory medications, so things like Aleve or Motrin, So if you have arthritis or back pain and you're having to use those medications, individuals with H. pylori infection that use aspirin or nonsteroidal medications are more likely to develop an ulcer than individuals who are using those medications without H. pylori infection, or even have H. pylori infection without using the medication. So the presence of the infection and those medications seems to play off one another to actually more than double your risk of developing an ulcer. Also, individuals with unexplained iron deficiency anemia, turns out that H. pylori can cause that or has been associated with iron deficiency anemia. And finally, idiopathic thrombocytopenic purpura, a condition where the platelet count is low for reasons that aren't apparent. H. pylori infection can also cause or has been associated with that condition. There are a range of different diagnostic tests which can identify if a person is infected. So tests that don't require endoscopy and tests that require or can be performed at the time you undergo endoscopy with an endoscope. The tests that don't require endoscopy can utilize blood to identify antibodies to the infection, breath samples to identify metabolic consequences of H. pylori infection, or finally stool testing to look for antigens or proteins that are shed by the bacteria that lives in the stomach. For endoscopy, there are tests that again can identify the metabolic activity associated with the organism. There are special stains that one could use to directly identify H. pylori organisms. And then there's culture, where you actually grow the organism in a petri dish with certain types of media. Now, in general, we're moving away from using blood testing to identify antibodies and really focusing our non-endoscopic tests on either breath tests or stool tests. Those are the most accurate tests. And if you're getting tested for H. pylori infection, the best tests to get, if you're not getting endoscopy, are a breath test or a stool test. If you get a breath test or a stool test, you should make sure that you haven't taken a proton pump inhibitor like omeprazole, lansoprazole, pantoprazole for 1 to 2 weeks before you get tested. You should make sure that you've been off of bismuth or antibiotics for any reason for at least 2 to 4 weeks. Treatment for individuals who are found to be infected consists of 2 to 4 drug regimens. Invariably, these regimens contain a proton pump inhibitor. So again, drugs like omeprazole, lansoprazole, pantoprazole, and then some combination of 1 to 3 antibiotics, usually drugs like amoxicillin, clarithromycin, tetracycline, metronidazole, levofloxacin, or rifabutine. And it's very important, even if your doctor doesn't ask you, if you're getting started on a treatment for H. pylori infection, to avoid antibiotics that you previously received for any reason. So let's say, for the sake of argument, you're diagnosed with H. pylori infection, and back when you were a teenager, you received a number of courses of clarithromycin or azithromycin, so a Z-Pak, for strep throat or sinus infection. You should not receive treatment that contains clarithromycin. You should try to avoid that, because if you have H. pylori infection, it's very likely to be resistant to that antibiotic. In general, treatments last for 14 days. It's very important to make sure that you take all the medication as prescribed for the proper duration of therapy, because here's the thing, your best chance to get rid of this infection is with your first try. If you don't get rid of the infection with the first try, it gets progressively harder and harder to get rid of the infection with subsequent courses of therapy. So being disciplined and taking all the medications for the specified duration of treatment is critically important to making sure that you successfully eradicate this infection. So to summarize, H. pylori infection is one of the most common human infections. In the United States, about 1/3 of Americans are infected with this particular bacteria. H. pylori is an important cause of inflammation in the stomach, also known as gastritis, peptic ulcers, so ulcers in the stomach and first part of the duodenum. It's also been implicated in the development of an increased risk of gastric cancer and unexplained upper GI symptoms, particularly upper mid-abdominal pain. There are blood, breath, stool, and endoscopic tests to identify H. pylori infection. In general, you want to stick to the breath tests, the stool tests, and the endoscopic tests, and stay away from the blood tests. Treatment consists of regimens containing 2 to 4 drugs given for 14 days. And there, by the way, there are a number of highly effective new therapies which have either recently become available or will be becoming available in the next couple of years. Patients treated for H. pylori should undergo a test to make sure that the infection is gone. This should be done no less than 4 weeks after completing a course of therapy. So I hope you've enjoyed this talk. I hope you've learned something about H. pylori infection, about being stubborn and persistent and advocating for yourself. And I hope you enjoy the rest of the Norton Education Series 30th anniversary program. Thank you very much.
My name is Darren Brenner, and I'm an associate professor of medicine and surgery in the Northwestern University Feinberg School of Medicine. I'm honored to be presenting this discussion on intestinal overgrowth on behalf of the International Foundation for GI Disorders 30th Anniversary Patient Symposium. And over the course of the next 10 minutes, I'm going to tell you a little bit about what we know, don't know, and what we think is overblown with respects to intestinal overgrowth. So let's begin by talking about something we thought we knew. And historically, we thought that our bodies were made up of more organisms or bacteria than actually human cells. Although over the course of the past few years, that's become contested. What we certainly know is that the number of organisms in our GI tract increases as you move farther down the system. So if you look in the more proximal GI tract, like the stomach, you're going to find between 100 and 1,000 colony-forming units of organisms per milliliter. But down in the colon, you'll see more than 1 trillion. We also know that the types of bacteria change as we move down the GI tract. In the upper part of the GI tract, we see organisms that are aerobic, meaning that they need oxygen to replicate and survive. Whereas in the more distal GI tract, like the colon, these organisms are anaerobic. They don't need that oxygen, and the oxygen may actually be toxic to them and kill them. One thing we know for sure is that the biological diversity of the GI tract increases as we age. We also know how to define different types of intestinal overgrowth. And many of you are probably familiar with the term SIBO, or small intestinal bacterial overgrowth. And this is defined as increased concentrations of colonic bacteria in the small intestine that cause symptoms. Now let's talk about that for a minute. A key point here is that these are colonic bacteria, because many people are under the misnomer that these are foreign or external bacteria, and that's not what this is. Furthermore, this has to be a symptomatic process. We find people all the time that have evidence of overgrowth in the small intestine that are asymptomatic. More recently, we've also had an increase in our lexicon, and we defined a new population of organisms known as intestinal methanogenic overgrowth. And these are organisms that can be found in the small intestine or the colon, and they are not bacteria. They are archaea. They are single-celled organisms, the most common of which is Methanobrevibacter smithii, that can live in both parts of the intestinal system. And thus, the reason we changed the nomenclature is because if they're in the colon, it's not small intestinal. And again, they're not bacteria. Now, when it comes to SIBO and EMO, we do not know the absolute incidence and prevalence of these disorders, but we do know that the incidence of SIBO increases as we age. We also have identified multiple protective factors against developing SIBO, and these are things that can be secreted by different intestinal organs, like the stomach. The stomach secretes gastric acid, and gastric acid can kill bacteria in that organ, and also the proximal small intestine. The liver and pancreas secrete bile acids and pancreatic enzymes that digest foodstuffs for these organisms so that they can't survive, and also can kill the organisms as well. There is normal small intestinal motility. Things in your GI tract are pushed antegrade or downstream. That's how food gets from our mouth to our anus. And remember what I said about SIBO. These are colonic bacteria that have to move upstream like a salmon swimming upstream to get to where they want to be if they're going to cause us problems. And as long as we have this continued peristalsis, those waves will push these organisms back down towards the colon. There is the ileocecal valve. This acts like a brake or a door between the small intestine and colon, impeding the ability of these bacteria to move upstream. And then there's the immune system. There are multiple antibodies and immune cells that can kill the bacteria if they're in the wrong place at the wrong time. So obviously what this would mean is the likelihood of intestinal overgrowth increases intuitively if we lose one or more of these protective factors. So let's say our gut motility doesn't work, or a patient with diabetes or scleroderma or Parkinson's. Because we do not push as well and force things downstream, we may be at increased risk of developing bacterial overgrowth. Let's say that we reduce our stomach acid, our bile salts, or our pancreatic enzymes because our stomach, liver, or gallbladder aren't working well for a multitude of reasons. This may lead to overgrowth. If we have surgical changes to the anatomy, a lot of patients with Crohn's have to have their ileocecal valve resected, and that increases the likelihood that bacteria can move from the colon to the small intestine. And then there are autoimmune disorders. If patients are taking immunosuppressants or things like HIV/AIDS, where we don't have the immune cells left to fight these organisms. These are just a few of the various reasons why people can develop intestinal overgrowth. We know what the most common symptoms are in these disorders, and the most common symptom overall is bloating, which is the subjective sensation of excess gas within the GI tract. We also see abdominal distension. This is the objective poofing out of the belly, or when you come in and you talk to us and you say, doctor or practitioner, every time I eat, I look 6 to 9 months pregnant. People will also complain of increased production and passage of flatus or gas. We have abdominal pain, nausea, constipation, and diarrhea. And in very severe cases, we can see evidence of malabsorption and maldigestion of carbohydrates, proteins, and fats. We can see losses of vitamins and micronutrients like vitamin B12 because the organisms use B12 as a food source. So they eat it, they take it away from us. We see iron deficiency because these bacteria degrade or break down the absorptive surfaces in our small intestine where we get our iron. And we can see fat-soluble vitamin deficiencies like vitamin A and vitamin D, because if we can't absorb the fats, we can't absorb the vitamins. Now, there are a couple of good ways for looking for small intestinal bacterial overgrowth or intestinal methanogenic overgrowth. And the gold standard you see on the right of this slide. This is aspiration and quantitative culture. We actually take the upper endoscopy or upper endoscope, we push it through your GI tract to the last part of the first part of the small intestine called the duodenum, or the first part of the second part of the small intestine known as the jejunum, and we suck up fluid and we send that fluid for culture. Now, this is cumbersome, it's costly, and it's really only done in a few academic centers because it is very hard to do. You can actually contaminate your sample if you pick up bacteria in the mouth or other parts of the GI tract, which can give you a false positive test, making it seem like you have evidence of small intestinal bacterial overgrowth, but it really isn't there. So what we use a lot of the time, and many of you may have had this test, is what we call breath testing. You take a straw and you blow into a bag or a test tube. Then you drink a sugar solution, usually glucose or lactulose, and you blow into sequential bags or test tubes every 15 minutes for the next 2 hours. And what we can do is we can measure the amount of hydrogen, methane, and hydrogen sulfide that you've blown into these bags. And this is important because human intestinal cells do not produce any of these particular gases. They are produced by bacteria. And that's what helps us determine if you have intestinal overgrowth. Now, hydrogen does not cause symptoms. It is just indicative of small intestinal bacterial overgrowth. Methane, however, has been correlated with a decrease in intestinal motility and thus constipation. And hydrogen sulfide, most recently, has been associated with an acceleration in gut movement and potentially diarrhea. Now, obviously, once your practitioner tells you you have SIBO or EMO, the first thing you're going to do is you're going to go to Dr. Google. And this can be a bad idea because if you type SIBO into the Google search, you'll find that there are almost 6 million results and more than 1.5 million recommendations for diet. There are more than 650 YouTube videos and 322 SIBO books on Amazon. And unfortunately, a lot of these fall into the naturopathic or osteopathic domain. And these people will tell you that you should be taking probiotics, prebiotics, nutricidals, herbicidals. And these really have no evidence to support their efficacy, and they are unvalidated. I'm showing you on the bottom of this screen a website that talks about a group of practitioners who are experts at treating SIBO. And you can see if you want to go through their 2-month program, you can do it for the low price of almost $2,400. If you want the 6-month mega program, it's $5,400. And everything that they're showing they do really has no evidence to support it. Furthermore, if you have a program that's really going to take 6 months, why do you offer a 2-month program? And if the 2-month program works, why do you need 6 months? So what really should we be doing to treat these disorders? Well, I think that we should look at the evidence, and here's the evidence from the American College of Gastroenterology guideline on the diagnosis and treatment of small intestinal bacterial overgrowth. And when it comes to SIBO, you can see on the left a chart of antibiotics and the efficacy of those antibiotics for treating this disorder. My favorite antibiotic is rifaximin because it predominantly stays in the GI tract. 99.6% of this never leaves your GI tract. It is safe and tolerable and has the most data to support its use. On the right side of the screen, you see what we have for EMO, or intestinal methanogenic overgrowth, and it's newer. This is a nice study that comes from my friend Mark Pimentel's lab at Cedars, where they compared neomycin to rifaximin to the combination of the two. And you can see significantly more patients responded to the combination. The problem here is that EMO will most likely recur and you'll have to retreat multiple times. And neomycin is an aminoglycoside, which means that it can cause kidney damage and deafness. So it's dangerous to use it over and over again. As far as the guidelines concerned, they make no recommendations in terms of treating EMO. So if the antibiotics don't work or you have intestinal methanogenic overgrowth and you're worried about using the combination therapy, what can you potentially do? Well, maybe diet. And there are ongoing clinical trials looking at using the low FODMAP diet for both intestinal methanogenic overgrowth and SIBO, although the jury is still out. And the thought process here is that you'll starve the organisms so that they can't survive. There have been studies looking at probiotics. They do not seem to be very effective. And for SIBO, fecal microbial transplants, and in many cases, this has actually been shown to make the symptoms worse. In my lab at Northwestern, we're trying an herbal preparation called Atrantil. This is a couple of over-the-counter herbals that have been purported to either scavenge methane or kill the organisms that induce methane and potentially reduce the symptoms of EMO. And we're almost done enrolling in that trial, and hopefully we'll have data for you soon. So what can I tell you? Let's go back to the beginning. What do we know with respect to intestinal overgrowth? Well, we know that small intestinal bacterial overgrowth develops with a loss of anatomical or functional protective factors. We know that SIBO and EMO are pathogenically distinct. We know that hydrogen correlates with SIBO but doesn't cause symptoms, whereas methane slows down gut motility and causes constipation. Hydrogen sulfide most recently has been correlated to increased movement and diarrhea. We also know that bloating is the most common symptom of these disorders. What's unknown is the best diagnostic strategy. Quantitative culture or breath test, probably the culture if you can get through it appropriately and correctly. With breath tests, there are different substrates. We cannot tell you exactly what the thresholds should be, and there are discrepancies on what constitutes a normal versus an abnormal test. We know as well that the best treatments are antibiotics, but we don't know what to do if the antibiotics fail. And finally, what's overblown are the benefits of naturopathic, behavioral, and dietary cures, which are unsubstantiated at this time by sound and validated data. I'd like to thank you very much for your participation.
Hi, everyone. My name is Tina Aswani Omprakash, and I've been living with small intestinal bacterial overgrowth, otherwise known as SIBO, since 2015. I've had, for a number of years now, a number of digestive ailments. This has really been a family affair for me. You'll see a photo to the right of my father and me. My father was diagnosed with Crohn's disease. He passed away from colorectal cancer when I was 8 years old and when he was 39. He lived with IBS as well, and may have had other functional GI disorders, but the IBD really took prevalence in his case as well as the cancer. For me, was diagnosed with chronic constipation just in the last few years, so IBS-C. But all my life, I can remember having issues with chronic constipation. Since childhood, I used to complain to my mom, who you'll see to the right as well, Mom, like I can't go to the bathroom, and I would have to have laxatives and enemas and all sorts of things just to go to the bathroom. After my father died, we didn't have health insurance, and we really struggled with, making sure that I was getting the pediatric care that I needed. So I wasn't diagnosed with irritable bowel syndrome for many, many years. And honestly, when I finally was diagnosed with a digestive disease, it was inflammatory bowel disease. And that was when I was 22 and finally had health insurance. But even before that, I had all sorts of extraintestinal manifestations of my inflammatory bowel disease. And I had all sorts of IBS, constipation related symptoms, as well as GERD, acid reflux in my teenage years. My own IBD diagnosis trumped any need to explore other functional GI disorders. So the IBS went ignored. Any other issues around constipation and incomplete evacuation went ignored for many years because my Crohn's disease really was the bigger beast, so to speak. I had many, many surgeries over the course of a 7-year period from age 24 to age 31. I had over 20 surgeries, and I was dealing with a lot of psychosocial issues around having the Crohn's, including this being labeled a diet disease, and a lot of the cultural stigmas in the South Asian community around using medication, having surgery, living with an ostomy were sort of the bigger concerns at that time. But what I didn't realize is what a toll functional GI disorders can take during this time. So when did my SIBO diagnosis happen? It happened in 2015. I had come out of surgery, and you'll see to the right, me after surgery at the Mayo Clinic in 2015. I was having one of my last surgeries at the Mayo Clinic where they were correcting a J pouch excision. And my recovery in Minnesota kind of looked like this. It was very, very difficult for me to come out of that state. But that whole year, I was struggling with a lot of issues around constipation. Even with an ostomy, even without a colon or a rectum, I was having trouble going to the bathroom. And that's when my eyes started opening that there could be a real problem here because I was feeling obstructed all the time. So at this point in time, my doctors back in New York suggested, hey, Tina, maybe you want to consider a breath test. Your symptoms sound like SIBO. That's when I was diagnosed finally with IBS-C and finally with SIBO. What were my symptoms? Loss of appetite, abdominal pain, nausea, bloating, a lot of fullness after eating. I couldn't eat that much. And I was gaining this abnormal weight, even though I wasn't eating that much. And it just looked like a lot of bloat. Felt a lot of gas coming up. And this might be TMI, but there was also this sort of rotten egg smell coming from my stools. And that, was all indicative of small intestinal bacterial overgrowth, according to my GI doctor. So how did I manage and treat the SIBO? I think this has gone on for a number of years now. Since 2015, 2016, we've been trying various methods to control this. And at times it's worked quite well. More recently, it's not working out so well. So what I did was initially I changed my diet in 2015 and 16, and it helped me to go to the bathroom, and I really didn't have too many problems doing that diet change with a GI dietitian at my IBD center who monitored consistently, me cutting out certain foods and then reintroducing them when I was feeling better. What happened in the last few years, though, is my SIBO started to become more chronic, more refractory, and I went the herbal antibiotic route because I had used so many traditional antibiotics during my Crohn's disease journey and with all the surgeries that I had had. So I was recommended things like Candibactin AR/BR, Biocidin, things like that would help. And I had also cut out a lot of carbs and sugar to try to prevent the SIBO from flaring up. And I cycled on and off these herbal antibiotics for some time and did quite well. I also started to explore things like pelvic floor physical therapy and acupuncture for constipation. The pelvic floor PT helped with a number of other issues. I have pelvic floor dysfunction on top of that, given the inflammatory bowel disease and all the colorectal surgeries I've had. So pelvic floor PT really helped with a number of different things, but has also been key in helping with the constipation and getting things to move. Acupuncture has been instrumental as a complementary alternative therapy. Electroacupuncture specifically has been very helpful in getting things moving when I feel really stuck. During this time, though, I think it became clear, especially in the last 2-3 years, that there must be some kind of underlying motility disorder for me to have this bad constipation. So I started exploring this in 2018 in New York, wasn't really getting many answers, and finally reached out to my IBD specialist at Mayo Clinic, frustrated, saying, there's something going on with me, you know, the traditional Miralax and other laxatives aren't really cutting it, and I'm having a lot of constipation. He brought me in, he did a whole analysis during this time to understand what was going on with me. I had a gastric emptying study. I had a small bowel manometry done. You can see the photos to the right. And he determined the gastric emptying study was a little bit tricky because what happens is, you know, with an ostomy and without a colon or rectum, there were really no fair values. So it was tricky to do just a gastric emptying study. But with regards to small bowel manometry, they put 15 sensors from my esophagus down into my stomach and small intestine to see the movement that's going on there. And they found antral gastroparesis. So 2 years ago in June 2019, I was diagnosed with that. And that was kind of like, okay, this is what's causing your problems, Tina. But I was still kind of hesitant because I was thinking, you know, that's an upper GI problem. Okay, so I have some nausea. I do have fullness and bloating, but what's going on with my lower GI tract? During this time, I started a lot of meds for off-label medications to treat the chronic constipation, but also to treat the gastroparesis. And things started to move along smoothly. And I just assumed that things were getting better from here on out. About 18 months ago, right before the pandemic, I started having problems again. And I had broken my ankle pretty badly and stopped moving. And as you might know, motility tends to be impacted if you don't exercise or move much. During this time, things got very bad for me. I started to back up consistently. And with the pandemic arriving just a few months after, without much exercise or going many places, my motility was really impacted. Even though I went for walks daily, it didn't matter. Things were starting to get pretty bad again. I was dealing with SIBO the entire spring of 2020. And I was started on a regimen of these herbal antibiotics again, and cycling on and off, and changing them every single time. And I continued sort of the pelvic floor physical therapy and the acupuncture. And I started to get better come last summer and last fall as things were opening up, you know, in New York City. I started to get better. But I found that, you know, after some time, I started to develop refractory SIBO again. It came back in November. Thing is, I was put on prucalopride, I was put on pleconazide, domperidone, all these medications to help me go, but nothing was really quite cutting it. During this time, I started seeing a SIBO specialist in New York City who decided she wanted to do an upper endoscopy with a jejunal aspiration. So she did this in March, and I tested positive, heavily positive for SIBO, but also positive for CFO, which is small intestinal fungal overgrowth. Within a few hours of that upper endoscopy, I had a massive bowel obstruction. She had me hold my meds for a couple of days to sort of see what that growth would be like in my bile. And that's how she found the SIBO-CFO. So this was considered the gold standard in terms of diagnosis, because it gave sort of the understanding of what kind of bacteria, what kind of fungus is growing in the gut, rather than a breath test, which just sort of indicates, okay, there is, methane gas or something like that growing. It's not so much indicative, though, of the strains of bacteria or fungus that might be growing. So she really wanted to do this upper endoscopy, and I'm glad she did, although the bowel obstruction really was very difficult to get over, and it took days and days of medications and magnesium citrate to sort of resolve. Over the last couple of months, what's happened in the spring and now into the summer of 2021, I've been treated with rifaximin, I've been treated with diflucan, I've done a low FODMAP diet. You can see some of these photos of different foods that I was trying at home to cook that are lower FODMAP. I've been doing a lot more smoothies and low FODMAP fruits, low FODMAP vegetables. I am vegetarian. I am plant-based for the most part. So trying to work with this with my GI dietitian, I've done 6 weeks of the low FODMAP diet, and I am currently reintroducing foods, but now I'm feeling SIBO flaring again. So this is becoming one of those recurrent problems with me. And just last week, I was diagnosed with another motility problem called chronic intestinal pseudo-obstruction, which I believe is known as SIPO or CIP, CIP. And how did they come to this diagnosis? So between the upper endoscopy and I also underwent an ileoscopy in May of 2021 by my surgeon through my terminal ileum, since I have no colon or rectum. He scoped my small intestine to, of course, look for Crohn's disease, but also to see if there was any mechanical source of obstruction that might be causing my the backups and the constipation and the SIBO. He said, Tina, I can assure you I've gone up 80 centimeters into your small bowel. There is no reason for me to believe that this is a mechanical issue. So once I found that out, we realized, okay, Tina's got a major small bowel transit issue. I am waiting to undergo further testing, but by a process of elimination, I've been diagnosed by 2 Mayo Clinic physicians who have said, this sounds and looks very much and presents like chronic intestinal pseudo-obstruction. So where am I right now? Right now, I have started pyridostigmine just in the last few days to see how I do. And I'm waiting to figure out how to deal with the SIBO. I am in the process of taking appointments with Cedars-Sinai to get to the bottom of this issue. As I understand, they have some of the world's best SIBO experts. I'm also awaiting further testing in New York City this summer. I've also been told that I may need some kind of chronic low-dose antibiotic to manage the SIBO, chronically speaking. But, I'm not going to lie when I say that this hasn't been taking a toll on me. Emotionally and physically, as we are starting to come out of the pandemic, I'm just wondering how I'm going to manage this. My lifestyle throughout the pandemic and even before that has been every hour or two taking something to help me go. What's tricky and complicated about my case is that I have an ileostomy, I have Crohn's disease, I have all these other functional GI disorders. So trying to parse these out and figure out what's causing what symptom, but also trying to sort of deal with the fact that my ostomy is getting obstructed, the site is getting obstructed without there being any real source of obstruction, that's constantly causing the SIBO to flare up. That's constantly causing the bacteria to ferment because there are these obstructions going on due to the compromised nature of my bowels. So that's kind of where I am today. But I am going to say, just like I've been very persistent with my Crohn's disease, getting it resolved, going to the Mayo Clinic, undergoing the surgeries, joining a clinical trial to get this Crohn's disease better controlled, and I'm fortunate enough to be in remission now, I'm going to figure this out. I realize how heavy of a toll this has taken, but I also realize that I'm very persistent and that I will learn what I need to learn about SIBO and about all these functional GI disorders so that I can manage my care in the best way possible. Thank you so much.
Hi, and welcome back. I hope you enjoyed that final session of the day on H. pylori and SIBO, bacteria in the GI tract. I know those were some great talks from Bill Chey and Darren Brenner, and we did get some questions from the audience in our chat from those. So Lynn, I'm just going to start firing away if that's okay with you. All of you, we have introduced it, but if you're new to joining with us, this is Lin Chang from UCLA. And so we've got a lot of questions from different places. So one of the things that came up, and this is kind of piggybacking off of your talk on IBS. So there are a lot of similarities between IBS and SIBO. People have been diagnosed with one and then the other. How can you better explain why are they so similar, and what sort of makes the differentiation between the two?
That SIBO is a complicated topic because there really isn't which stands for small intestinal bacterial overgrowth. There is actually no gold standard test. So there's some discussion and debate whether the way it's diagnosed, which is typically by a breath test, whether it's glucose or lactulose, if that's really representing true SIBO. Because the breath test can also be positive in healthy people, and it also is a measure of transit time. So the faster transit, it could be more of a positive test. But there are patients with true SIBO where typically they've always found it associated with some slower motility of the small bowel, or you know how you talked about diverticula of the colon, but people can have it in the small bowel as well, or partial stomach resection. So certain people are predisposed and they'll have symptoms that mimic IBS, the bloating, abdominal discomfort, abdominal pain, loose stools. But in some IBS patients, they have who have those symptoms, they can have a positive breath test. And the question is whether or not SIBO is the explanation for their symptoms. And if you treat it, will their symptoms completely go away? And even people with chronic intestinal pseudoobstruction, which Tina was diagnosed with, that's treated with cyclical antibiotics, meaning that for like a week per month, they'll treat with antibiotics because the underlying condition doesn't change. So the small intestinal bacterial overgrowth will recur. That's separate than IBS, where you don't really have chronic intestinal pseudoobstruction per se. So the symptoms mimic each other, but the question is SIBO the real cause of the IBS-like symptoms?
So very convoluted and something that you have to talk to your healthcare provider about to make sure you're getting the right diagnosis, which definitely differentiates the treatment between the two of those.
Right. Yeah.
So what sort of testing? So Darren talked about EMO, right? So the intestinal methane overgrowth, which is a new topic and sort of something that's breaking news right now in this field. And so what type of differentiations between SIBO and EMO should we be thinking about, and as patients may be asking about with their healthcare providers?
So when bacteria break down the food products in the gut, it causes the development or creation of gas, which is hydrogen or methane. Those are the two main ones. And we see more of hydrogen methane. But a standard, like for example, lactulose breath test can measure both hydrogen and methane. In patients that have more methane, greater production of methane, that has been seen to be more associated with patients with constipation. And different centers have found that rather than just the classic hydrogen. But there are some patients that you don't detect really increased amount of gas. And so another gas that's actually people are starting to do research on is hydrogen sulfide.
Oh,
Yeah, so that's going to be a new one that we'll find out more about. But for the methane producers, it's more characteristic in chronic constipation or IBS with constipation. However, there have not been great randomized controlled trials on how you treat that,
okay.
like we have for IBS with diarrhea with the positive test.
Okay. So I know that tomorrow we're going to really get into treatments and we're going to really talk about that. But we did have a question from the audience about rifaximin. And rifaximin is a very common medication that is prescribed for people with SIBO. And the question that we have is that how often can someone take rifaximin? And is there a danger of taking it too often or too many times?
Yeah, I think the one really important clarification is that rifaximin is only FDA approved for IBS with diarrhea. It's
Okay.
not actually approved for SIBO.
Got it.
Now, people may use it for a positive breath test, but the physician actually has to link the correct indication of rifaximin with IBS with diarrhea, and that's where all the data is.
Okay.
For the FDA approved indication of IBS with diarrhea, you can use it up to 3 times because this is based on a rifaximin retreatment trial. And they don't tell you in what period of time that you do the treatment, but it's been shown that you can treat up to or approved up to 3 times. Now, if somebody has a positive lactulose hydrogen breath test, that enriches and increases the chance that a patient with IBS with diarrhea will respond to rifaximin, about 69%. Overall, if you have IBS with diarrhea, you respond to rifaximin positively in 40% of the patient population in clinical trials, in large clinical trials. If you have a positive breath test, then there's about 69% that will respond to rifaximin. So you increase the chance. If you have a negative breath test, it's about 26%. So that helps guide you on whether, now this is based on 93 patients, so it's not a large group of patients. Now, people also don't know exactly how rifaximin works. It's presumed it's reducing the bacterial load and you're treating SIBO, but we don't know if that's true. It also has anti-inflammatory properties. It could have effects in the colon. So you just want to make sure we're clear on the data of rifaximin in IBS diarrhea. It's not in SIBO per se.
Got it.
So I think that's important for people to know.
Absolutely. Absolutely. I actually wasn't aware of that. So thank you for clarifying that. And so to answer the question about how many often can you take it? It's not really an often. The FDA has approved it for 3 times maximum in a patient. So great information. Thank you so much. And then also Tina mentions CFO. So that's the fungal overgrowth. Can you tell us a little bit about what that is? And there's a lot of overgrowth things that we're talking about here today. So can you talk a little about that?
Yeah, so as I said, that people have done lactulose or glucose hydrogen breath testing for positive diagnosis, presumably due to SIBO. But the other way of detecting it is actually due to an endoscopy, or where you can take a tube and aspirate fluid in the small intestine, the upper part of the small intestine, and you culture it and you see how much bacteria. And there's a certain criteria that they use for small intestinal bacterial overgrowth. But now you can actually test it for fungus as well. Same aspiration in the small intestine, collect the fluid. And so there is not as much data on this, but there is some data, not nearly as much as for SIBO, that you maybe find a fungal organisms like, say, Candida, and that it could also explain these IBS-like symptoms. There hasn't been enough data to know that if a patient has that and you treat them with the antifungal medication, will they get better? I think there's some evidence, but not really in randomized controlled trials as I know of. But also just even a positive duodenal aspirate for SIBO or the CFO, age, if you're on a proton pump inhibitor, if you have slower motility, that all can also cause a positive test. So I think that the patient and the healthcare provider should take that information and think about the factors that can affect a positive test as well. So that's something that we'll probably get more information, hopefully, also antibiotic use.
Right.
That would affect it as well.
So, just to clarify, would these types of fungus or fungal organisms, will they be naturally found in the digestive system? Or is this
Yes.
something to be alarmed if your healthcare provider tells you you have SIFO?
Yeah, see, this is always the interesting part, is whether or not a organism that we naturally have, like Canada, we naturally have that, if that's really causing the symptoms, if it's allowed to grow more. Because if you're on antibiotics, you're going to suppress the bacteria and you're going to more allow the Candida to grow. That's the same as C. difficile colitis.
Right.
We have C. difficile, but if you're on antibiotics, it allows that to grow and take over and cause colitis. H. pylori is an organism that, we talked about, that we also have in our stomachs. And in many people, it causes no symptoms. So you don't really need to treat it per se. But in certain individuals with a certain number of factors that come together, it causes symptoms. And if you treat it, they can get better. So that's something that we all have to think about is this a consequence? Is it really explaining the symptoms? And you have to take a lot of factors in mind when you're approaching a patient with this.
Absolutely. And so talking about H. pylori, so understanding from Bill's presentation that originally those were considered like stomach ulcers, right? So that was sort of the peptic ulcer disease, and that was the sort of the early understanding of H. pylori. And I understand that, with the ulcers left untreated, sometimes they can bleed. And then you can have a really big problem in your stomach. What sort of symptoms should patients be thinking about? So some people have H. pylori and they think they have GERD, or they're being treated for something else. What are some things that would say, you know what, I probably should go to my doctor and find out about this before it becomes something that like a GI bleed?
So H. pylori is associated with ulcers, but ulcers are also associated with medications like ibuprofen, aspirin. So when you see someone with ulcers where they have pain, and it could be, when they haven't been eating, and food could actually relieve it. And they could have bleeding, and sometimes they don't have bleeding, but that can be associated with H. pylori, and you have to treat the H. pylori because that reduces the risk of getting recurrent ulcers. But H. pylori is also associated with dyspepsia. And that basically means that, above the belly button in the upper part of the abdomen, the patient has burning discomfort or pain. That's what dyspepsia means. And studies have shown that there's two ways to go about treating it. One is to detect if you have H. pylori, and you can do that by a stool test now, a breath test. You don't have to do an upper endoscopy. And if they have it, you treat it. And if you treat it, there is a small but statistically significant chance the patient will have relief and resolution of the upper gut symptoms. The other pathway is to take a proton pump inhibitor, like omeprazole, pantoprazole. A lot of those are over the counter. And if that heals and resolves their symptoms, they could have had inflammation or an ulcer. You go that way. Then functional dyspepsia, which we're going to talk about tomorrow, is where you have dyspepsia, but you do a procedure like an upper endoscopy and you don't see an ulcer. You don't find anything to explain their symptoms. So we call it functional dyspepsia. And that has also been associated with H. pylori. And so if you detect H. pylori by doing a biopsy, a piece of tissue, you do an endoscopy and find H. pylori, you also treat those patients who have it with functional dyspepsia. But if someone's having really bothersome pain, they're taking those over the counter, omeprazole or famotidine, or they vomit, maybe they're having blood, or they have dark stool, like black color, like your or my hair, then that's a sign they could have bleeding, and they should definitely see a doctor, or they're dizzy or lightheaded. But anything like we said earlier today, really bothersome symptoms, they're not getting better with over-the-counter remedies, or they're just concerned, they should seek healthcare.
Fantastic. Absolutely. And thank you so much, Lynn. I really feel like this is such a big topic right now, and there's just so much to learn. And I just really learned a lot from Bill's talk for sure. So this was our final talk of the day, and we are going to be closing out. And we really hope you enjoyed our programming today, and that you will join us again tomorrow for the second half of the Norton Educational Series 30th anniversary edition. And before we close today, first, I want to make a reminder to everyone that we do have daylight savings time this evening. So make sure that you watch your clocks and get those set back 1 hour so that you can be here with us tomorrow at 9 a.m. Eastern Standard Time. And we look forward to having another day of some excellent programming with Lynn and Bill joining me tomorrow as my onboard hosts. So I appreciate your attendance. I do want to thank all of the speakers who have provided these educational talks. We had such a wonderful, wonderful group of speakers today, and tomorrow more world experts educating us on the different disorders of the digestive system. In the morning, we will start with treatment. So this morning we talked about pathophysiology and the different disorders of the different areas of the digestive tract, from esophagus all the way to the rectum. Tomorrow, we're going to talk about treatment. So that's going to be great for those of you who might be struggling with what to do with your symptoms. And so please be here in the morning, 9 a.m. to do that. Also want to again thank the supporters of this event. Through educational grants from AbbVie, Ironwood, and Takeda, we have been able to construct this program and provide it to you free of charge this weekend, but then keeping those videos on our website ongoing so that you can watch them again later. And we really do appreciate the support that they have given us to be able to create this event. Before we close out this afternoon, I did want to share with you our honor and memorial wall. For those of you who joined us in 2019 for our education and advocacy event in Washington, D.C., you remember the candles and hearts that we filled a wall with. Candles represent all those people who we love, who we've lost, that are in the GI illness community. And hearts represent the people that are still within the GI illness community that we wanted to honor. We, as attendees of the event in 2019, were able to handwrite our hearts, and we taped them to a wall. Because we could not be in person for this event, we did allow people to submit names for those for candles and hearts. And we've created a video to share with you this evening that represents all the hearts and candles for the names that were submitted. So please just take a moment and join us in honoring all of these people.